Yes.
Can you hear me in OT? OT?
Can you hear me in the
Yes, sir, right. We can hear you.
today's page? Yeah. Can we zoom here?
Right, sir. You're audible in the auditorium.
This is a 10-year-old child with the lobular microtia, and the that the head is here, but the location of the ear paramount. We can't change the cranial look, so we take into account the existing hairline and see that we make a ear which doesn't have hair on the upper part. So first we will do some ear measurements on the left. We go you. Are you We'll start with the markings. Is the audio okay in the auditorium?
Yes, sir. Audio is okay in the
Yeah.
auditorium.
So we are
Yes.
starting with the first measurement is to the base of the helical or root of the helix. So I am taking measurement corner of the mouth to the base of the lobule, 9.5. We ask the patient straight beta. The pen देखना. The first point that I mark location. Now you turn. Replicate the measurements of the normal side to the side which has micro, same as the other side. Now let us mark the 7.2 which was for the root of the helix where here. To mark these two measurements. Thing is no turn this way beta. The axis of this. So what you can do is line first. You draw the axis of to the axis which is the perpendicular line. So this is roughly 20 degrees. This is going to be the orientation of our future ear. We create a thing of normal ear. Please let me know if you want to ask anything. I can stop and I can explain. The size of the normal ear. I normally keep the size of this template a millimeter or so smaller than the actual size of the ear to account for the skin thickness.
I think at any stage you can ask questions. That will be better for you. You are open to ask any question to the.
So I've created a tracing of the normal ear, and now we replicate this on the side which has microtia. Turn please, look straight now. So first thing you have to do is decide the axis of the ear. So this is the correct axis. Ear is not like this, ear is like this. And then you just trace out the earring at the correct location. So roughly looking at the size of the normal ear, you can draw the border of the microtic side. So this is going to be roughly the location. Now in the Fermin technique, there are three different variants of the skin incision, and which type of skin incision to use depends on the type of microtia. So in a child with lobular type of microtia, there are two incisions which we can use. One is a type 2, where the lobule is turned back like this and it is transfixed to the postauricular skin. So the lower part has both the surfaces as they are currently, and the upper part will have only one surface, and this will be elevated after 6 months. So that is determined by the size of the lobule. When you draw the tracing of the normal ear on the side which is microtia, if you find that the lobule is big enough to reach that marking, like in her case, up till here the lobule is easily reaching our marking point. So this is a good case for a type 2 incision. So in a type 2 incision, there is a horizontal incision like this, and this will be the level at which the skin will be transfixed. So this part of the lobule will have two surfaces, the anterior and posterior. Are you able to see the posterior surface?
Yes, sir.
So the same incision what we marked on the anterior part continues on the posterior part and then continues on the postauricular skin. So this will be transfixed like this, and of course we will be creating a pocket in the upper part to insert our framework. All this rudimentary cartilage will be removed, of course, and we'll just preserve the skin. Now we also want to insert two drains, so I normally mark the location of the drains also pre-operatively. So these will be the two drains that I would like to insert. So let us see the pattern one more time and see how your ear is going to look at the end of the surgery. So this is roughly how the ear will be located. Any questions about the markings?
Sir, good morning, Dr. Paraktalan. Dr.
Good
Jaindas this side.
Good morning, sir.
So first is there is a debatable issue. What is the ideal age of reconstruction?
So the ideal age of reconstruction is 10 and above. Okay. It is ideally 10 to 15 is the upper limit, but even up to the age of 20, 21 the cartilage is very nice and soft. After the age of 20, 21 then it becomes very calcified and hard. So the ideal age is between 10 to 15.
So is the only 10 age is the parameter, or any other parameter would like to consider if suppose the patient is coming at the age of 10?
By the age of 10, normally the chest circumference is adequately developed, so you don't really need to take measurements of the chest circumference. If you have a child who is younger than 10 years, then of course chest circumference plays an important part. Ideally around 55 to 60 centimeter of chest circumference is what we should have. But by the age of 10, there are two advantages when you operate at that age. One, the opposite ear has completed almost 90-95% of its growth. So the opposite ear is also not going to grow. And plus the child is tall enough, the chest is wide enough for you to be able to get a good kind of cartilage for the carving. So at the age of 10, normally you don't need to take any other measurements like the chest circumference. If it's a younger child, then yes, you also should take into consideration the chest circumference. There are sometimes children who, even though they are 10 years old, they are quite small in size, they don't have adequate height, or there are sometimes syndromic cases where the child is not well developed. In such scenarios, you should take the chest circumference also. and plan the surgery only when the chest circumference is at least 55 to 60 centimeters.
So age and chest circumference are the two parameters we should consider. And
That's
what
correct.
about the pre-operative chest X-ray?
Correct, correct.
Pre-operative chest X-ray.
I don't depend on the pre-operative chest X-ray, but if you have an adult, like you have a 40-year-old or a 50-year-old person coming for ear reconstruction, then I do a CT scan of the chest, which is called as a 3D CT scan, and that basically is to check the ossification of the cartilage.
Sir.
In the Fermin technique, the chest is opened on the same side as the microtia. So if it's a left ear, we are going to take cartilage from the left side. So on the CT scan, if it shows that there is too much ossification on that side, then maybe you can go to the other side if it is less ossified. So a 3D CT scan of the chest is sometimes very helpful.
Yes. Next is how do you address the hair on the that cartilage framework area? Suppose the patient is having hair. So how do you tackle that situation?
Correct. So it is all about how much percentage of the skin is covered by hair bearing area. If the hair bearing skin is only on the uppermost rim, which is the case in 90% of cases, then you can remove those hair follicles when you do the second stage. And if the hair bearing skin is covering more than 50%, then sometimes you need to use a temporal fascia to cover the framework.
Well, Dr. Chaudhary, I am speaking.
Right.
Well, in some school of thoughts, they tell by 7 to 8 years, we can go ahead of the reconstructions.
Yeah.
So the advantages are always there because of the family, they are very much worried. So if you
Correct.
wait up to 10 years, maybe little late for. So most of the Nagata and brands and all that, they also tell that you can start earlier. By 8 years, most of the more than 90% of the ear of the other side has already developed. So I think these are different school of thoughts in taking of the case. I think every case has to be taken its own merit.
Correct. If you operate on a younger child, the problem is that you may not get rib cartilages of very good quality, and the chances of resorption are more, so better to wait till the age of 10.
What are the patients in which you advise the pre-operative laser hair removal before the ear reconstructions? It's mandatory.
If the hair bearing skin is between 10 to 50%, like it's a borderline case where there is not a very wide area which has hair, then you can start the hair laser as soon as the patient meets you in the consultation, so that by the time they come for their first stage, at least 3-4 sessions are finished. If 1 or 2 sessions are remaining, they can do it between the first and the second stage. But once your cartilage framework is in place, then it becomes a little difficult for the hair laser to reach the grooves of the ear. So it is always better to start it when the skin is plain, unoperated.
Anybody wants to have any question till date?
Dr. Parag, one question regarding you told that to discard this remnant of this cartilage which is there. Can it be used for the tragal reconstructions? If you discard this cartilage, this cartilage may be used for the tragal reconstructions.
So in the Fermin technique, sir, we already reconstruct the tragus using costal cartilage. So we don't really need this cartilage, but yes, you can. Why not?
Okay, thank you.
Anybody wants to have any question? Till date, what he has narrated? Anybody? Okay, so everybody has understood nice, you can go ahead.
Thank you, sir. Thank you. ये बंद करें, जस्ट म्यूट करें. हाँ, बाद में.
A very good morning, respected teachers and sirs and all the delegates. We'll start with embryology related to microtia and anatomy of external ear, since we are reconstructing ears by different techniques, the latest technique that is Nagata and Fermin. So it is very important to know the embryology of the ear, and because the classification and then the treatment and follows according to it. We'll start with the embryonic period. The external ear develops from the first and second branchial arcs, that is mandibular and hyoid arc, and it develops from the dorsal side, ectoderm, and we can see here that the pharyngeal pouches and the pharyngeal clefts are there in this image, which is showing the first pharyngeal arch, second pharyngeal arch, third and fourth pharyngeal arch with its nerve arterial supply. And the mesenchyme is forming the cartilage, and we have the ectoderm layer, which is shown in the blue color. This will be forming the external pinna, and the mesenchyme, which is shown in the brown, that will be forming the cartilage. Whenever there is a problem in the formation of chondrogenesis, then we have anoxia. And the other deformities I'll be later on speaking about, where we have malformation and deformations. This is a scanning electron microscope imaging of a developing embryo. We can see the FNP, which is the frontonasal process, and the oral stoma, and MX is the maxillary area, and the MD is the mandibular area, and H is the hyoid, and we can see the brachial cleft in between the mandibular and the hyoid branchial arches. And this is the frontal view. The next image, we can see in the lateral view that we have nasal plicoid developing above the oral stoma, and just lateral to it is the maxillary development. And beneath the oral stoma, we have the mandibular arch, which will develop into the mandible. And just beneath the mandibular arch is the hyoid arch, and we have the brachial cleft in between. Just lateral to this mandibular and the hyoid arch, we have an arrow pointing towards the area on the dorsolateral side. That is the site where the ear starts developing. And in the next image, that happens around into 5 weeks. Just after 5 weeks, in the next image, we can see that at 6 week around, his has given the concept. We have the mesenchyme proliferation in that area that will be developing. We have 6 hillocks in this circled area. And around 9 weeks of intrauterine life, these 6 hillocks will be differentiating, proliferating, and then we have this image in this last picture, where we can see the tragus and the antitragus developing, helix and the antihelix are developing at 9 weeks of age. Further continuing into the development of auricle, this is a pictorial diagram. We can see that around 35 days, that is around 5 weeks, the first and second brachial arc is that will be differentiating into the anterior and posterior side. That is the dorsal and the ventral side. The ventral side, that is the area of 1, 2, and 3 hillocks. They will be forming the ventral part, and the posterior or the dorsal side will be formed by the 4th, 5th, and 6th hillocks. And around day 45, the hillocks start merging, and around day 49, the hillocks will merge to form a very bland auricle. And around day 52, the developing auricle will start having definitions. And around day 63, there will be the complete formation of this auricle with the tragus, helix, antihelix, triangular fossa, scaphoid fossa, and the lobules. Also, I want to highlight that the helix and the scaphoid area, these will be less rigid as in comparison to the conchal area. That we can also say that it is developing from an ear fold. This is the pictorial representation again of the same thing, where we can see that the first, second, and third, they are forming the anterior part or the ventral part, that is the tragus, root of helix, and the anterior helix. And the posterior part or the dorsal side, we can see that the fourth and fifth and sixth hillock, they are forming the posterior helix and mid helix and the lobule and the concha and the antihelix area. Coming to the anatomy of external ear, as I've already described about the embryology, now we'll go to the anatomy of external ear. Ear is a complex, convoluted framework of cartilage, which is covered by a hairless skin, and anteriorly the skin is more adherent than the posterior posterior part. We have the crus of helix, which is crus of helix, which is starting from the conchal area, and it is the helix is again divided into anterior and superior, anterior, and posterior helix. The superior helix will be the part which is from the crus of helix to the triangular fossa area, as we can see, and till the tubercle. Then we have the posterior part of helix starting from the tubercle to the lobule. Actually, the ear is can be defined in a three-tier area, like the helix and the helix will be in the one of the tier, and then the antihelix and the antitragus will be another tier, and the concha and the tragus will be another tier. We can also divide the anatomic ear into anatomic subunits, that is the helix and scaphoid fossa and helix, and antihelix, lobule, concha, and tragus, for more definition for preparation of the cartilage and reconstruction of ear. Ear is slightly posterolaterally in an angulated in an axis of 15 to 30 degree from the sagittal area. It has a ratio. The length of the ear is about, in an adult, we have a length of about 5.5 to 6 centimeter. And the width is about 0.6 to 1 in 1 ratio between the length and breadth ratio will be about 0.6 to 1. I've already defined the key lines of the ear, that is the helix, antihelix, tragus, antitragus. These are the key lines, and the details of the anatomy of the external ear I have explained. The average height of human ear is about 55 millimeter, which is slightly smaller in female, and in male we have average about 62 millimeter. And the width in the female, the average width in females will be about 34, and slightly more in male, that is 36 millimeter. And I have already explained that the angle between the axis of the ear and the coronal plane will be around 20 degrees. The protrusion of the ear or the projection of the ear is different. The projection of the ear will be different at different sites. That is, it will be around 10 to 12 mm in the superior pole, and in the middle ear it will be about 16 to 18 millimeter, and in lower part of the ear it will be about 20 to 22 millimeter from the mastoid area. We are about to start with the OT. Parag sir is about to start. So we'll continue our presentations later on. Thank you.
Thank you, Reena ma'am. We'll move on to OT3 now. Can we play OT3? Yes.
Hello. Am I audible in OT3? Can someone please respond?
Yeah, you are audible.
Sir, sir, I am here.
Oh, you are sorry. Tell that from OT side. You are audible means what?
Hello. Hello. Is anybody there in OT3 to respond? This is Dr. Akanksha from the mini auditorium.
OT3, can you hear me? Please respond. OT3. OT3 is.
We can hear you. Patient is being induced. We can hear you. Hello, we can hear you. Can you hear us?
Hello. 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 Am I audible? Hello.
Hello.
Hello, am I audible?
Yes, yes.
The patient is currently being intubated. We will start shortly.
Okay. Can we check in the auditorium? Audio is on. Can you hear me in the auditorium?
Yes, sir, we can hear you in the auditorium.
Great. The patient is getting induced. We should be able to start in another 5 minutes.
Right, sir.
Should I inform? Till the time the patient is getting induced on it. Maybe we'll finish the presentation on the anatomy of the ear and the embryology that was going on.
So, resuming the presentation on anatomy and the development of ear.
No problem. Can I turn? Head on this side. That's okay. We'll open now.
Good morning, everyone. We'll continue with the
Shoulder turn
presentation.
chest के नीचे Eknath.
So we were discussing about the characteristics of ear.
Shoulder gap.
Now we'll go to the muscles of ear. Uh, we have 3 intrinsic muscles of the ear and 3 extrinsic muscles from the ear and 6 intrinsic muscles. The anterior auricular muscle, the superior auricular muscle, and the posterior auricular muscle, they are the extrinsic. And in intrinsic, we have this heliacus major, heliacus minor, and tragus, antitragus. And posteriorly, we have this obliquus and a transverse muscle in the ear. Whenever we have this abnormal insertion of the ear, then we may have, we will be having the deformation of the ear, like in prominent ear and other deformational deformities.
अपना जो टेबल है ये ऐसे टिल्ट होता है. You can tilt like this. Patient को catheter.
Coming to vascular supply, the ear is supplied, as we all know, by superficial temporal artery and the posterior auricular artery. Coming to nerve supply, the ear is supplied mostly by the auriculotemporal nerve on the anterior side and the greater auricular nerve on the posterior side. Also in the meatal region, we have the supply from vagus and facial nerve. Lymphatic drainage, mostly in the parotid region, we have the preauricular lymph node draining from the anterior side. It is divided into anterior, superior, and middle zone, and the inferior zone in the lobule area. And the anterior and the anterior area, we have the preauricular draining into the preauricular lymph node in the parotid region. And then on the posterior side, we have drainage into the cervical lymph nodes. Coming to congenital auricular anomalies, as described by Tan et al., we have malformational or deformational anomalies. In malformational anomalies, we have deficient or supernumerary auricular components, that is like anotia, microtia, polytia, where we have mirror images of ear auricle, and then we have preauricular tags, sinuses, and cleft ear. And these when the child will be presenting early, like in 3 months, even molding and all can be, the child can be subjected to molding, ear molding as a treatment, and there are reports of good outcome in by ear molding also. But in deformational ear, we like in cryptotia, stall ear, and prominent ear. In the deformational ear, we have we will be requiring ear molding for as a treatment module. But in malformational ear, the child has to undergo surgical treatment during childhood and adolescence for correction of the ear. But in deformational ear, the child can be subjected to ear molding and other minor surgical procedures for correction of the ear. This is the images showing the deficient auricular components in the superior, inferior part in the first part of the ear. And deformational ear, like can be seen as the second picture in the middle can be shown, that is stall ear. We have the lobe ear. We need to classify the auricular defects for a proper management. So Tanzer gave the classification which we standardly follow everybody. That is anotia. Then we have complete hypoplasia or microsia with atresia of external ear canal and without atresia of external ear canal. Then we have the hypoplasia of middle third of auricle, and then we have the hypoplasia of superior third of auricle, which is again we have in that component we have constricted or cup ear and cryptotia, hypoplasia of entire superior ear and prominent ear. Coming to prominent ear, this is mostly most common type of deformational ear anomaly, where we have the superior crush of the superior crush in the antihelix area and the body of the antihelix. This is very poorly defined, and we have increased concoscapal angle.
आने के बाद अब पहना है, बट ये रख सकते हैं.
Coming to cryptotia, here the upper pole of the ear will be buried in the temporal area, and there will be the retroauricular sulcus in the superior side will be absent. And this is more commonly seen in Japan, where they have a prevalence of 1:400. And here the goal will be to create retroauricular sulcus by skin grafts and local flaps. Even more, the child can be subjected to molding if presenting very early, like within 3 months. And the cartilage deformity, if it is present, then and the cartilage deformity is there, that can be also replaced. And helix and scapha adhesions has to be addressed. Stall ear, as we know that we have the absent superior crust, as we can see in the diagram, that we have the inferior crust, but the superior crust is missing. And we have a third crust which is extending towards the helical rim times. They are again into 3 types, and where we have the superior crust missing, and in another type we have trifurcations, and another type we have a broad superior crust and third crust. And surgically we can excise the third crust, and then we can position it in the area of superior crust area to reconstruct the missing superior crust. Coming to constricted ear or lop ear, Tanzer has again classified into 3 types: lop ear and hooting of helix and scapha area. And the helix difference, the height difference is about 1.5 centimeter from the other part. And there will be flattening of the crura, as we can see in the image, that the cruras are flattened in the superior part of the antihelix area. And this can be surgically corrected by raising flaps and then replacing the cartilage. Also, ear molding can give very good results if addressed very early in life, like in 3 months. Coming to microtia, the cause is unknown, and it is more commonly seen in the Asians. More being seen in the Navajo Indians, and we have right microtia more than the left, and then the bilateral. And in 90% of the cases, the microtia is unilateral, and 10% we have bilateral. And it is because during the development, during the development of ear, most of the derivatives are from the first and second arches of branchial arches, that is the mandibular and hyoid arches. The facial nerve also may be affected, and the development of mandible is also affected at the same time. So we may land up with syndromes like hemifacial microsomia and Treacher-Collins syndrome. Sorry for the error there. And sometimes there can be abnormal course of superior temporal artery. And also the risk of cholesteatoma can be there. So we should be little careful during the surgery for damage of facial nerve as well. And he's Satoru Nagata, sir, who has given a lot of work in, we follow the Nagata technique. Yes, sir. Yes, sir. So we can see that the ear deformity, microtia, it is the range of deformity with complete absence having lobule, and then we have some part of the helix will be developed, some part of the antihelix is developed, and some areas the concha has been developed. So that is why it is so important to classify it into 4 parts, so that the treatment is shorted out. And this is the Nagata classification which we follow, where we have the anotia type, lobule type, concha type, and small concha type. This Mark's classification of microtia has been given to us also, where we have grade 1 auricle, where the auricle is small but all the subunits are present, and in grade 2 we have the auricle is small and subunits are underdeveloped or absent. And in grade 3 we have small cartilage remnants with anterior superiorly rotated lobule, and in grade 4 we have anotia. Furman classification of framework and projection and skin approaches, this will be described later on by Parag sir tomorrow. He'll be describing us about the complete procedure. Another classification which is also given is the Virda classification, where we have grades 1, 2, 3, and where we have the prominent ear macrotia, cryptotia, stall ear, cup ear deformities, and deformities of tragus, antitragus, and lobule in grade 1. And cup ear deformities in grade 2, we have cup ear deformity type 3 and concha type microtia cup ear. And then grade 3, we have lobule type microtia and anotia. Thank you.
Thank you, ma'am. Your detailed presentation not only deepens our understanding but also sets the stage for advanced techniques that we will be exploring throughout this workshop.
Anybody want to have any questions to Dr. Minj? Rina? Anybody wants to have any?
One question to these students, PG students. How do you mark, means in a microtia? It's a very, what is the, how do you plan in a bilateral microtia? Anyone can tell bilateral microtia, how do you plan it?
We'll plan the template with his or her father's. If
we have been taught in our MCA students times that exactly the same height you have to take another boy, same age, same height, you calculate from that area. But with tracing papers. During our time, these people, our MCS teachers asked these questions, so I think it will be helpful for you.
Do we operate on both sides at that time, or that is my question?
I don't think doing both the surgeries will take a big surgery, and it will take more than 10 to 12 hours. Better you do one, and subsequently after 6 months or 1 year, you can do another. Age criteria. Within 1 year, I think nothing will be. And we have to ask these questions to our experts also.
So, yeah, that makes sense also, because on the family members, the different characteristics of the ear differ. They can take from the family members, that trait will be preserved. Each ear's family ear father, probably, but then we can just probably reduce it to the height of that. That should be fine.
If there is any sibling to the patient, that will be a better template drawn on that sibling will be better one. Yes. Otherwise, father definitely family member, because as I said, it runs the characteristic they run in the family. They will not differ from one member to other member a lot unless they have some abnormality.
Sir and delegates, there has been slight change of plans from Dr. Mohit Sharma sir's case. Now we are going to take up another case of post-burn deformity of the ear, and we'll be playing the video of the same with the planning.
So
She is a 27-year-old female with a history of thermal burns in April 2024. She was admitted under us for post-burn contracture of neck, which was grade 4, and she underwent contracture release of the neck with Polynovo application in the first stage, and along with 21 days later, we have done grafting for her. Now she is presented with post-burn deformity of her bilateral ear, and we'll be addressing the right ear in this admission.
So she's 20 years?
27.
27. So she's a 27-year-old female, and she has obviously good chest circumference. There are chances that the costal cartilage will be somewhat ossified, making the carving and molding of the cartilage is slightly difficult. In that case, we might use some burr also to carve and soften the cartilage. So as we see, we do not have a parameter of the normal ear here, so we'll just take a 56 millimeter long template, and here what we plan to do is a single stage total ear reconstruction by costal cartilage framework formation and covering it with temporoparietal fascial flap. And on top of that, we'll take the graft from the scalp and put it, because it gives the best color match. And scalp is more or less untouched, so we can use it. So we will just utilize this normal skin and position it based on the normal tragus, which is hidden here under the scar, and there is normal external auditory canal. So we'll try to utilize this normal skin here. थोड़ा सा इधर मुड़ जाइए. We'll try to utilize this unburned skin, and if we just position it around the external auditory meatus, the framework should come somewhat like this, and the lower portion of the framework will be mostly covered by this normal skin. The burnt cartilage underneath, the remnant cartilage, we'll remove, and the framework will come here, and the top portion of the framework would be covered by the TPF. Now, as you see in this situation, the tragus is present, and after removal of the cartilage, if we see a good presence of tragus, we might not include tragus in our framework reconstruction. So the framework comes like this, and it is all around covered by the temporoparietal fascial flap. On top of that, we put the scalp graft, and then we apply suction and leave the whole of the construct exposed with no pressure dressing, and it should settle over a period of time. So it will be a single stage reconstruction. Thank you.
So we'll switch to OT3 camera. Yeah, this is OT3. OT3 can hear us? Are we audible in OT3?
Hello, am I audible to you now in the auditorium?
Right, sir. You're audible, sir.
Excellent. So the patient is getting prepped, and I will explain my markings one more time once the draping is done.
Yes, sir.
So we have a 10-year-old child with lobular microtia. Now one of the advantages of the Fermin technique is that we will create the tragus in the first stage itself. So it is different from the Brent way of doing the tragus in a separate surgery. So for the patient it's one step lesser. So you finish everything in 2 stages. एक मिनट तू ड्रिप कर ट्रायंगल स्टार्ट लेना किन त्याच्यावर जातं removal of rib cartilage 3 hours 50 ml Is the field visible?
Yes, sir. The field is visible.
मार्किंग मधली स्केल द्या मॉप दे एकनाथ मॉप so I'm going to explain the markings to you one more time. Wait. So there are two measurements that we took. One was from the lateral canthus to the helical root. So this was the first line that I had drawn from the base of the helical rim to the lateral canthus. So this was one marking, and the second marking I had done was corner of the mouth to the base of the lobule. So this was the second line that I had drawn. Then I drew a line which was perpendicular, which was this one. Now the ear, axis of the ear is roughly parallel to the axis of the nose, which is roughly 20 degrees to the perpendicular. So the line with the two arrows at each end, that is the axis of our planned ear. So this is the axis which will be used as the reference when we create the ear. Any questions regarding the markings?
No questions.
What
we'll
is the
start
status of the
infiltration.
external auditory meatus in this case?
The patient does not have an external auditory meatus, but we will be creating a tragus so that aesthetically it will look as if she has a ear canal. So in patients where you want to do some form of canalplasty, if at all, you need to do a HRCT of the temporal bone. In cases of lobular microtia, there is less than 5% chance that the inner ear will be well developed. Most of the patients have some kind of otosclerosis where the stapes incus, they are deformed or they are joined to each other. Some children have deformities of the tympanic membrane. So you can do a high resolution CT scan of the temporal bone to evaluate the status of the hearing apparatus. Let's start with the infiltration. So for infiltration I use 2% lidocaine with adrenaline.
Hello, Bera has to be done also.
Bera test, yes, you can do audiogram and a Bera test to check for the hearing capabilities.
So what is the concentration of adrenaline you are using?
I use the commercially available 2% lignocaine with adrenaline.
So dilution, any dilution, because it is 1:1000, which is usually available adrenaline separately. So
for the ear lobule area or for the post-auricular infiltration, I don't dilute it because we want hemostasis.
And so what is the maximum amount of ADR lignocaine we can use here?
The maximum volume that I normally use is around 5 ml. Just in our incision line. And in the post-auricular area, it's much better. I also routinely do a handheld Doppler in all the patients to mark the course of the superficial temporal artery. Sometimes we find that it has an anomalous course and you don't want to inadvertently injure the superficial temporal artery. Tooth forceps, please. I will also infiltrate in the remnant. Now in the Fermin technique, we use cartilage from the same side as the microtia. So because the child has left-sided microtia, we will be using rib cartilage from the left side. 40 monocle. Let's wait for a few minutes for the infiltration to act. Can we zoom in a little bit? Can we zoom in a little bit? Perfect. Thank you. So in the type 2 incision that we are planning for this patient, it is basically a transfixion incision. So how do we decide at what point to transfix? So you draw this blue line, which is the border of the proposed ear. Then you hold the patient's lobule and you check till what point of time the lobule is reaching this blue line. So you will find a point beyond which the skin is deficient. If you try to take the lobule to an upper point, it will not reach. So that is the guide which tells you at which place to transfix the lobule. I think most of us who have trained, we all have trained in the Nagata technique. So the Fermin technique is slightly different. it is a more surgical technique. So you can use the same technique for microtia, you can use the same technique for post burns or post traumatic deformities as well. So as a plastic surgeon, it has a lot of advantages and it's a good technique to learn. So I'm going to start with transfixion of the lobule. Is the video good enough?
Yes, sir.
So this point of transfixion I have already decided pre-op in the markings. So we will transfuse the lobule. One more skin. Small dolphin. Cautery, please. Handheld. Perfect. So the question that a lot of times I get asked is, in what plane should we raise this skin? Well, the answer is that the plane is exactly the plane where your hair follicles end. It is also the plane which, when you identify the remnant cartilage, you will see that there are tiny fibrous septae which run from this remnant cartilage to the skin. So when you go to the remnant cartilage, you will see these fibrous strands connecting the skin and this remnant cartilage. So you can follow the same plane and elevate your skin pocket in the same plane. So your skin should not be too thin because then it will compromise the vascularity, and it should not be too thick because then the contours may not be very well seen.
So it should be thick enough to survive and thin enough to give a good contour.
Exactly, sir, exactly. Suction, please. So as you can see, the white glistening structure is the remnant cartilage. Can we zoom in a little bit more?
It's visible, sir.
It's visible?
Yes, sir.
So there are some fibrous bands which go from the remnant cartilage to the skin. So that is the guideline of the plane in which you can raise the skin.
Can you keep at the center, cameraman?
Can we pan the camera to little left?
Please zoom out a little.
Left.
No, the other way.
Yes, yes.
This is better?
Little more.
Yes.
Yes. Or little down.
The other
Little inferiorly.
Can we take it little down?
Yes,
Yes.
good.
Right.
Better?
Yes, sir.
Yes, sir. Better.
So do you prefer any particular positioning of the patient, like head extension or?
Yes, we do need a small bolster under the shoulder and a little bit of neck extension. And the head is turned to the opposite side. So normally if you are in the correct plane, it will not be a bloody field. So if there is any excessive bleeding, then also you should, think whether it's the correct plane. Cautery, please. Long forceps. Long forceps. खाली था इसमें ये तो हे गिर मिला गिव दैट forces please. Lobule sister ऐसे रखो, keep a finger here. So we will continue with our pocket. Now I am going on the other side of the remnant cartilage.
Can we have the camera a little? Yes.
Mosquito, please. So I hold the remnant cartilage with a small mosquito forceps. So now. It becomes easier to dissect. Action there. इधर तक है। In lobular microtia, usually there are 2-3 small indentations on the skin. Those are like blind pouches. You can see it from the top. Remove this, I will show you. So at these points, can you see this indentation here? So at these points the skin is very tightly adherent to the cartilage and we need to be careful there not to buttonhole. Hold this please in this direction. But even if you get a small buttonhole, it's not something major, you can manage. It is just that the skin is too tightly adherent sometimes to the cartilage. There is no easy plane that you can get.
So, sir, if there will be a buttonhole, will not it affect the negative suction drain? Because that
So
is
you
also
have
very...
to, you have to suture it. If there is a buttonhole, you have to take a suture to close it.
Close it, right, sir.
Yeah. It should not be a big rent in the skin. A small
rent is
can
manageable.
Can be sutured, it can be managed. So you can see that the cartilage is now getting peeled off. Now at the base of the remnant cartilage, normally there is a vessel. Yeah, I demonstrated by opening it, I think. I'll go on the other side. Cautery, please. Suction, please. Suction, please. Copy. Got it? Good. Okay. I normally prefer to use the cautery at the base of this cartilage because inadvertently there are some branches of the superficial temporal artery which supply this cartilage and then they bleed. So that is our remnant cartilage. So as someone was saying, if you want to use a part of this for tragal reconstruction, you can. But in the Fermin technique, we are anyways going to carve a separate piece for the tragus. So usually you don't need it. 40 monocryl. Small forceps. So now that the remnant cartilage has been removed, we continue to transfix the lobule at the correct location. Small figure. So I am identifying the point which is going to be my point of transfixion. I am using a 4O monocryl. Mosquito, please. And now we will proceed to take a continuous running suture between the third and fourth layers. Skin up, please. So you can see that this is the under surface of our lobule. Is it visible?
Yes. Yes, it's
This
visible.
is the back surface of the lobule, this skin, and this is the postauricular skin, and we are going to transfuse these two. We are going to transfix these two surfaces. किस तरह पकड़ो? माफ करा मध्य में. It is important to take bites which are very close to each other so that there is no air leak and you get proper coaptation of the skin. Is this step visible to you all? Can you hold this, sister? This. Hold like this. Super. This like this.
Can we take a question on the online chat box, sir?
Sure, sir.
Yeah. Dr. Jacob Kurian says, good morning. Please throw some light on atresia-plasty and restoring middle ear function.
So as I said, it also depends on the type of microtia that your patient has. It is not possible to do anything for the atresia or the canal if the inner ear is not developed. Because if the hearing apparatus is not developed, there is nothing much that a canal is going to achieve for you. So what I routinely do is that I do a high resolution CT scan of the temporal bone. After doing the high resolution CT scan, I ask my ENT colleague to take a look at the inner ear, and I involve them in the discussion about a canalplasty, because canalplasty is functional, and unless it's going to improve the functioning of the hearing, it doesn't make sense trying to do a canalplasty. Plus there is the risk of injuring any branch of the facial nerve. So we really have to weigh the pros and cons. In most of the centers of excellence which do high volume ear reconstruction surgeries, a canalplasty has been given up now, and instead of a canalplasty, normally what is recommended is a bone anchored hearing aid or BAHA. BAHA has been found to give much better clarity of hearing as compared to the hearing improvement seen after a canalplasty. So that is something that you'll have to do in discussion with your ENT colleagues. I am almost done with the transcription of this matter. Give it to me. Small dolphin. Now once the lobule has been transfixed, the next step is to create a pocket in the lobule for inserting our future framework. Small tooth forceps, please. Sister, can you hold it? Hold it like this. So we have to create a pocket in the lobule. This is where our future framework is going to get inserted. See? So I will show you the extent of the dissection in the lobule. Are you able to see the tip of my stylus?
Yes.
So this is where the base of our framework is going to be. Now we also create a small pocket for the tragus. Don't hook like that. Small dolphin, please. The tragus is going to be somewhere there. So I will make a small little space for the tragus. Is it visible?
Yes, sir.
So you can see my scissor, I have created this space for the tragus. This is where the tragus is going to be. So we are done with the work in the ear pocket. Now we just pack it with a gauze piece.
So the tragus pocket is in same continuity with the rest of the pocket.
Yes, yes, yes. That's all. Suction please. So we'll start with the removal of the rib cartilage now. Let me just pack this cavity with one single gauze. Stylus, please. Let us extend the ear pocket a little bit more.
So will you remove the small auricular tag at the tragus, or
Yes.
you will leave it like that?
I have already removed this one you are saying?
Yes, yes, yes.
We can either remove it or, yeah. There are sometimes skin tags which are near our incision. Those are dangerous ones. You get a lot of temptation to
Yes,
excise those tags. but
it
that
might create a
compromises-
buttonhole.
buttonhole, and it compromises the vascularity. But this tag is quite harmless. It's quite far from the incision, so we can actually remove it. So let us see where the tip of my scissor is. Can you see it from outside?
Yes.
So it is like 2 or 3 millimeter beyond my marking. Can you see this?
Yes, sir.
That is to, accommodate the cartilage without too much of tension. We don't
Yes.
want too much tension on the incision line.
Even the hair bearing area is also less.
Correct. Correct. Yeah, I think this is the adequate pocket. It's back. Long forceps. So our
Hello.
pocket creation is done.
Hello.
I am packing it lightly with a gauze piece.
Sir, Parag sir, I have a question.
Yes, please.
Sir, usually we find artery, a branch of the posterior auricular artery, which is coming to supply the posterior surface of the pinna.
Right.
Sir, do you preserve that artery every time?
Usually you should try to preserve it if you can.
So if it is cut, then what is the percentage, or what is the likelihood of problem in that flap?
Usually it doesn't cause any problem in the first stage, but then in the second stage when you have to elevate, the vascularity of the skin is slightly compromised. So you should always do a handheld Doppler before the incisions are planned, mark the course of the superficial temporal artery and any other vascular branches in this territory. Sometimes you find that the STA goes right exactly in our pocket. So that is something you need to be careful of. We don't want to damage the STA for the second stage. In case you need to use the temporoparietal fascia for the second stage, we want to make sure that the artery is intact.
Thank you, sir.
So now I am moving to the chest. Let us wait for the camera to get adjusted. Fresh. Is the chest visible to you?
Yes, it is visible.
Can we zoom out a little bit? So I am just feeling the border of the costal area, the rib cage. So I will first mark the border.
So you are taking from the same side.
From the same side, yes.
Right.
In Permin technique, it is from the same side. So this is the border of the rib cage. This is the opposite side. So I will first feel for the first rib that I can feel is the 8th rib. This is the 7th and this is the 6th. So normally these are the 3 rib cartilages that we need. So we can take the incision around an inch inside the border of the rib cage, somewhere here. And I prefer to take an oblique incision like this.
So you take cartilage from the 6th, 7th and 8th.
6th, 7th and 8th. So the length of, can I get the scale? The length of this incision is around 7 centimeters. Local please. You can. So I am infiltrating lignocaine with adrenaline. Yes, please.
Yeah. Sir, if the patient is a female, So what is your marking, incision marking?
I normally stick to the same incision.
So it will have a visible scar.
Yes, the scar will be visible, but if you suture it well, it fades out over a period of time. Because if you try to take an incision in the inframammary crease, well, the inframammary crease is somewhere here.
Right, it is
And
quite
the
above.
rib you need is somewhere here. So it creates a lot of difficulty in removing the rib cartilage. If you take a proper incision and you close it meticulously, usually it results in a very, very faint line. And I have never had any patient complain about visibility of the incision so far. So
As
let's
for
wait for a
the
few minutes.
as
Yeah.
for the infiltration, you can take the spinal needle 24. That helps a lot. Rather giving multiple pricks.
Correct.
In one
Yeah.
prick you can withdraw and give the analgesia and the.
Correct. Yes, you can. Yes.
And second is the left side with the other vital structures.
Correct.
So sometimes some people prefer to be in the right side, not in this procedure, but in other procedures.
That's correct. Yes. Let's start.
So your incision is parallel to the costal border or little oblique.
Around 1 inch inside the costal margin.
Right.
Symmetry. Long forceps. Can we increase this now, the quadrant? Maybe my intention. Certo. So this is the muscle layer, and we have to incise a part of the external oblique and a part of the rectus abdominis to reach the rib cage.
I have a question. Muscle
please.
splitting and muscle cutting, your take on it?
Muscle splitting.
Yes.
So you can split the muscle at the edges, but there is going to be the main part which you need to cut actually to reach the rib. What I do is I keep the length of the skin incision very small, and in fact you can split the muscle much more than what you have in terms of the skin incision. But then you need to incise the rectus sheath, and then you can decide whether you want to split the remaining muscle. So we are on to the rib cage. Khali. I am removing or rather opening the.
Eighth is visible.
I am sorry.
It is the eighth costal cartilage which is visible.
Yes. The first rib that we will see, which is free, which is not attached to the other rib cartilages, is the eighth rib. So how we identify the eighth rib is by seeing the starting point of the rib. Relax sister. So if you see, the eighth rib is completely free. It is not attached to the upper rib. Can you adjust the light a little bit? Upper end. So this is the 8th rib.
It's the edge of the.
So removal of the 8th rib is extra perichondrial. You are going to remove it along with the perichondrium because it's a free rib. Can I get a gauze please? And the rest of the ribs are removed by keeping the posterior perichondrium intact. Now the advantage of the Fermin technique is that you are going to carve on the posterior surface of this cartilage framework, of this cartilage piece. So there is no perichondrium there. Yeah.
So what are the precautions you will take to avoid rupture of the pleura?
When you remove the 8th rib, it is a very safe dissection because it is a rib which is free and it's extra perichondrial. For the other ribs, I will show you how I remove the rib cartilage to protect the pleura.
Good morning, sir.
Can you come
Myself, Dr. Rasmi. I want to ask what is the benefit of taking the cartilage from the same side than opposite side?
This is a technique described by Dr. Fermin, and the advantage of taking the cartilage from the same side is that the patient has the ear dressing and the chest dressing on the same side, so the other side is totally unoperated. And plus you are already leaving the perichondrium behind on this side, so you don't need to spend time on separating out the perichondrium. You can start carving on the posterior surface of these ribs. Of course, there is nothing wrong in taking it from the opposite side. If you are more comfortable taking it from the opposite side, then you will be carving on the anterior surface. But the anterior surface will have this perichondrium. You need to spend some time cleaning up the ribs of the perichondrium. So it is just the technique really. It is up to.
So you are taking this it with the perichondrium, entire perichondrium.
The 8th rib, yes, is with the perichondrium.
So it is a little bit out of box. So in rhinoplasty, which costal cartilage you prefer for rhinoplasty augmentation?
In rhinoplasty, I prefer a straight piece. So it's usually the 7th here, somewhere here. This is a straighter piece.
Right.
The 8th cartilage is kind of 15 number plate, please.
It is more carved.
It's more curved, yes, sir. Okay. So now let us identify the costochondral junction. I need this to be shown properly. Can someone from the camera team focus the camera here? No, here. Can you turn the patient to the opposite side? Can you turn the table to the opposite side? Okay, can you show the rib? You'll have to show it from here. Yes, can you see it better? Perfect, thank you. So how do you decide at what point to cut the 8th rib? There are basically 2-3 landmarks at that point. Keep it under the muscle. So one is of course the color. If you can notice, the bone is grey and the cartilage is pearly white. So the demarcation can be seen from the change in the color. The second feature is there is a small little blood vessel, and you can see this tiny vessel running vertically at the costochondral junction. And thirdly, of course, with your 15 number blade,
You can cut easily.
with your 15 number blade you can check. So this is the bone, my knife is not entering that, and this is the cartilage part where I'll be able to insert my knife easily. So I'm making a small incision on the rib. I normally prefer to keep 1 or 2 millimeters of cartilage intact. So let us separate out the muscle a little bit. Hemostasis. I keep the cartilages in normal saline. We'll check for hemostasis.
Do you add any antiseptic like gentamicin to the normal saline?
No, sir. Once the framework is completed, then I insert it in betadine before putting it in the skin pocket. But when I remove it, I just keep it in saline. Now we go to the upper rib. Relax, sister. Don't be pressure like this. We'll go inside.
So, what is the advantage of keeping 1 to 2 millimeter of cartilage intact beyond the margin
There
of
are
bone?
some studies which have shown that the chondrocytes grow back to some extent, so that it helps in the healing and the rest of the chest cavity doesn't get weakened.
So, without perichondrium, how will it grow?
I'm sorry?
So, just 1-2 millimeter of cartilage is being left. Over that, I suppose perichondrium is also there. But, sir, how the margin which has been cut, it does not have any perichondrium?
It is
The cut
basically
is.
the growth center of the cartilage part of the rib. So we don't want to damage that growth center. So it's always advisable to just keep like 1 or 2 millimeter. So the same step will repeat on the upper rib now. So again you identify the bone and the cartilage. There is a small blood vessel running here. You can see the change in color also. So I will make a small incision on the upper aspect and on the lower aspect, because now the upper two ribs will be removed subperichondrially.
You will leave the perichondrium.
We need to lift the perichondrium, that's correct. So we use a periosteum elevator. Yes, please hold. Section please. Relax. Is it visible?
Yes, sir.
Let us remove. Right side. So I prefer to use this rib brass for elevating the rib cartilage. So there is a right side and a left side. So you have to go very flush to the posterior aspect of the rib.
Dr. Parag, which I have seen, you are I think you have 2 to 3 assistants are there. Why don't you use the self-retaining retractor so that it will be helpful for
I have tried using a
self-retaining retractor?
I have tried doing that, but I am more comfortable with this.
Any disadvantage of self-retaining to damage the surrounding structures? That's why.
No, you can do that.
Mhm.
But then I find that it's a surgery which is constantly moving. You are not at one point. So the retraction has to keep moving according to which rib you are cutting, or at which point you are.
Okay, okay. Thank you.
So I made an incision at the lateral aspect of the rib, and now I am separating the muscle layer from the rib cartilage.
Now, sir, you are talking about how to prevent the rupture of the pleura.
That's
So,
correct.
what are the steps? What are the steps? Precautionary steps.
The most important thing is to preserve the perichondrium intact. I will show you. So if you look at the under surface of my इधर नहीं जाना इधर रुकना चाहिए आपको इधर दिखना If you can see the under surface of my rib cartilage, is this visible?
Yes, sir.
So this is the posterior perichondrium. Let me mop it for you. This is a very dense layer, and once you are making sure that the posterior perichondrium is getting peeled off from your ribs, the pleura and everything else is underneath this. So you are in an absolutely safe plane.
So you first separate the perichondrium, then give a incision, then rest of the incision you do it under vision.
Correct.
So you are over the cartilage, just you are separating.
Yes, you have to keep hugging the posterior surface of the cartilage so that you are safe from the right angle here. थोड़ा आगे आगे. Let's go on to the upper rib now, 15 number blade. So the same step we do on the upper rib. Is it visible? So we take an incision on both the upper and lower aspects, and then we use a periosteum elevator to separate out the perichondrium. Simply. Right side. So I use my rasp to find the plane on the under surface of the rib, suction piece. Section here. Decrease little bit more. ज़्यादा प्रेस मत करो. Right side. Section. Don't come in my way. You are putting it on top of my instrument. Let us cut the right angle now. This rib now. So this is bone. You will not be able to cut it. So you identify the costochondral junction, and then you will be able to insert. And subsequently. Nice change कर लेंगे ठीक. So after cutting the costochondral junction, we go along the medial border and free the undersurface to plan accurately. Can we get a longer cautery tip now? Light please. Section per minute. 15 number group. Can you get little better light here at this point? Right angle please. Don't touch it. Let's cut the upper part. Section. मोटा भी नहीं सकता ये ऊपर बोलो रिब जिधर है ना उधर रखने का. So again you have to make sure that your posterior perichondrium is getting peeled off. Can we see the back surface of my rib? Don't keep moving picture. You have to be very stable. Is this visible? The posterior perichondrium?
Yes, it is visible.
I am just peeling it off the posterior aspect of the rib so that the pleura is safeguarded. section please. So when we are harvesting the rib, it always looks as if you are removing too much, but at the end of the carving you will realize that each and every piece of the cartilage that has been harvested will be utilized. Right angle please. So just I am freeing up the muscle layer from the underlying rib so that we get a plane to incise the cartilage. Section please. Now all of you must be wondering how I am going to sterilize my template which I just carved in front of you before I started. So I am going to show you how to sterilize your template without the need for autoclaving it or without the need of using something like Sidex or anything. Let's go up sister, go here. Number blade. Gotcha. Can I get a new gotcha sister? Okay. Hold this sister. Keep it out there. Hold it.
Sir, how far you go? So, what are the landmark?
I will now take the now I will take the framework that we carved from the opposite ear. I have to first identify the place where I am getting adequate width for the base frame.
Then you will cut it.
So so this seems to be a good synchondrosis. It's quite stable, and I think this is what will form the base frame. So let us take the framework now. Can I get a tegaderm? Remove all of this. Remove it. 10 by 10 centimeter. Plain tegaderm. So what I do is I wrap the X-ray film into tegaderm films so that you can use the template during the surgery.
Just for sterility purpose.
For sterility. It's plain, right? Without a pad. Yeah.
We can do ETO or we can keep it in a formalin chamber. So
yes, you can. Formalin I am not very fond of, sir, but ETO will also take time, and unless you have the facility of doing ETO, it is difficult to get it done on table. Here template, yeah, come from this side. One more tegaderm will need. So you can keep this template in the center of the tegaderm, drop it. Yeah. One more tegaderm please. So you get your reference template without having to autoclave it. Are you able to see this?
yes, sir.
You can keep a few millimeters of the tegaderm films attached to each other. And that's how we get a sterile template. Is
You
it visible?
prepare two templates, one gross, another for framework.
No, I have made only one template.
One
and from the same template I will create both the base frame and the rest of the components. Artery please. Right angle. Either Raja, picture. Come on this side. So let us now decide what synchondrosis to use for the base frame. Yes. Can you give better light? So खालचं दाखव आधी. So if you try to use this synchondrosis, it's too small. My base frame is not going to fit on such small synchondrosis. Let's go to the next one now. Go up. Keep it under the muscle system. Super. So don't pull so much. So when I place this base frame, this is a good synchondrosis to have for making the base frame. So I am going to choose this particular synchondrosis for the base frame. So let us go a little higher up. Muscle के नीचे रखो. बस, ठीक है. Suction please. Suction please. Okay, thank you. Periosteum elevator. So let us free upper part. 15 number blade. Yes. Retract. ये blade change करेंगे. बाद में. So let us free the perichondrium. Suction please. Suction. Left side. Let us see. Suction please. So I am separating or rather peeling the perichondrium off the posterior aspect of my rib. Right side please. Same we do from the posterior aspect and the anterior aspect. So the rib rasp is a very useful instrument. You can see my rib rasp. It has come out from the other side. So 15 number blade please. This one also. Correct. Muscle के नीचे रहना. So this instrument helps you safeguard the pleura because you are displacing the perichondrium on the posterior aspect using this instrument. Give my longer cutting. So a lot of times I get asked what happens if you open the pleura. So yes, please change this bit. So the answer to this is that nothing happens if you open a small nick in the pleura. Happens nothing to worry because it is just the parietal pleura. It's not the visceral pleura. You can easily suture it with one or two vicryl sutures. Of course, you should do a Valsalva maneuver to check the integrity once you have sutured it. But you don't need to put an intercostal drain. In none of my patients so far I have had to put any intercostal drain. So that doesn't mean you can open the pleura with impunity. You have to be careful, of course, but even if you open a small portion of the pleura, it's not something life threatening. You can just suture it back and nothing will happen, because it is the parietal pleura, not the visceral pleura. Can we reduce the cautery now a little bit?
How do you maneuver with the anesthesiologist to know that the rent in the pleura is been properly sealed by your suturing?
By doing a Valsalva maneuver.
So for the audience, if you can just little elaborate.
Yes. So basically, Valsalva maneuver is where you ask the anesthesiologist to do positive pressure ventilation, and you insert some water in the chest cavity and make sure that there is no bubbling. So we will do it once the rib cartilages are out. I will be doing the Valsalva maneuver. So we will check whether we have been able to salvage the pleura properly. Periosteum elevator. Relax. Hold. Lightly. Okay. Periosteum elevator. So when you stay in close proximity to the posterior surface of the rib, you eliminate or at least reduce the chances of opening the pleura. टेबल का हाइट बढ़ाएंगे थोड़ा, नहीं अप टेबल अप, यहाँ से किस तरह आप ना उस तरह से करके जा रहे हैं, मैं लाऊंगा।
सर अगर हार्वेस्ट के टाइम सिनकॉन्ड्रोसिस डैमेज हो गया तो कैसे मैनेज करते हैं?
You can fix it with sutures to stabilize it. Sometimes the synchondrosis is naturally also not very stable. Has someone reduced the cautery? The cautery has not yet been reduced.
Sir, which suture you use to stabilize?
I normally use stainless steel sutures. I am going to show them in some time when you start the carving. So you can bust it. Thank you. You're out of the muscle, under the muscle. Lightly. of time. Portion. I have almost reached the upper extent of our rib cartilage harvest. So let us again place the cartilage framework and see the placement. Can we focus on this? Is this visible? Can you bring it little up to the center so they can get a top view? No. Take it from the top. Some slightly, this is not, yeah, little better. So if you try to use this in chondrosis, this is too small. My base frame is not going to fit on this. So that's why we selected this base frame. So when I'm placing my template on the rib, you'll see that the entire template is fitting on this particular synchondrosis. So this particular piece we'll use for the rim, and the piece that we harvested before that can form the Y. Now we need a small piece for the tragus and for the second stage. We will be banking a small piece for the second stage. So let us decide at what level we are going to take the upper cut. Can you turn the table towards me, please? Right up, yes, correct. Turn towards me. Super, thank you. Can we adjust the light a little bit? And the camera also. Can we get some light?
Sir, the three cartilages visible, the 7th, 6th and part of 5th?
Part of 5th, yes.
Right.
That is also probably because of the age or size of the ear.
Okay, that's why.
If the opposite ear was slightly smaller, then maybe we could have used
only 7th and 6th.
Yes, only 7th and 6th. A little bit of 8th, but in this case we have to use a little bit of 6th also. Substantially. If there is no bleeding, there is no. Okay. Let us decide at what point to cut. Let us place template one more time. So this much we are going to use for the base frame. We need at least a couple of centimeters for the tragus and the tragus. So I am just marking out where the upper cut is going to be. Now for the upper cut I use a special knife which I am going to show to you. Can you see my cutting knife? Relax, relax.
No, sir.
Is it visible?
Not visible.
So this is actually a knife used in maxillofacial surgery. The French call it the coude. So coude is basically a right angle knife, and these blades are disposable. They are detachable. You can detach the blades from there. So this knife I use for cutting the upper end. If you try to use a 15 number blade to cut the upper end, you don't get that kind of access. So this is a very helpful device, and you can ask me when you meet me where to buy it, and I'll tell you where to buy it from.
It comes in one size, so there is no 11, 15.
Let me remove it. Sorry. It comes in one size, and the blades are like a pack of 25. So you can change the blade.
And what about the handle? The handle
The
is
handle
also.
is autoclavable. It's a stainless steel handle. You don't need to discard the handle. It is like any other instrument. You can autoclave it. The blades, of course, when you use it routinely, it loses the sharpness. So you need to change the blade. Let's wait for the camera to zoom in before I make the cut. Suction room, is it? You are too low. You have to be here. Copy. Okay, is the upper incision visible? I had made a small mark on the rib. Can we show this incision?
Yes.
Can you show this? I am pointing it out with my blade. That is going to be the upper extent of the dissection. That's where I will cut the rib at the upper end. Can you pull?
Sir, it's a bit offbeat question. So, in the age of endoscopic surgery,
Yeah.
So is it possible to harvest costal ear the cartilage
Yes.
endoscopically?
Yes, why not? Why not? If you have someone skilled enough to do it, there is a center in South Korea where they do all temporal fascias endoscopically. They harvest huge size temporal fascias endoscopically. So yes, why not? It will surely reduce the morbidity for the patient. Why not? Yes. If you can give me a little better light at that point, at this point. Yes, sir, right? Is this sir? Pull इतना थोड़ा pull push up. Can you pull? Pull. Section. Right, section. इधर लाइट अंदर नहीं जा रहा. हाँ सर तो ठीक है. अच्छा था लाइट. Someone moved the light. It was quite good actually. No. This light was quite good. अच्छा था वो light. Section. Chase enough. That is camera. But anyway, it has light also. Can I get a fresh draw? Just for everyone to see. For me, it's not a problem. But let us adjust the light so that everyone can see how we made the upper cut. Yes. Yeah, you can adjust, then I will make the cut. Yes. This you take from that side. No, little bit to this side, the no. Hello, isn't it? Yeah, I think this is okay. Is it visible? Can you give the light to me? I am making the upper cut.
Sir, another question with the advanced technology, there is a piezotome.
Yes.
Is it possible to use it here, physiotome?
Yes, I use piezo regularly in adult cases which have calcified cartilages. In young children, knife is good enough. But if you have bony or calcified cartilages, then definitely
Piezo can be used.
piezotome is very helpful. I use it very routinely. So one rib I have cut. Second one now.
So you have put a gauge piece to protect the underneath structure.
Yes.
Okay.
I have. So this is the piece of cartilage that we use for our reconstruction.
So it include 3 cartilages.
Yes.
And
Let it go up.
8 cartilage is separate one.
Yeah.
So 4 cartilage.
8, 7, 6
That
and
again-
part of 5th.
Part of it. Yes. Let us check for hemostasis.
So you have taken perichondrium of one side along with the cartilage.
I use taken perichondrium on the anterior surface. The posterior perichondrium we have left inside to protect the pleura. So now we will request our anesthesiologist to do a Valsalva maneuver for us. Can you take some saline, sister? We'll do a
You'll
positive-
check for the any leakage.
Yes, we'll check for pleural integrity. Yeah, no, wait. The nurse has to give me saline first. Just wait. I'll tell you. 2 minutes. Can we get some saline? Remove this tube. It's coming in the way. Right angle. Put here, sister. So I'm putting some saline to check. Can you give positive pressure ventilation? Blowing? Blow, please. Yeah.
So it is like testing a leaking tube in a tire. If the air bubbles comes out,
Yeah.
is not
If the air
coming, it
bubbles-
is okay.
So we seem to be good. Back on 20. Thank you. So I'll just pack the cavity and then we start with closure of the chest cavity. Any questions so far? Y320.
So you will put a drain here while closing,
No sir, I don't put any drain in the chest.
and it
but
would be a
I-
true two-layer closure.
It will be a two-layer closure. First the rectus sheath and
Ah.
then the subcutaneous layer. For the skin, I take a running subcuticular stitch at the end, and I infiltrate ropivacaine in the muscle layer for pain relief.
Whether you will place the discarded cartilages in the chest wall or
Back into the chest. I preserve a piece of cartilage for the second stage, but I don't do it like Dr. Nagata, who used to dice the cartilage and put it back between the two layers of the perichondrium. I don't do that, but I will place a small piece for the second stage.
How do you preserve the cartilage for the second stage?
I will first close the rectus sheath and I will place the cartilage between the rectus sheath and the skin. So in the second stage you don't need to open the muscle. What is more painful to the patient is when the muscle is opened or the rectus sheath is opened. You just need to make a small incision on the skin and your cartilage is right there. So you don't need to do anything more. Right angle flower,
Sir, whether there is any chance of chest wall deformity?
We were having this discussion in the morning, Dr. Mohit Sharma sir and me, and we have never actually seen any chest deformity happen after rib harvest. I have operated more than 13 patients of bilateral microtia, and in bilateral microtia I took out of course rib cartilage from both the sides, and they are all doing fine. There is no chest wall deformity or there is no restriction in physical ability. They are able to exercise normally, they are able to perform all activities absolutely like normal. So if you don't damage the GC sternum, then I think there is no deformity that you'll have. We find that the posterior aspect of the rectus sheath and this leftover posterior perichondrium, everything fuses and it forms like a very dense and adherent layer, which is something which gives strength to the chest wall, so the patients don't have any deformity. When I close the layer, you'll see that the chest wall is almost the same as the other side. There is no, depression or deformity that you can see. Bone transfer.
What is your longest follow-up cases?
I have been doing ear reconstruction since the year 2011, so around 12-13 years of follow.
So after 10 years, what about the status of the cartilage?
Status of the ear cartilage? The
Yeah.
framework? If you have a good healthy vascular cover, the cartilage remains absolutely as it is. You may have some blunting of the contours, and therefore it is important to create a little bit of exaggerated contours when you create the framework. So you can expect a little blunting of the contours as the years pass by. But the shape is very well maintained, and I believe this has got to do with rigid fixation of the cartilage components. So sutures normally don't give that kind of rigid fixation what stainless steel can give. So I am a very firm believer of stainless steel sutures in fixing the components, because it is all about the exertional force of the skin envelope. As the skin envelope starts to heal, that's when, don't pull so much, that's when your cartilage components come under a lot of stress, and that's when the cartilage components can move if they have not been fixed rigidly. So it is, I think, similar to the principles we follow in maxillofacial healing, that the fixation has to be very rigid, and that ensures that you get a longer lasting outcome.
So regarding the resorption or the deformity of the pinna, after 10 years?
Right. I would rate it as maybe 15 to 20%. So if you don't have an adverse event such as infection, then the cartilage survives very well. If you have an adverse outcome or adverse event such as infection, then yes, of course your cartilage is going to get resorbed. And I have had one case where the cartilage framework was almost completely resorbed. It was completely destroyed by the Pseudomonas, and we had to redo the framework using cartilage from the opposite side. But with proper attention to asepsis and attention to detail, we should be able to prevent any kind of infective episode. Infection is more likely in patients who have an active ear canal. So if a patient has an ear canal, I spend some time cleaning the ear canal with antibiotic before I start. So you can use the earbud dip in an antibiotic solution and clean the ear canal properly before you start, because the organism is something which comes from the local area, so either from the hair or from the ear canal. So in female children, we ask them to keep their hair properly tied and out of the way, not to touch the ear framework for at least 15 days post surgery. And in patients who have a ear canal, as I said, we use antibiotics to clean the ear canal before the surgery. Udhar laga.
You have exposed this cartilage, and also intercostal nerve is also exposed. Why don't you block intercostal nerve block? It is a very painful condition.
You can give intercostal nerve block, but I normally infiltrate ropivacaine,
Okay.
Ropinlac and Ropin.
What drug you are using in intercostal nerve block?
I normally use ropivacaine. Ropivacaine remains for around 6 to 8 hours. And in the muscle also I am going to infiltrate ropivacaine now.
Thank you.
How much percentage you have? There are 2 percentages of ropivacaine. So let us see which percentage we have. 0.5, right? 0.5, yeah. So you take 10 cc and 10 cc saline. So we'll use 10 cc of 0.5% ropivacaine and 10 cc of normal saline to infiltrate the muscle. I normally find that the younger the patient, the less is the post-operative pain that the patient has. Children are much more comfortable than adults. You operate on an adult male, he'll keep complaining of pain for almost 2 weeks, 3 weeks. And you operate on a 10-year-old child and there is no pain after 4 or 5 days. That also has got to do with the thickness of the muscle. The pain is caused by the cutting of the muscle. So thicker the muscle, the more is the pain. So, right hand is that. So let us infiltrate ropivacaine. That's all. So we'll start from the uppermost end of our muscle incision. Adieu. You can also use transdermal patches of either fentanyl or buprenorphine if you have for post-op pain relief, but it's not available everywhere. So part of the infiltrate, half of it I have infiltrated in the muscle and some part I am infiltrating in the subcute. Twice repeat. Sister? Thank you. So now I'll close the chest incision partly. I'll not close it completely because we need to bank a small piece of cartilage for the second stage. So I'll just close a part of this incision and then we start with the carving. Any questions so far?
Anybody? Yeah, there is a question.
Yes.
So what is the advantage of keeping the perichondrium intact on the anterior surface of the cartilage while we are harvesting it?
Yes. So when you have to carve on the posterior aspect, especially at the area of the synchondrosis, what happens is if you don't keep any perichondrium on both the surfaces, you can have a little bit of instability of the synchondrosis. So it's better to keep the anterior perichondrium intact. it gives a kind of support to the cartilages, especially at the synchondrosis. And the posterior surface, of course, is the one you will be carving on. So it doesn't come in the way of your carving also. It is on the opposite aspect.
So any advantage with respect to the survival?
That's difficult to say.
So because always as synchondrosis, definitely some fibers are there which are connecting it. So we can even use one or two sutures to stabilize the sutures cartilages if we are finding that they are a little bit mobile.
Yes, yes. There are some surgeons who completely make the cartilages bare of any perichondrium. They completely remove all perichondrium on both the surfaces. And there are some who keep a little bit of perichondrium on one of the surfaces. So I think it is each person's experience. Betadine का बहुत ध्यान रखेंगे. So I keep a small piece of betadine on the incision till we do the framework carving. And we start the carving now.
Well, I like your incision, line small incision.
Small cartilage later. Sorry?
Dr. Parag, I like your incision. It's very small incision, no?
Thank you.
And second is, do you encounter any golden heart syndrome patient?
Sometimes, yes.
Did you get, how many cases have you seen?
Sorry.
Golden heart syndrome patient.
Yeah.
How many cases you have seen?
I have seen maybe 3 cases so
Three
far.
cases, okay.
So when the child is syndromic, it could be golden hour syndrome or it could be Treacher-Collins syndrome.
Yeah.
Mainly the planning has to be a little different for the location of the framework, because you may not be able to replicate exact measurements of the opposite side, given the fact that the jaw is going to be asymmetric. So we need to cheat a little bit and arrive at the ideal location of the ear framework.
I am little excited to ask you a stupid question. What is the percentage of povidone iodine you are using?
Povidone iodine, what was the percentage, sister? Let me ask. 10%.
10?
10%.
Okay, good.
हाइट थोड़ा बढ़ सकता है. It's okay. Can we adjust the camera to show the cartilage? Yes, I think it should be fine. I think you can remove the plastic. Not it. Remove the plastic. Okay, ये इधर रखेंगे, ये उधर रखेंगे. Okay. फिर ये वहाँ रख दीजिए, इसका जरूरत नहीं. So for the carving, I'll show you what instruments I normally use. Is this visible? So we
yes, it is visible. Can we have the camera rotated? We want to see the surgeon's view.
So there are these gouges which I use. No, it's not. No, other side. So there are 3 gouges, small, medium and large. Then we'll use, of course, a 15 number and a 10 number blade. And then I use this cutting board to do the carving.
Can we rotate the camera towards the opposite side?
You want the camera to be rotated 180 degree. So it can be a good surgeon's view. Yeah. 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 Okay.
Better?
Yeah.
Right.
I will be just cleaning first, so 10 minutes वहाँ ले सकते हैं. So we are shifting to the OT1 where the other patient is prepared. I am just going to clean the cartilages till we come back, and once we are back in this OT, I will show you the steps of the cartilage charging.
Yes, sir. We'll have you on the split screen. Please let us know when we can come back to you.
Sure, 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 I will. म्यूट है 15 नंबर ब्लेड हाँ कटिंग मैट पकड़ो इसका एडवांटेज क्या है इसमें मेजरमेंट भी है ना स्केल भी है तो यू कैन कटिंग के लिए तो थोड़ा रिपीटेड ऑटोक्लेविंग से फिर वेयर आउट हो जाता है बट कटिंग से कुछ नहीं ये थोड़ा एक्चुअली कटिंग के लिए है ना तो नथिंग हैपेंस नथिंग थोड़ा सा हाँ ये स्टेशनरी शॉप में मिलता है I can send it to you. Okay. No, I'll not separate for now. I'll of course separate it later on. Let everyone see it. And just remove the cartilage, the muscle. ले सकते control it. Doesn't make any difference. Right, see, in C2, this was like this. This is what we harvested. So the anterior perichondrium is intact. So we are going to flip it and carve on the posterior surface. So what this does is it gives stability to the thin chondrus. It doesn't move. If you want, you can peel it off, but there is no advantage of peeling it. So it gives better stability. सर का स्टार्ट हो गया दूसरी ओटी में और we can
I think Parag, still Mohit is getting ready only. You can continue as soon as he
okay, sir.
ready.
Marking pen, can you switch on? So let us see how we are going to position the base frame. So when you see the length of the ear, the majority of this has to be on the cartilage. So you see a way in which majority of the framework is going to lie on the cartilage. So this seems to be the most ideal location. So I'm going to mark the base frame. 15 number blade. Pull this. So let us see what all things we have. We have these components. So this is going to be our base frame. This is the largest piece. The second longest, so my cutting board has a measuring scale. So this piece is around 9.5 to 10 centimeter long. So this will form the rim. The 8th rib what we removed is around 7 centimeter. So this will form the Y. And these two pieces which were the uppermost ends of our cartilage piece, one of these will form the tragus, the broader one, and the thinner piece I will keep for the second stage. So as I said before, when we harvest the cartilage we feel there is too much, but at the end of it you will find that everything is used. So I am going to give this piece to my assistant to bank in the chest for the second stage. ये पानी में रखिए and we proceed with the carving. Number marking, sorry. Let us see the size.
हाँ क्या जी गिव अ स्टेराइल टेम्पलेट
Can you adjust it so that this is better?
टेम्पलेट मैं इधर आ जाऊँ एक शिखा एक सेकंड या अभी राइट नाउ इट्स ओके कैन आई स्पीक
Yes, sir. You're audible.
हेलो
Yes, Mohit.
या सर एम आई ऑडिबल
Yeah, you are loud and clear.
Okay, so good afternoon, everybody. There is incredible delay in starting this case because we cancelled our microtia case because the child was very small in size. So we have taken this post-burn ear deformity in which we are doing total ear reconstruction using temporoparietal fascial flap. So this is the remnant of the ear. Practically whole ear is gone, only the external auditory canal is visible.
Yes.
So as you can see, this is the side burn.
OT1, can we have it a little zoom out, please? OT1, little zoom out. Right.
Eh?
Right. Can we rotate it a little bit? No, to the opposite side. Right. Right.
So can you hear me?
Yes, sir. We can hear you.
So this is the side burn of the patient, and this is we have marked the superficial temporal vessel, and just by the side of it we have marked the vein arbitrarily. Then if you take one index finger, the root of helix should be one index finger behind the sideburn. So taking the patient's finger and taking external auditory canal as a reference, we have just marked the position of the auricle, and we have given this this should be the incision for raising the fascial flap. So our plan is to raise a temporoparietal fascial flap, take out the temporoparietal fascia at this point and create an auricle in this position and cover it with TPF and put a scalp split thickness skin graft. And the only issue is this skin here is very scarred, so it may not be possible for us to create a tragus. The tragal cartilage is present here, it is buried under the scar. So right now we might be creating a framework without the tragus, just like that. And it will be fully elevated primarily and covered by TPF from behind and from the front. And we'll try to utilize this normal remnant skin, which should come in front of the cartilage framework, and the bad cartilage we will discard. So we'll simultaneously start raising the TPF, and here you can see, you can focus here on the chest. Come here. Can we switch the video to the chest? कहाँ पर? So this patient's chest is very much scarred. There is a big contracture band here. So we have to give a bigger incision because the breast has been pulled down and this thick contracture band is restricting our access. So we'll have to give a bigger incision and expose the cartilage 6, 7, 8, 9 and harvest it extraperichondrially. Are you able to see the chest, Dr. Bharti?
Yes, yeah. Tell me, Mohit. Yeah.
Are you able to see the chest?
Yeah, we can see.
So
from the side view anyway.
We have to give this bigger incision because of the contracture, and then we'll be harvesting 6, 7, 8, 9 costal cartilage.
Okay. Are you planning to push the breast also up at the same time and cover it with a skin graft?
No.
Okay.
Okay, so we'll start. Thank you. इसको we can take off. इसको हटा लो. बीच में बोलना पड़ेगा मगर, है ना? ठीक है. ये थोड़ा सा करेक्ट पोजीशन पे हो सकता है क्या? ये थोड़ा एक सेकेंड. ये कान पे कहाँ से आ रहा है? ये थोड़ा सा ऊपर हो सकता है, थोड़ा सा. हाँ, विदाउट डिस्टर्बिंग द लूप. हाँ, हेड के ऊपर नहीं आएगा ना? ठीक है, जो भी है. कम कम कम. मुझे स्टूल दे दो. ये ठीक है ना? ये यहाँ से ऐसे देखो, ये TPF Come from behind the ear ना, है ना? यहाँ से नहीं लाएंगे उसको.
Am I audible in the auditorium?
ठीक है. Okay. हाँ, start. ठीक है. टेबल हाइट थोड़ा कम हो सकती है.
Has it been infiltrated already, Mohit?
Am I audible in the auditorium?
Are Dr. Mohit able to hear?
Hello?
Are you able to hear from the OT?
Yeah.
Yeah. So have you infiltrated now?
Yeah.
Already. Okay, I was a little late.
As Mohit sir is starting the case, can we please switch to the other OT? Parag sir is showing us the carving.
Section? Something mop. You can mop.
So, I hope I am audible.
Yes, sir, you're audible. Parag, sir, you're audible.
So, if you remember, we harvested the rib cartilage like this.
Your volume should be little more, Dr. Parag.
Can you increase the volume? So this is the anterior surface. This is how the cartilages were in the chest. And we kept the anterior perichondrium intact. Now the carving happens on the posterior aspect.
Better.
So you can, from the anterior side, you have to flip the cartilage so that your carving is going to happen on the posterior aspect. Now you remember we had chosen a piece for the base frame. So I am marking the base frame using the template that we had made before. Now if you look at the thickness of the cartilage, we have to choose 2 points, one for the root of the helical rim and one for the lobule, which are going to meet the ground level. So these 2 points have to be the thinnest. So with the number 10 blade I have thinned out the thickness of the cartilage. You can see it in this view at the lobule, because I want to tuck this inside the pocket that we made in the skin. And this part where the root of the helical rim will be made, I will also I will also thin out the base so that the rim looks proper. So these two are the lowest points in the framework. Then I am creating the scapha, 15 number blade. To make the scapha, I am going to incise the cartilage in a way that it is not full thickness. We keep a little bit of cartilage still intact, and you core out the rest of the cartilage. So you take an incision with a number 15 blade.
Can we zoom in a little bit? OT3.
Can you zoom in, please? Medium down. Is it better, sir?
Little. Yes. This is fine.
Better. So with the gouge, I am going to core out the grooves that we marked.
What should be the minimum width of this groove?
At least 3 to 4 millimeter at the narrowest point. and here it should be quite deep. If it is less than 3 to 4 millimeter in width, then you will not have adequate area for the skin to enter into that gap. We don't want the overlying skin to tent, we want it to drape. So we need to create a sulcus where the overlying skin can enter. 15 पे करो। 15। Small go. पकड़ो। Medium. Medium. So now I will deepen the areas that we carved so that we get a better depth. Of course, not going full thickness through and through, little short of the full thickness.
Is not possible to fix up the base? We can fix to one place. Is it possible?
To fix the base, meaning I didn't understand.
Whatever you are moving on, no?
So the yeah.
Yeah.
That we do when we are fixing, we are suturing the different components together. We will do it to a silicone board in some time. But
What is the demerit of making it full thickness?
What is the
Demerit of making this group full
it
thickness?
will weaken your framework, and then the pieces will become wobbly. They will not remain stable. And that is also the reason I was saying I prefer to keep the perichondrium intact, because if you see you are almost full thickness here, and if you don't have support of the perichondrium as well, then these two pieces will become very floppy. Small ball. Because we want the framework to be stable. Thickness. You want me to pause? Chandra? So I have deepened the sulcus to create a scapha marking pen. Now we mark the Y of the antihelix. Is it visible?
Yes.
Leave it remove. We are creating the triangular fossa between the two limbs of the Y. Again, this is almost full thickness. You can go full thickness if you want. This doesn't matter as much, but here I don't prefer to do it full thickness. So when you look at the three-dimensionality of the framework, this has to be the highest point. Can I get a marking pen? This has to be the highest point of the framework, both for the Y and for the helical rim. And from these highest points, everything will go back and meet the ground on both the sides. So highest point and then lower it everywhere so that it meets the ground level. So this is the base frame. Now let us start carving for the rim. So as I said, if you see the longest piece of cartilage that I have, it is around 9.5-10 centimeter. थोड़ा कट हो रहा है, little yes, perfect. Are you able to see this?
Yes, sir.
So I am going to mark with a marking pen again on the posterior aspect. So again, how much thickness or height of the helical rim to make, that depends on the available skin envelope. If it's a post-traumatic case, and I will show it to you tomorrow, if the skin envelope is very tight, then you cannot really make a helical rim which is too high, because your skin will not be able to accommodate that much. But in microtia cases, you can create a helical rim which is at least 4 to 5 millimeter in height. Number 10. So I am just lowering the height of this cartilage piece on one aspect, because what I want to do is to have a helical rim like this. So I don't want it to be too thick. So we need to thin it out to the desired level, and this you have to keep progressively seeing how much you are thinning it out. You can't over thin it also, because then your sutures will not hold, and you need a little bit of cartilage to remain to hold our sutures. I will remove a little bit of muscle attachment on this surface also. Is this visible?
Yes, it's visible, sir.
So still too thick. Still I will want to reduce the height, the thickness a little bit. Let us see again. It looks okay to me. So this will form the helical rim. It will start from here and it will go till the base. So our base frame is done and the helical rim is done. Can you shift it slightly to that side? Just for a second. Yeah. Can you? Yes. Now what I have is the 8th rib, which you remember. Can we center it on this? Yes. So the length of this rib is roughly 7 centimeters. So it is just enough for me to do the Y and the anti-tragus, and of course the tragus will be formed separately. So let us start marking for 15. Marking pen. So the advantage of using the 8 for the Y is that it has a natural curve. I don't really have to work on making it curved. In fact, sometimes it's too curved and that becomes a little difficult. So we use the natural curve of the 8th rib to create the anti-helix. At any point of time, if any step is not clear, you please feel free to ask me. Let us check. So I am okay with the curve, but I want a little thinner piece. So after this, I am going to thin it out a little bit. Just a little.
So what should be the ideal height of helix and anti-helix?
So with each fragment, it adds around 4 to 5 millimeter. So when you stack it on surface of each other, it will be around a centimeter. I will show it to you in this view when we finish the fixation. So you are able to see the height. So roughly this will be the height.
And how will decide the highest point of your base frame?
I will explain to you the highest point of the base frame. So when you look at the base frame, the highest point, marking pen, on the base frame is somewhere just beyond the synchondrosis. So it is somewhere here. This is the highest point, and the adjoining point on the helical rim, this is the highest point. The rest of it has to keep lowering till the lobule and the helical rim meet the ground. So for example, if you look at it in this view, this is the highest point, this is the highest point, and these two are the lowest points. Is it visible?
And what should be the width of the triangular fossa?
Width of the triangular fossa depends on the width of the ear framework. So when you place, you have to replicate the triangular fossa on the opposite ear. So this is exactly the same size of what it was with the natural ear, the opposite ear. So roughly that. Rest everything is as per the opposite ear actually. We'll just remove a little bit of झाले. बघू. So again, marking pen. When I place the Y of the anti-helix on our base frame, can we zoom in a little bit? Yeah. So this was the highest point, if you remember what I had marked, this point. So when you keep the Y, this will be the highest point. Let's mark on the Y. And the rest of it, the two limbs and the distal part, everything will be tapered to the ground except this little area, which will form the antitragus, which I will keep a little high. Rest everything I will lower. 10 number blade, please. So from the highest point, we lower the height. Okay. Is this visible?
Yes.
It's visible.
This was one crura, one crus, and this is the other crus of the anti-helix. Same with the lower part, the caudal part. Highest point, lower it down, just short of the antitragus. Can you see this?
Yes, sir.
So this is the highest point, marking pen. Highest point, and then it curves on either side, and then again, of course, antitragus is the highest point. Let us go to the tragus now, marking pen. So for the tragus, I have this piece, which you remember was the highest point of the upper end of the synchondrosis. So let us see how we will position our tragus on this. 10 number blade, please. Number blade. No, marking pen. So the shape of the tragus is marked on the cartilage piece. It is like a U-shaped structure, which is the incisura intertragica, and then the tragus is like this. So it's like a lazy S. 15 number blade. Full thickness. So if you see it in the profile, this is the highest point of the tragus, and then it will taper downwards. So we reduce the height. Of this area, which is going to form the intertragal area. So this is somewhere how the tragus is going to be. This is how it will be somewhere. So highest point, and then the rest of it is made thinned out. So let us see what all components we have. Can you take a photo? So these are all the components that I have created. The base frame, this, then the Y of the anti-helix, the helical rim, and the tragus. The anti-tragus is, as I said, going to be formed from the Y of the anti-helix where it ends. So let's take a photo, please. Now I use stainless steel wires to fix the different components of the ear. Light, please. With silicone. This is a silicone block what I am using to fix the different components so that they don't move when the fixation is happening. अजून एक देतो? हाँ, ऐसा देखो. हाँ, needle. Marking pen, wire. Okay. So let us see how the helical rim is going to sit. Okay. So we start fixing. So the stainless steel sutures that I use are like this. It's a packet of 5 and there are straight needles on either side. So the thickness is like 40 epsilon. It's the same caliber. And is this visible?
Yes. Well, I have a question. After the frame is made out, did you test with the globe with the frame with a suction apparatus? Or some people do it in outside?
Suction apparatus at this point, no.
No. Suction apparatus put into a frame where the globes are being used. So the frame can be tested for this contour.
No, so when I insert the framework in the body in the pocket, I will apply suction drain before we close.
Yeah.
So that we are able to see the stability of the framework. That's
Well,
what you're saying, sir?
no. I am telling prior to that. Can you make it replicate in a gloves frame? Some people do it in a frame. There is a gloves and also a suction apparatus. So you put this your frame into that, and you can get a contour.
That is basically for training.
Yeah.
So Dr. Fermin has created something with Carl Stotz
Yeah.
called as the Fermin trainer.
Mm-hmm.
So in the Fermin trainer, it is what you're saying. There is like a gloved, surface made of latex, which you can cover your framework with, and then it has an outlet to put and pull with a syringe, which creates suction.
Yeah.
And you can see how the contour is going to be.
Yeah.
Yes, but I don't do it in actual practice. It is good for practicing as when you train in it.
Well, maybe you are experienced with, so I don't think may not be required for you, but for learners, could
So
be a
it's
possibility.
very good device, and it's something which really helps you see how the skin is going to drape.
Whether this stainless steel wire is available in the market?
Stainless steel wires, I will give you the contact number, sir, where to find this.
Okay.
I don't have any royalty with this, but it's not a problem.
So what is the cost?
The cost per packet is around 1100 to 1200 rupees. Each packet has 5 wires, and normally we need around 3 packets, so it's around 3600 to 4000 rupees for each year. So once we insert the double-edged needle, then we lift the framework of the silicone block. Are you able to see this?
Yes.
And the knots will be tied on the under surface.
What is the size of the stainless steel wire you told?
40.
4?
40. There are some companies which are now manufacturing PDS 40 and 50 with straight needles at each end. There is a company in Turkey which is manufacturing PDS sutures, and again you can contact me and get the details from me. Yes, with sutures you have to tie knots at the base of the framework. With stainless steel sutures you tie knots like how I am doing, by twisting the two ends together like in creating a IMF. So this not only saves a lot of time, but it also creates a framework which is very stable. I will show you the stability of these pieces once I fix the helical rim. See how stable it is. There are some concerns that sometimes people have about extrusion of these stainless steel wires. So if at all you have a silicone stainless steel coming out from any point in the ear location, you can just use a small mosquito forceps and pull it out. So it is not a major thing. So if you see the stability of the helical rim on the base frame, it's not going to move. So I am going to cut the length which is extra, and with a 15 number blade you have to tuck in these knots into the framework so that they don't jut out or hurt the patient. Just make sure all the knots are buried into the framework with a 15 number blade. So this is the first step where we have fixed the helical rim to the base frame. Is this visible? So now we go to the second step, which is fixation of the Y of the anti-helix. Y. Marking pen. So I am going to see where the Y is going to end, and I am going to trim off the excess portion of both the limbs. Wire, please. Wire.
Dr. Mohit, can you hear? Yeah.
Hello.
Dr. Mohit?
Yeah. Can you hear me?
Yeah, we can hear you very nicely. How far you have gone?
I have marked the vessels here and then tried to be as superficial as possible just below the follicles. But still, there is a vein here. This vein is into the fat going between the follicles. I am not sure whether this is the only vein we have. It is very superficial and it is damaged at some points. Means we cannot be as superficial for raising this TPF. I just don't know whether there is any other vein available or not. That's why I'm trying to be as superficial as possible. But it is not the ideal case scenario. So up till here it is okay. And here it is just in between the follicles and some branches are injured. So I'm not sure. Just suction.
Can you not do a micro?
Sorry?
Can you not do a micro of the vein?
I think we'll have to repair the veins at some points. You see here it is just in between the follicles. And we cannot raise it so superficially.
So I am about to fix the tragus to the
Okay, we'll quickly go back to Parag sir's OT and come back.
Yeah. Hmm?
Parag sir, over to Parag sir. Sir, can you hear me?
Yes, I can hear you very well.
Right, sir.
So I'm going to fix the tragus now, and to fix the tragus sometimes I use a small piece of cartilage because the width of the base frame may sometimes be insufficient in this area. So you can use a small piece of cartilage to stabilize the base of the tragus. Let us see. So that's a motor. I'm just seeing the availability of what all cartilage pieces we have. ये पकड़ा. नंतर यायला लागेल. फिक्स करेल. ये टॉपिक कितनी है? कनन नहीं. मगर let us place the base frame and recheck the location of the tragus. Seems to be okay. Now, for those of you who are aware of the Fermin classification, she has described a projection concept. So, to increase the height of the tragus, we can put a small piece of cartilage underneath the tragus, and at the same time we can stabilize the helical root using that piece. So that projection is something called as a P1. So I am going to create a P1 to show you. Marking pen, brush number blade. पकड़ो. So you don't need a very thick piece. of cartilage for this fixation. In fact, you want a thin piece of cartilage because it is just to stabilize the two components. It is not to add bulk to the framework. So I will use it to fix these two parts, the root of the helical rim and the tragus. Is this piece visible to you?
Right.
So this piece you can't of course use in patients who have a ear canal. Because we have a patient who doesn't have an ear canal, we can use a P1 to give more projection to our tragus. Wire please. So I fixed the tragus to the lower end of this piece, and I will fix now the helical rim, root of the helical rim rather, to the upper end of this piece. So we have achieved two purposes. We have given more projection to the tragus. I will show you in the side profile what it has done to our tragus, and it will also stabilize our helical root. So if you can see it in this view, can you zoom? Marking pen. Yeah. Is this visible?
Yes, it's visible.
So highest point of the framework, see, lowest point of the framework, and to give additional projection to the tragus, we have given a small cartilage support here, and to stabilize the root of the helical rim so it doesn't move, we have also fixed the root here. So that's how a P1 helps in creating a stable ear framework. Let us see how it is. I will refix the tragus. I want it to be slightly higher than what it is. Okay. We can go back to Mohit sir till the time I am fixing the tragus. Marking pen.
Okay, we'll shift to Mohit sir's OT. Over to OT1. Mohit sir, can you hear me?
Dr. Mohit? Dr. Mohit? Can you hear?
1 second, sir.
Please
Okay.
go ahead with.
You can split it here little bit. नहीं कर दो so that we can go because this is a very firm cartilage. Okay. And you can little bit split here also so that you get 9th excess for 9th. Okay. Then you take 9th with the perichondrium as long as, or maybe what you can do, you can first expose it, then I'll tell you what to do. Yeah, sir.
We are with you. Please go ahead.
Yeah. So I just want to show you. We give tumescent solution and then started raising it. So this appears to be superficial temporal artery. You can see? Can you appreciate?
Yeah.
So this is a superficial temporal artery. This is the anterior branch. This looks like the posterior branch. Then this vein is there, which is injured at 2 or 3 points. But it's a very superficial vein and it was in between the hair follicles. So we somehow preserved some length of it. Okay, now as I am dissecting further, I am finding another vein. The vein sometimes is far separated from the artery, and there is a vein, one more vein here. So once I dissect it to some level, I'll come back to you.
Right, sir.
Okay, you can go to the other OT.
We'll switch to Parag sir's OT.
Yes,
Over
so
to
I'm going
Parag, sir.
start.
Dr. Parag.
Yes, sir. Am I audible?
Yes, sir. You're audible. Yes.
Please zoom your.
Can you zoom in, please? So I'm going to fix these wires now, like how we did for the helical ring.
Okay. Little joke. Dr. Parag, little joke. Is almost like Bhishma sitting on the arrows.
Yes, yes. I always say that. It reminds you of Bhishma sitting on a bed of arrows. Fix that later. Remove करून घे. So normally you need 3 packets of the stainless steel sutures to finish fixing the complete framework. So let us cut off the excess lengths of our wire. Okay, I think. So same like how we folded the knots previously, I am going to fold each knot of the wire so that it doesn't poke. The main reason why you can have extrusion of wires is if you are not taken care to make sure that the knots are not poking anywhere. If your knots are well fixed to the under surface of these cartilages, usually you shouldn't have problem of wire extrusion. So make sure that you buried the knot properly. Let us recheck. Now if you see the framework in profile, can we zoom? So this is the thickness of the framework. So since each piece is around 3 to 4 millimeter, roughly 7-8 millimeters is what it is. And these two are the lowest. Can you zoom out? Marking pen. These two are the lowest points. The part which is going to get inserted into the lobule and the root of the helical rim. These are the two lowest points. On the Y, again 1 and 2, these are the lowest points. This is also low and the antitragus is at a slightly higher point. So this is the completed framework. We'll take a photo. So yes. So we can compare it with the size of the template that we had made. You have to make sure that the framework that you are making is not larger than the template, and this is how.
Can you make out the quantitative measurement of the heights with your caliper?
Yeah, sure. Quantitative, the height you are saying?
Yeah, I am talking of the heights.
Can you give me a scale? White scale, plastic scale. Zoom in, zoom in, zoom in. This is my phone. Okay, lights on. So if you check with the scale, it is roughly a centimeter. I am not sure if you are able to see this.
We are able to see.
At the highest point, is this visible?
Yeah, it is visible.
It is at the highest point, it is 1 centimeter, and then of course progressively it tapers at on either side. Okay?
Okay.
15 number blade please. I am going to do some fine tuning of the framework. We can go to the other OT if you want for 5 minutes.
Right. We'll switch to OT1. Mohit sir's OT. OT1, can hear me?
Dr. Mohit? Dr. Mohit, can you hear us? Hello?
Sometimes we can put a additional wire to stabilize the framework. हाँ बना सकते हैं बनाएंगे तो
No, sir. Not yet.
Can we show this step?
Not nothing in
Am I audible?
Yes, sir, you're audible.
So for additional stability, if you feel that the pieces are not stable enough, you can put another wire, which is going to stabilize the helical rim and the base frame so that they don't move when you apply suction. I will put one more.
इसको you can superficially buzz here, no problem.
You can put it as a small figure of 8. And tie it at the base.
So this is okay. यहाँ पर मैं ये अगर ये यहाँ तक भी आ रही होगी ना, एक काम हम कर सकते हैं, इसको इस वेन को ले सकते हैं। लेंगे ही तभी तो। एक मुझे उधर आ जाता हूँ। सीजर्स, एक सेकेंड, मैं इधर आ जाऊँ संजय। यहाँ घास देना, घास। नहीं 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 अभी ठीक।
Am I audible?
Yes, sir, you are audible.
So I have inserted additional wire here to fix the inferior crust with the helical rim, because these two were moving. So this has also become stable now. Now if you want, you can also create a few holes in this scapha area for better suction. 18 number needle. So we'll create a few holes. That helps in better suction effect. So you can create a few punctures in the scapha or in the lower part. In the triangular fossa if you want. Marking pen. Now I call this as the final touch. So if you see here, it has to be circular. It is the base of the concavity of the scapha as it continues downward. So we remove a little bit of cartilage from here. So this is what enhances the antitragus. Are you able to see this? So marking pen. When the skin redrapes in this concavity, you will see this as a circular depression, and you can always trim a little bit of this cartilage so that it merges with that concavity. Gouge, please. So this is what I call as the final touch. So now I am happy with the way the framework is, and we can go ahead and insert it in the pocket. Any questions regarding the framework?
Any questions from the audience?
So we'll keep this framework in betadine, which has a little bit of gentamicin. So the ear goes for a small dip because it is time of Mahakumbh. So we ensure that the framework also gets sterilized, and we go now to the. We can shift to Mohit Sharma sir's OT till the time we organize.
Okay, over to OT1.
Local drain cut केलं, hole बनवलं drain. I think you take it a little bit to this side so that it gets the surgeon's view. Can we?
Hello, can you hear me?
Head high.
Yes, sir, we can hear you.
I have nothing great to show to you right now. So the thing is, this is the artery. This is one vein which is there. It is injured here. I am trying to repair it. There is another vein which is going behind. Now it is just like looking like occipital kind of drainage. We will not be able to use it. So probably we'll have to sacrifice it somewhere here and then use the TPF based on this existing vein. That's what our thought is. And that is what is making me slightly uncomfortable. Let's see. Thank you. Okay. Give suture.
Long forceps, please.
हैं? माइक्रोस्कोप तो आइडियल है. अगर मैं उसको करता हूँ, लूप से लग जाएगा वैसे. मैं देखता हूँ.
What is the BP of the patient now?
कर्व्ड है क्या? कोई कर्व्ड वाला?
What is the BP of the patient now? Dr. Mohit?
Sorry?
What is the BP of the patient? Is it high?
129 by 60.
Okay.
You can just cut it here. Cut off. Hey, 1 second. 1 second. Just cut it. You cut it here. Near my thumb. Hey, you have cut my glove. 1 second. See, just a minute. हाँ हाँ तो इसको हाथ से उठा लो और हाथ से उठाकर मतलब just go underneath this. हाँ 9th. हाँ 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 ये लो. Sister, take this. Give me microphone, sir. एक सेकेंड यार, एक करना तो है. एक यार, एक ही वेन है वो. सक्शन. एक सेकेंड सक्शन करना. आइडियली तो 1 सेकेंड रुको. ठीक है, ये यहाँ तक है ना. ठीक है, इसको रिपेयर कर देते हैं एंड देन वी रेज इट. इसको माइक्रोस्कोप में रिपेयर कर देते हैं व्हाटएवर, है ना. एंड इसके साथ यहाँ तक डिसेक्ट करके इसका पॉकेट इसको दे यार. जस्ट पुट इट इन द. देन यू टेक 90 if you can take. And let me just remove this thing.
Can you, Surya, can change to...
I'll dissect all around. ठीक है, कर देंगे इसे.
We'll go back
कर
to
देंगे.
Parag sir's OT. Over to OT3.
Mosquito. Am I audible?
Yes, sir. You're audible.
So I'm going to insert two suction drains. 15 number blade, this fresh blade.
Zoom in, please. Dr. Parag.
Yes, sir. Yes, sir. I'm listening to you.
What I mean to zoom it, we are in the other operativity zoomed. So please, you do it
ये
here.
वो बराबर था अभी. यही बराबर था. या सिस्टर आप मॉप करो जरा. ब्लड आ रहा है ना, वो मॉप करो. Zoom out. Yes, is this visible?
So it's visible.
So I use silicone tubes which are 14 French in size. There will be two drains.
Yeah, now
One
it is
will be in
clear.
the post-auricular space and one will be in the concha. Next, please. So let us put a right angle, long forceps. We will first insert the drains properly in the pocket. Can I get a gauze piece? Gauze piece and cautery. Cautery. ठीक है ना? Relax. Okay ना? It's okay. ठीक है. Framework. I'll come on this side. Can we keep this in the center and दूसरा gauze piece? Better, yeah. I'll go on that side. Vertical. ये ले लो तो. So when I am inserting the framework, camera is moving. My head is coming. खाली रखो. Long forceps था ना मेरा. अभी वर जाता है. बरोबर नाही लावत तू हात. कॅचपॉट ऐवजी ना राईट अँगल लाव. ठीक आहे. आय थिंक लावले. इथे लावा हो. थोडं काढतो. 15 दे. 15. I'll reduce the length of the lobe a little bit. The view is little oblique. Is it proper? I am reducing the length of the lobular part. What is going to get inserted into the lobule. Okay, now we put the tragus. Looks okay. Let us check the drain वरती आला. Let me go to the other side. एक periosteum elevator दे. I have to make sure that both the drains are exactly where I want them to be. One drain is in the yes, and second drain दाखव. In the concha. है ना? Both in the concha. वरती नाही. हेच बघायचं असतं assistant मध्ये. चल, चल. थोड़ा सा सलाइन लो हाथ पे मारने के लिए. So I have just positioned the drains, Gosti's please. One in the post-auricular area and one in the concha. 20 Y3 and back to grass. Marco dolphin.
Sir, you always use 14 number drain?
Small dolphin.
Hello?
Sorry?
You always use 14 number drain?
I always use the same drain.
And you always use same type of skin incision or any other approach?
No, it is never the same incision. It is as per the Fermin classification, which I will explain to you tomorrow. It depends on the type of microtia that the patient has. So for each type of microtia, there is a different incision. The incision that we are using today is called as a type 2 incision. I am just making sure the lobule is properly inside in the. ये निकालो सिस्टम में मांगूंगा तब दो मैं मत मुझे रिलीज दीजिए.
And you keep drain for how many days?
चिनुक वगैरह काय पकड़ो चिनुक लो. फोर्सेप दोन लॉन्ग और छोटा. ओके रिमूव ट्रेजर लाओ भाई चलो. अब बोल रहा है 20 Y3. So to stabilize the tragus, I am going to take a stitch here through the skin.
Okay. If the patient wants to have a ear piercing later, do you still have the same approach?
Yes.
The cartilage goes into, yeah.
Yes. I normally create the piercing in the second stage.
Okay.
You go through the cartilage, or
Okay.
if you have a little bit of lobule which is devoid of the cartilage, you can use that portion.
Okay.
We routinely do ear piercings for all our female patients.
Okay, right. Is the second drain which is going to the conchal area, is it going under the framework?
It is going from under the framework in the lobule area to the concha.
Okay, right.
Yeah, it has come. एक catfall लगाओ. I'll show you. एक suction भी दो मुझे. इसे catfall आ रहा है. I am not sure if inside of the pocket is visible to you.
Partially seen, yeah.
So this is my drain.
Okay, right. You
Yeah,
can see
which
that
is
nicely.
in the conchal area.
Yeah.
Remove. 40 monochrome. Now there is a lot of excess skin that is available there, and we have to make sure that it doesn't come in the way of our framework. So I will see where we can adjust that skin. Check करेंगे. So mosquito कुठे गेला? This is 40 monocryl.
Yeah.
हमारा नहीं है. कुठला बघ आहे. Suction करा.
Sir, you keep the drain for how many days?
There is a question that how many days you keep the drain?
2 days, 48 hours. I empty the drain 12 hourly.
Okay.
Recharge it. It's a normal Romovac suction drain number 14. And I remove it on the 3rd day morning before discharging the patient. All patients get discharged on the 3rd day.
There is a question for you, sir.
Yes, sir.
Sir, what is the pressure you create? Do you do full negative pressure or do you do it partially for 14
Full
number
negative
10?
pressure of the Romovac suction drain, nothing excessive. Whatever pressure the suction drain gives, only that. Nothing special.
Nothing special. And sir, can we use single drain also, which is transversing to the trigger, to the concha as well
You can use
as?
a single drain, but a single drain may not cover the entire framework, and coaptation of the skin is very important. We don't want any part of the skin not to be adherent to the cartilage. We don't want any collection inside this. Mop करत राहते हैं. So I prefer 2 drains because one will drain the conchal area and one will drain the post-auricular space.
So can mini-vac be used?
Sorry?
Mini-vac, sir.
I am unable to make out.
Mini-vac, sir. Mini-vac drain.
Mini-vac, yeah, you can use mini-vac. Some patients also use, some plastic surgeons also use vacutainers. You can put 2 vacutainers instead of the Romovac suction drain for suctioning. But then the pressure has to be good with the mini-vac or with the vacutainer. You will have to keep changing it every 6 hourly, 8 hourly probably.
Thanks, sir.
What is the post-op advice in this case?
The post-op advice is not to sleep on this side for at least 1 month. They have to use a soft pillow when they want to sleep.
So these are kids, so how they can obey this type of advice. That means sleeping on, not to sleep on that side.
Yes. You can tell them to use a soft pillow so that even if the child sleeps on the side of the operated ear, it doesn't cause too much pressure on the framework. Or you can ask them to keep a pillow on each side of the head so that the child is not able to turn the head too much. A little bit of pressure is fine, but 8 to 10 hours of sleeping on this ear is not a good thing.
Can you use your sharp foam, no? So elastic foams are available. So yeah, that foam can be used and keep it in position so that in child also it will not matter much.
Correct. You can ask them to use a foam or a soft pillow, sir, and that is really very helpful. So after finishing around 80% of my skin sutures, I will apply suction to the framework, and then we will see how the skin is redraping, whether we need to trim any part of the excess skin. That decision I will take in some time now.
Sir, you are using monocryl suture?
I am using 40 monocryl, sir. Yes. You have to cheat a little bit on the closure because one end of the skin has too much of excess skin and the lobule part has a limited skin. So you have to take like army navy sutures or a little bit of cheating sutures to adjust the excess skin.
There is a question for the superior part of the helix, that the hair bearing of the scalp. So what you have decided for it?
If you can see, the extent of the hair is not much, it is hardly like 3 millimeters. So when you raise the ear in the second stage, you can just excise the hair roots here, and that's the end of it. Nothing needs to be done. If you have in-house hair laser, you can keep doing hair laser sessions between the first and the second stage. So that also is one way of removing the hair, or you can also in fact do direct excision when you do the second stage. Only if the hair bearing skin covers more than 50% of the surface, then it's something you need to deal with.
Okay.
There was a small buttonhole in one area where the skin was very adherent. Let me take a suture there also. It's right here. I'm not sure if you can see it. Can you see this?
Can we pan the camera?
Just.
Can you see this?
Yeah.
So I'm just taking a monocryl suture there to close off that rent. Now what I'll do is I'll apply the suction to this framework to see how the skin is getting co-opted. and if any modification needs to be done. I have not closed the incision completely. There is still some space for me. Adi Satyam. Don't small tooth forceps. So my assistant is going to apply suction to the framework now. So let us see how it is going to look after the suction is applied. Yeah. So I have connected both my drains to the suction tubing with the help of 18 gauge needles. And now once the suction is applied, the skin has started to drape into the contours. Of course, this is still not the final thing. I need saline. Got it. So there are still some areas where I need to do the suturing. This was just a brief, trailer of where I want the skin to drape into. Too much zoom out. Is it visible?
Yeah.
Can we have better light?
Can we zoom in?
Hello. Dr. Bharti?
Yeah, tell me more.
Yeah. Now I am in a bit of some clarity. I'll just show you.
Yeah.
Okay. So we have dissected the whole TPF. Now this thing is, just give me a forceps. So this was the vein which was very superficial between the follicles.
Yes.
So as soon as I incised, it got injured.
Yeah.
So we just wanted to make sure that there is a proper vein which will drain this flap. Then we found this vein here, and many times this venous drainage of this flap, the draining vein is totally separate from the artery.
Yeah, arterial course.
And then there is a very good vein here. This is going in this direction, and just do suction. And then coming and again turning back and then coming up till here.
Okay, right.
So I had to go all around this thing and then come at this level in the ear.
Okay, right.
So we will take this vein.
Okay.
This vein.
Yes.
You can see that?
Yes, we can see that.
So this vein we will take. This is another vein, and this is the artery.
Okay.
Posterior branch and anterior branch.
Right.
So we are just going to take a huge flap.
Yes.
Including this vein, and then we just dissect the skin now here. Create a pocket, and then I'll just give some talk about the costal cartilage.
Okay,
also.
right. Is your method of harvest different from Dr. Parag's?
I think I have not seen Parag's method.
Okay,
Parag
right.
is, I think, done also.
Yeah, finished.
I can see his nice job.
Okay.
But method remains more or less similar. Give me the tumescent solution.
Okay, we'll switch over to Parag again for his final touch before coming up.
Are we back in this OT?
Yes, we are.
Okay, sir. So I am just taking the few remaining sutures. So there is a excess skin pocket which I marked to show you, which is here.
Yeah, I can see that.
So it is very tempting to excise this extra skin pocket, but it is not advisable in the first stage.
Yeah.
Because you already have an incision here.
True.
And if you take an additional incision here, what happens is this intervening skin area becomes a little precarious in terms of its blood supply.
True.
So better idea is to do this excision under local anesthesia between the two stages, or you can excise it even when you are doing the second stage.
Okay.
So I am just making the closure a little bit more watertight. थोड़ा mop करो. No. Change करेंगे. Now sir, पहिला काम मारता.
Have you any time used a bolster suture like Nagata does?
No, sir. I
On the
think you
top.
have to be a very brave man to use bolster sutures.
Okay,
and
right.
I am not that brave.
Okay.
But I do use sutures to fix the tragus, like what I did here.
Okay,
I will
right.
probably use one more suture to fix the tragus at one more
Okay,
point,
right.
because I am not happy that it's still moving.
Okay.
So let us see.
How do
But
you
the
counter
suction
the?
has-
Yeah.
Sorry?
Yeah. Go
No,
ahead.
no, sir. Please, sir.
How do you counter that tendency of that earlobe is always to rise up a bit
Like this.
curved?
To rise up here.
Yeah, the earlobe, yeah, always
So
tends
one
to
of-
curve up.
Yeah. So one of the trick is to ensure that your cartilage
Cartilage
goes
reaches
right,
up to
right, right up to the base of the earlobe.
Okay, right.
Yeah, that helps.
Okay, thank you.
Well, you have put in the gauge piece. Can it not with a button from the shirt of the patient? Usually put a button there.
A bottle here.
Button.
Button
Sure.
here at
Yeah,
the
yeah,
lobe.
I know that gauge piece you have put in for the.
Here.
Yeah, that one, yes.
I'm going to put one more suture here to fix the tragus.
So you can put a button or you can put the foil of the sutures also.
Yes, I put this kind of bactigrass, a small roll of bactigrass to hold the tragus in place. Long forceps, bactigrass.
So we can see the scalp hairs over the upper part of the reconstruction. So at what stage we are going to deal with this and how we are going to deal with this?
Yes, already explained, no? The best.
So you don't really need to do anything if the ear hair-bearing skin is less than 10% of the ear framework. So if you just have a few follicles here, there are two options. One, when you do the elevation, when you take an incision here, you just raise up the skin and excise the root of this hair-bearing portion of the skin, and that's the end of it. You suture it back along with the skin graft. Or if you have a diode laser, you can give a few sessions of the hair laser here, so that while the patient is waiting for the second stage, you can get rid of these hair. छोटा करके जरा बोलते scissor भी. So I am putting one more bolster suture at the base of the tragus. These can be removed 7 days post-op. So let us see one more time. Small forceps. So this is the highest point of our framework, right here. And I want each of you to see the ear of the person sitting next to you. And you can see that this is the highest point of the ear. So the point adjoining to this is this, which is the highest point of the helical rim. Then the root of the helical rim, which is right here, and the base of the lobule, which is right there. These are the lowest 2 points. So 2 lowest points, 2 highest points, and of course the rest of it is something that has already been done. So we now fix the drains. We are almost done. I will pack the concavities with a little bit of Vaseline gauze here also and in the scapha.
So what about the external auditory meatus? Can you show there if it is there or not? It's not there completely?
There is no, the patient does not have an external auditory meatus, but we have created a tragus which gives the appearance that there is a canal inside. As I said, whether you can create an external auditory meatus or canal, it depends on CT scan findings, and you can't really do it in each and every patient. So canalplasty is something which is not possible in each patient.
By the way, this is little lighter question. What type of hair cutting he should have?
What kind of
Hair cutting he should have after this.
hair cutting?
Yeah.
So in my hospital there are OT assistants which have devised their own hair cutting techniques for patients of microtia, and anything which removes around 2 inches of hair bearing portion here, trims the hair in this area, is good enough, so it doesn't come in the way.
So
You
Kohli
can
type.
take a photo of
Kohli type. Virat Kohli type.
huh? Bada Didi. We'll take a photograph and then we do the dressing. Come slightly on this side. Zoom. Keep the phone parallel to this axis. Correct. Good. No, it's fine. Can we get the light back on? Yeah, light. Okay. So any questions regarding the framework or anything else? Bactigraphs cut correct? Six.
When you plan for the second stage.
Normally 6 months after the first stage. I wait for 6 months between the first and the second stage.
And how do you execute the second phase or second stage?
So in the second stage, normally I use the Fermin's technique D, which is a tunnel which is created on the post-auricular space. And in that tunnel we place the banked cartilage piece. So it avoids the need of using a temporoparietal fascia flap. Unless the opposite ear is very prominent, we don't really need a temporoparietal fascia flap.
Any more questions? Rasmi, you give some concluding questions.
Ointment hai?
I have all doubt clear.
Huh?
My doubts are clear.
All doubts are clear?
Sir.
So Dr. Paras should be a great job. Huh?
Thank you, sir.
We have
Thank you.
cleared all the doubts of everybody. No questions.
Thank you, sir. Thank you very much.
Announcement for the mini auditorium guest. The lunch is ready, and you can have it in the dining hall as and when required.
Search करो. Ointment, mupirocin. Tincture benzoin है. Tincture benzoin है. Tincture. Ointment. On third day, and this after 7 days. Yes. Just a normal mastication. Normal mastication. No stick or nothing. Mupirocin ointment. Someone has gone to get mupirocin. Okay. Sure. Hmm? कोई गया लाने को है मुझे रोशन open. So I like to put some ointment on the bactigrass. Huh? Am I audible? Am I audible?
So we have a doubt, sir.
Yes, sir.
Parag, sir?
Yes, please. Am
Yeah,
I audible?
yes, you're audible. How long will we keep this dressing, and when do we open? When will we be doing the first dressing?
We open it on the third day morning.
Okay.
I keep the drains for 48 hours.
Okay.
And remove the drains on the third day morning and discharge the patient.
Okay.
And sir, during discharge, what kind of dressing will we advise patient?
A mastoid dressing.
Okay.
You can put a bactigrass on the ear, a little bit of fluffed gauze, and a mastoid dressing.
There is no need to put dressings in the contours.
No need.
Okay, sir.
The skin has already coapted in those 48 hours, so it doesn't really need any more packing of the contour. Filter eye and 4-inch micropore.
Sir, one more doubt. You have used monocryl sutures, right? So
Yes.
we need not remove them, no?
You need not remove them, yes.
Okay, sir.
I'm just putting a little bit of fluffed gauze, and on top of that we'll put some micropore. Micropore, please.
Hello, sir. Sir, Parag sir.
Yeah.
What all advice will we give patient during discharge? How frequently we have to call them?
I call the patient back after 7 days.
Okay.
Can you check this, no?
And regarding the cleanliness and all those things,
They have to start taking a bath. Cut one more. Same thing. They have to keep taking a bath every day after the 7th day. And I give them chlorhexidine shampoo sometimes, one more, to wash their hair. One more.
okay, sir. Thanks a lot for.
Thank you.
Yeah, thanks a lot for demonstrating such a beautiful surgery. Now we would like to switch over to the other OT, OT1.
You want to go to the opposite side? One more micropore. And 14 number Romovec drain. एक ही दोनों ट्यूब लगेगा इसमें। Bandit, do you want to disconnect the tube? Do you want to disconnect it? I am going to lift the head. 4-inch bandit. हा चांगला आहे. हे काय हे पकडू शकतो.
Parag sir, can you hear me?
Yes, I can.
Dr. Bhandari is here, sir, wants to speak to you.
Dr. Parag, good morning.
Very good afternoon, sir.
We just reached. You're through very fast.
Yes, yes, sir. We are done. Just doing the dressing now.
Okay. And what about Mohit?
Sir is harvesting the temporoparietal fascia.
Okay. All right. All right. So you'll talk to Mohit then. Okay. Okay. Great.
Over to OT1. Can we switch to OT1? OT1, Dr. Mohit. Am I audible in OT1?
Micropore. और एक
एडजस्ट कर लेना आज ही नहीं में डायरेक्टर का ये है
14 नंबर होमवर्क, 14 नंबर ट्रेन.
Hello. No, we have not gone to.
ये ले लो सर. Micropore. Can we remove this? No, just sticking. I'll keep it like this because I have to fix the drain here. This is okay, na? Micropore. Ado, asan uba. So you just have to cut the knots and remove the drain and change the dressing on the third day. Here we will put a Dynaplast dressing. Itla karto, chesta kartos. Okay? Sure. No problem. Sister, instrument, thank you. Instrument autoclave करके रखिए कल के लिए. मैं यहीं पे रख के जाऊँगा. कल लगेंगे. The gloves go to which bucket? Thank you. Can we remove this? So was it something new for you? Was it something new for you? Yeah.
बता दीजिए
और
फिर
एक
check
रिफ्रैक्टर
करते हैं। Yes, you can give a ring and you can tell the हाँ मैं कौन हाँ will call you call कहाँ फोकस कर रहे हो तो लाइट कहाँ फोकस हुआ है
देना आटे
मार्कर को निकाल के दो
एक में देना मोनोपोलर ठीक है इतना ही चाहिए होगा इतना ही चाहिए इससे ज़्यादा नहीं चाहिए
नहीं चाहिए
ठीक है नाइफ इसको बस ऐसे हम विल बी वेरी जेंटल ऐसे इंसाइज करके ऐसे आ जाते हैं एंड सत्ताईस साल में एक अलग प्रॉब्लम है 8 साल में एक अलग प्रॉब्लम है अच्छा देना एलिवेटर आप खाली इसको यहाँ से आप धीरे धीरे जाओ जेंटली इस लेवल पे और इन सबको ऐसे फोर्सेप से पकड़ो और इसको एलिवेट कर दो ऐसे जल्दी हो जाएगा ये पूरा एलिवेट कर दो उसके बाद पीछे की तरफ हम बहुत केयरफुली एलिवेट करेंगे अब ठीक है पहले आगे का कर दो दोनों तरफ मैं इधर आता हूँ ठीक है नाइफ नाइफ ये यहाँ पर ये अपनी वेन कहाँ है ये देखना पड़ेगा हमें ये वेन है ना यहाँ पर है अब हम उसको लगाते वक्त जब इस इंसिजन को लगाएंगे ना तो हमें उसको डैमेज नहीं करना ये मैं सोच रहा हूँ ये इतनी स्किन बचाने का कोई वो नहीं है इसको हम यहाँ से आकर है ना यूँ कर देते हैं ये कहाँ पे आ रही है ऐसे आ रही है ना दिस इज़ कमिंग हियर तो हम टॉप तक ले आएंगे और इसको हम यहाँ पे काट देते हैं इस जगह पे है ना ये कहाँ है ये है सक करो अब मुझे ये है कि मैं इसको जब तक उसको देख नहीं लूँ, बहुत ही एक टेक्निकली इसमें जो चैलेंज आया है ना, वो थोड़ा सा अनयूजुअल है, ऐसा होता नहीं है, सबको सामने होता है। गिव मुझे वो दो। इसको रिट्रैक्ट कर दो सिस्टर, मैं उसको देखना चाहता हूँ अब पता पड़ा कि उस वेन का बैंड नहीं बजाते हैं। सिजर्स। longer tenotomy. सखिए, बहुत ध्यान से, धीरे से, because I can injure it in no time.
एक रिट्रैक्टर मेरे को देना इधर।
Yeah. ठीक है, दिखा। This is cartilage है। हाँ, cartilage है ना ये bond। Hook please। Mom. Hook please। Yeah. Can you remove this thing? It is troubling me badly. This, it is creating serious headache.
Can you hear me? Hello? Can people in the auditorium hear me?
Hello. Hello.
Hello, Surya?
Yeah, I can hear you.
Yeah, okay.
Hello.
Hello.
Can you hear me?
Yes, sir, we can hear you.
I am raising the temporoparietal fascial flap.
Right, so we can see that.
So just underneath is the deep temporal fascia, which is the covering of the temporalis muscle. So we are going above it. You wait, please. So this is the deep temporal fascia. ये काट नहीं रहा है blade.
Surya, are you able to see?
So we are able to see that. Yes, it's invisible.
So this is a vein which we have preserved. This is one vein and this is the artery. Does it track here? Yes. You blade, please.
So you don't include that him going to the hospital later?
Yeah, pata hi hai. Not
Yeah, so I am raising it. You can see the deep temporal fascia.
not please. I have tried to speak. ये क्या है? मेरे को नहीं आ नहीं, इसके ऊपर है। ठीक है, पकड़ो।
Mohit sir, can you hear us?
Hello?
Yeah, can you hear us?
Yes, yes, we can hear you.
Someone wants to ask.
Am I audible?
Yeah, you are audible. Someone
Good,
wants
great.
to ask a question.
Yeah, I'll give it to Mohit sir.
Yeah. Please tell me.
Yeah, good afternoon, sir.
Okay.
Sir, my question is regarding the width of the flap which you are raising, operative fascia. So, what should be the width ideally, and what should be the position with regard to the midline across?
I'm not hearing.
So, can you hear it now?
Sir, your voice is not clear. A little bit louder would be great.
Can you hear me?
Hello?
Yeah, am I audible?
Yes, yes, yeah. Now the volume is good, yes.
Hello, sir. Can you hear me?
Yeah. Yeah.
Yeah, sir. The question is regarding the width of the flap at its base, and the second part is what is the position of this margin of this flap with respect to the long axis of the ear.
See, the width of the flap should be narrow, but in this case, here is the artery and there is one good draining vein on this side. This vein we injured somewhere here. So that's why, otherwise I would have kept it something like this. I would have cut it from here. But now to be on the safer side, we are using it like this, and just leave it. Just leave it. It might come in this fashion, and this will cover the whole ear framework in this particular fashion. Okay.
Yes, sir.
And the framework will come underneath. This will be attached, and then the whole framework will remain elevated, and then we will apply a section. This will become only clear when we just fix a framework here and then wrap it around it. But this looks adequate right now. It is coming up to here, and just because of a good vein here, I have kept the width also broad to be on the safer side.
Okay, Mohit.
So artery is here, and one good vein is here. This vein is damaged, so that's why I'm not taking any chances. Okay.
Mohit?
Sir.
I In absolute terms, what is the measurement?
What?
The dimensions of the flap, I mean. And what is the minimum you will require for a covering a reasonable?
Sir, it varies from case to case.
Yeah.
So here, how much skin is available
Yeah.
and how much framework is going to be exposed, it all depends on that. Here it's going to be total framework from front and behind.
I know.
So that's why we have taken it very broad. It's like this.
Yes.
So let's see when we carve the framework, which is also difficult in this because the cartilage is very brittle.
Oh.
So I will struggle in carving also. Okay. We started also very late, so that's why we are running slightly behind schedule. So we will end up discarding most of this bad skin, and the total framework will come here, which will be covered, and then we take a graft from the scalp.
Right.
So long way to go.
So in cases of burn patients requiring reconstruction of ear, so what is your experience? Does the cartilage get ossified earlier than in comparison to healthy patients who have not suffered burn?
Sir, can you please repeat the question once?
The question is regarding the costal cartilage which we are going to harvest for reconstruction of the ear framework. So I want to know about the experience of Mohit sir with regard to this. Has he observed, or is this observation that cartilage in patients having suffered burn injury, they get ossified earlier in comparison to similar age or stature patients who have not suffered burn?
You are right. It is already looking highly ossified. But I don't know whether it is ossified in 6 months. Okay. So she is 27 years old.
Yes,
so
sir.
that's why it is ossified anyway. Anyway.
Sir, I have one more question regarding the flap. Mohit sir, can you hear me? Hello.
Yeah, ask, I'm hearing.
Yes, sir. Sir, is it possible to cover whole of framework with this sticky fascia, or we need to use something else also to cover the distalmost part or some part of the cartilage framework?
If CT fascia is not there, then you can use the deep temporal fascia.
No, sir. Sir, is superficial temporal fascia enough to cover the whole length of the cartilage framework which we are creating?
Yeah, that we will see in 1 or 2 hours. It should be enough.
Yes. Thank you.
Dr. Mohit. Dr. Mohit, can you hear me?
Yes, sir. Yes, sir.
Dr. Mohit, good afternoon.
Good afternoon, sir. Welcome.
Just had my lunch. So you are through with the temporoparatal facial flap?
Yes, sir.
And you are now on to costal cartilage.
Yeah, we are struggling with the costal cartilage. It is highly ossified.
Looks calcified.
Yeah.
Looks calcified, and you take always with subperitoneal dissection.
Yes, sir.
And then ultimately whatever is left behind, you make a pocket and fill it up.
Yeah, ultimately whatever the leftover cartilage is there, we put it here.
Right. Absolutely fine. And she's a female patient.
Yeah.
And you give some mammary incision.
Sir, she had a contracted ball scar, so we have given a bigger incision because there is a huge scar.
No, Dr. Mohit, what I have seen, if you plan to give incision in the submammary area, you have to give very large incision because the 8-9 spaces are lying very far off, so you have to give a very big incision. Hello, can you hear me, Dr. Mohit? Dr. Mohit, am I audible to you?
Dr. Mohit, can you hear? Dr. Mohit? Dr. Mohit, can you hear?
Hello? 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 আসলে হবে?
Yeah, can you hear us now?
फिर भी noise आती.
Hello, Dr. Mohit, can you hear us?
Hello?
Hello? Am I audible to you? Hello?
Hello?
This mic is talk here. Hello? Speaker টা কাম করছে কি? Speaker লাগাইলো?
Hello, I'm audible. Hello, hello. Audible? Okay. Good.
Hello?
Just a minute.
Can everyone hear me? So anybody wants to ask any question, we can discuss it out while you're taking out the cartilage. So we can discuss out. So if you people have seen temporoparietal facial flap while he was harvesting. I think everybody has seen temporoparietal facial flap. And I was not here, but I understand temporoparietal facial flap when you're raising, there is no plane between the skin and the fascia. I hope you understand. You need to make a plane. So I will always inject Edlin saline in the plane, means superficial to the fascia and deep to the hair follicle. Unless you inject over there, it is extremely difficult to raise it because there is no anatomical plane, that is one, and it bleeds a lot. So I will always inject Edlin saline. I usually give 0.5% Zalocin with Edlin, next to 1 in 200,000 Zalocin. Everybody uses 205 Zalocin. So once I have injected in that plane, I literally wait for 20 minutes. And then I come back when you are raising the flap because there is absolutely no plane. You have to actually make the plane. And the vein is on the surface of the fascia. If you are not careful, you can injure the vein. It is lying exactly just below the hair follicles and on the surface of the fascia. So you have to be very, very careful, and quite often, if it is hemifacial microsmia with the deformity of the ear, sometimes you won't find the vein also. It quite often happens. So if it is only purely microtia, it is most of the time the vein is there, otherwise difficult to find the vein also. So and by any means it's not possible to find out whether the vein is present or not. You can Doppler the artery, but it is very difficult to find out the vein. Hi, how are you? You were just discussing temporoparietal fascia. Great job done. So I think Dr. Parag has done a wonderful job. Please, a big applaud for him. Excellent job done. And it's done very fast also. So we are discussing temporoparietal facial flap. So it's very difficult to raise a temporoparietal facial flap. You give injections, wait for 15 to 20 minutes. I wait for 20 minutes and start raising it. Look for the vein. The literature says the Chul Park is from Korea. He's written an article of 123 temporoparietal facial flap. I've also done more than that. He says the vein lies anterior. In IM experience, it is always posterior. Always posterior. Difficult to find the vein. So once you have injected, you raise the flap. You can give a invert. You can give a Y incision. As of now, people start giving 2 transfer incisions. I feel comfortable. We have a good exposure. I give Y incision. Go. I have a lecture also. I'll explain to you. Go just deep to the hair follicles, but don't expose the hair follicles, because when you're raising it, there must be fat globules in the hair follicle, around the hair follicles. Otherwise, you will have alopecia in that area. So you inject Edlin saline, raise the fascia just below the hair follicles with the fat globules raised up, and you can clearly find the glistening fascia with the vein superficial to it. The artery is embedded in the fascia. So usually there is no, the artery is not in danger, but vein is always in the danger. And you understand there are multiple tributaries of the veins. So vein is going like this, and the tributary is going at right angles. And now if you are cutting through the tributaries, but the distance of the tributary from the vein to the skin is very little, it's 0.1 millimeter, 0.2 millimeter. If you don't cauterize, you can see the capillaries, the tributaries coming to the vein. If you don't cauterize those before you cut it, there will be a rent in the vein, because the distance is very little. If you cut it, it will retract and into the vein. And then if you have a rent, if it is 0.1 millimeters, how would you stop it? You cannot cauterize the wall. You have to suture it with 8 or 9O. So you have to be very careful when you're raising the skin or subcutaneous tissue from the fascia. Once it is done, around 12 to 12 centimeter fascia is required in all dimension. The undersurface of the fascia, there is a definite plane of cleavage. You can easily raise it. You have a loose areolar tissue just deep to this fascia, and then you have a deep temporal fascia. So it is so easy to raise it. And then you take out that loose areolar tissue along with the fascia. And then when you put in the graft, because the fascia will be turned like this, So the deeper surface will form the anterolateral surface of the cartilage, where it will come superficially at. So that means deeper surface of the fascia along with the loose irregular tissue. And when you apply the graft once it is taken off, graft can even be moved also. So you take the loose irregular tissue along with the fascia, and once you raise it, then it becomes very simple. And then once you have draped it, sutures all around, it has to be watertight, because you need to create the suction. And then over that, a thick split skin graft. Always a problem with the graft, because once it is taken up, it is always in dark in color. So people say, if you take it from the scalp, the color matches good. Have not taken it. In one of the conferences, Dr. Paragav also, they have taken the graft. Dr. Keshwani has taken the graft, and it turned out to be very nice. The color match is very good if you take. But you know, majority of the patients are female patients. They are not willing to shave off the head. It is very difficult. So that's all. Anybody wants to ask any question, Dr. Paragav, you want to say something?
So Dr. Fermin always used to harvest graft from the scalp. Now harvesting graft from the scalp is a lot different from harvesting a graft from the thigh. One, you need to have a dermatome. Without a dermatome, with a Humbee's knife, you really can't get a scalp graft. And the depth is just that you leave all the hair follicles behind. So when you harvest the graft, you will see tiny little hair shafts on that graft. So with a soaking or a soaked gauze piece, you just need to rub that surface, so all those shafts, they fall off. And of course within 7 days the hair grow back from where the graft is taken. So actually, if you look at it, it is the most concealed site of skin graft that one can have. And plus it gives excellent color match. I have seen several cases where Dr. Fermin used to use the skin graft from the scalp, and it gives a beautiful color match. As Dr. Bhandari correctly said, it's difficult to convince the patients or their parents that this is ideal donor site. If you have a male patient where the patient keeps the hair very short, then it's easier to convince the patient that it is just going to need a trim for 7 days and then the hair will grow back. In a female patient, of course, it's a challenge, and so that's the thing about scalp graft. Rest, when it comes to fascia, I think as sir mentioned, it has to be done very meticulously. Magnification is something you should always use when you harvest fascia, because what you see with naked eye may not give you the precision of what you need in harvesting the fascia. And if I have to harvest fascia, I always make sure that the size of the fascia is at least half a centimeter more than what you need. If you harvest fascia which is just exact size of the size of your framework, it is going to do two things. It is going to tent over that framework. It is not going to go into the contours, which is what we want. So we don't want any tenting of the fascia. And second, we don't want a closure which is going to be very tight for the fascia, because what creates problems with vascularity is the venous drainage. It's very rarely an arterial problem unless you damage the artery. But to prevent venous complications, you have to ensure that the fascia, when you apply the suction drain, it is not too strongly sucked into the crevices of your framework, because then that will impede the venous drainage. So have fascia which is slightly larger than the size of your framework, and pack it very loosely with Bactigrass, stool grass, or with fluffed gauze. Don't give too much of pressure, and keep your fingers crossed.
Thank you very much. Some question is there for you.
My question is regarding the suction train. Usually it does not hold up for beyond maybe half an hour.
Yeah.
So how do you tackle that?
If your closure is watertight, airtight, it does hold. The suction becomes a little weak by the end of the 12-hour period, so you need to charge it at the end of 12 hours. Now, having said that, you have to realize that suction is not what is going to create the shape of your ear. Okay, it is what you have carved and the projections that you are given, which will help you achieve the suction is just to prevent any blood accumulating between the skin surface on the cartilage, so that the skin coapts properly with the cartilage. So what is coaptation? Coaptation means both the surfaces, they just have to remain in contact with each other. It is not that you are actually fixating the skin with the help of the suction. That is wrong concept. In fact, in lot of centers they apply very mild suction. If you use a vacutainer, for example, what pressure it gives? It gives very minimal pressure, but that is sufficient. We don't want aggressive suction any which ways, because as I said, it causes venous problems. And plus you are going to pack the concavities with a little bit of tool graft. So you are not really dependent on the suction. If you feel there is a little bit of air escape or your suction is not getting maintained, you can always apply skin glue, ferrocrylum you can apply on the suture line to seal that suture line. It is nothing major. But as I said, suction is not the only thing. It is an important aspect of the surgery. But then I don't think it is the point determining your outcome. It is one of the points determining your outcome.
Thank you.
Well, we have two great people here in this hall. It's a formal welcome and introduction of Professor P.H. Bhandari. He was in faculty and head of department of Maulana Azad Medical College, Department of Plastic Surgery. And he is master not only, he is the master of the master as far the ear reconstruction concerned. In all the aspects as a good surgeon and a lot of publications in the different national international journals. And he is authority in that, you can tell. So we are lucky to have him in Orissa, in the land of Jagannath, as one of the guest surgeons, speaker, mentor and so and so. So you can take the advantage of having all your knowledge regarding the reconstruction of breast. So on behalf of the organizing committee, we welcome you with a bouquet of flowers. Thank you very much for coming all the way from Delhi and sparing your valuable time and giving and dissipating your knowledge to our young generations. And obviously, Dr. Bhandari name is, in 2014 we had a live operative workshop. Another P.S. Bhandari, but he is a brigadier. And he taught live lesion of about 11 cases. We had an operative session for harvesting in brachial plexus injuries. We learned, all of us learned how to harvest the intercostal nerve. Previously we were giving all grafts for different surgeries in the upper limb. But he is the person who mentored us that how you can directly harvest. So these are the tips of their whole life, dedication of learning, and that they dissipate us. So we are really indebted to all these people. And Dr. Parag, he is no way less as for the reconstruction of ear. And another Parag also in Pune, Dr. Parag Sasudri. He is a master of AB fistulae. All through he is doing national conference this month also he is having. So these similar named people and very rarest of the rare people of their masters in their own ways. So we welcome both of you. And Dr. Mohit Sharma, he is another master in as far as the heart transplant in India first time. One of the key person with Dr. Subramaniam Swami Iyer. So Subramaniam Iyer of Kochi. So we are really grateful to you two people with Mohit also that we are with us. So I think the young generation will take your knowledge and touch for the eastern part of India, which is almost I don't say neglected, but somehow we are in the rising phase. We have not achieved as other part of the country has gone. Okay, now we are proud of two people. The President of India, Draupadi Murmu, he belongs to one of the tribal village of Odisha, who have been, what parliament things are happening. But anyway, she is from our state. And we have a chief minister, he is also a tribal, and Mohan Maji. And almost the functional chief minister is no way the Prime Minister Narendra Modi. So in 1 month he has come 4 times, and by in between he has come about 9 times to Orissa. So these are all political things, but do matter in our system. Thank you very much.
Yeah, please ask questions. I would love to answer your questions. Dr. Parag is here. Please ask him questions. He's shown you excellent reconstruction today. Related to surgery, you can ask any number of questions to Dr. Parag. He'll be happy to answer your questions.
What is your preferred technique for second stage? Like you use fascia, and what for elevation what do you use? And how?
So, Dr. Fermin has described four types of elevations. So, I think let's discuss tomorrow when I show you the actual presentation. But the technique basically is divided into four types. Now, which type of technique you will employ for the second stage depends on one important factor, which is projection of the opposite ear. If your opposite ear is having normal projection, not over projected or not a prominent ear, you can do it the way Brent does it with release and skin graft on the posterior aspect of the ear. If you need moderate elevation, Dr. Fermin has described a type D technique where you create a tunnel on the post-auricular surface, insert the banked costal cartilage and fix it with sutures and then put a skin graft on top of that. And if you have the opposite ear which is quite prominent, then you need to use temporoparietal fascia. So you need a larger block of cartilage to give more elevation, cover that with the temporoparietal fascia. So it all depends on the opposite ear. Yeah.
Thank you, sir.
Dr. Deepti, I have a different opinion over here. See, I also used to elevate without graft also sometime. But I believe if you don't put any cartilage graft behind the ear, it always go back. Because the graft has a tendency to contract. It will always contract. So I believe in the second stage, putting a cartilage is must. And then depends upon you want to cover it with the post-auricular fascia or temporoparietal fascia, depending upon what is available over there. Now, once you're putting the cartilage, because the cartilage of its own will not take the graft, it is covered by a vascularized tissue. So quite often I've used post-auricular fascia also, and sometimes use temporoparietal fascia. So any of the fascia which is available over there, but you have to be very careful when you're raising the cartilage from the bed. If you plan to use the post-auricular fascia, you have to be very careful saving the fascia over there, because inherently if you go deep, then you are cutting through the blood supply of the post-auricular fascia which is coming from anteriorly. So it is turned like leaf of a book. So it is safer to raise it and raise the temporoparietal fascial flap and cover it with the temporoparietal. But Dr. Parag, what I have seen, if you raise it and don't put in the cartilage, it will always go back. And in fact, if the elevation is 1.8, which usually is there from the scalp, 1.8 to different levels over here in the mid portion, the lower portion. So I take measurements of 3 to 4 places and then put the cartilage. If the elevation 1.9, I will be putting it 2, because it will contract even after that. It will go back. So you try to make the elevation a little more as compared to the normal ear. And once you see the patient, because you always ask the patient to massage and do whatever, they will keep on doing also. In spite of that, it will contract. So cartilage, I believe, I have done many elevations without cartilage. There were another reason, working in a government hospital, I used to have waiting of 2 years. So you don't have time for elevation. GA ka time nahi hota hai. So you do it under local anesthesia, then you elevate and put in a graft. But if you have a time, if you have inclination, if you want to really do the job, you have to put in a cartilage, cover it with the fascia, and then put a graft. That is what I believe. So as of now, I will always put in a cartilage, cover it with the fascia, most time with temporoparietal fascia, and then put a graft. So Dr. Parag has a different experience. So you're happy with the, sometime if the elevation is not much, then probably it can be done. If the other ear is not much elevated.
That's what. If the other ear is not very elevated, then you can get away with. But as I said, cartilage, of course, you need to use. It is not only a skin graft. A skin graft was a part of the discussion as regards the Fermin classification. When you actually raise and put a cartilage behind between a tunnel on the post-auricular surface, you always put the cartilage first and then put the graft on top of that. Purely just the skin graft is not going to suffice. You have to have cartilage and then cover it.
Sometimes what the people have done, even if without raising, they make a tunnel, put the cartilage. Even not putting the graft also. It will only work if the other side ear is not too much elevated. You're getting my point. The ear is there, and then you make a tunnel, put the cartilage, and try to elevate it. So that will be little elevation. Sometime if you have lot of skin in the first stage, then you can put a cartilage at the same time. What वो usually होता नहीं. Cartilage pocket always falls short. And as I always mention, the cartilage carving is extremely important, but I believe more important is skin pocket. If the skin pocket is right, adequate, and if the skin which you have raised is very thin, but at the same time thick enough to survive, that is the crux. If the skin is tight, contours will not show. If it is very thin, they will die away. If it is very large, you want to have a good pocket of adequate size. That is very, very important thing. Cartilage carving to hai hi, but I believe that is the most important thing.
Absolutely. Cartilage carving is something that you will always, learn with practice and with training. It is the intelligent use of the local skin which makes all the difference. Yeah, very true.
Like you usually give a pre-auricular incision. I will go little higher to the scalp, very little, and go in the subfollicular plane. Or else you have a vestige cartilage. You raise the skin and then the same plane you go, because that is the thickness. And what I basically do, I will not put in a light from here. I'll put the light from through the skin, so I can actually see through it. It should be translucent, not transparent. It should be translucent, so there is skin and thin layer of subcutaneous tissue. So that is the thing. And then another thing what we have started doing, and there is always a perforator in this area. So you always mark a perforator. And then you dissect it out. It is extremely difficult thing, but if you can save that perforator, you are very happy to raise the skin pocket, because then the chances of marginal necrosis, I am telling you, the quite often you get the marginal necrosis. लगता है 1 millimeter का है, but then it exposes the cartilage. So the margin of error is not little, it is zero. If it gets exposed, then you will have it. Then everything melts out. So if it is getting exposed, please take the patient again and put something. Excise the skin and do a preauricular flap or whatever flap available over there. You cannot wait, because cartilage is avascular structure. It will take its blood supply from the skin pocket. And if it is gone, the cartilage will go away. And if the infection sets in, you give anything, it will not settle down. Any more questions? Yeah, I have a question.
What is your longest follow-up case?
The longest follow-up case is less than 10 years. उसके बाद तो आज तक कोई आया नहीं. It is like they have come with other patient. So that is the only thing. And I'll tell you a story. One of the patient recently, I had a patient, female patient. Unfortunately, the patient born with microtia, and a boy had come for the matchmaking. So उसने obviously he rejected her. उसको ये बोल के गया कि आप कम से कम डॉक्टर बना, इसे कान तो ठीक करवा लो. And then the patient had come to me. So it is the resorption. It is the resorption. You see, quite often happens. There is a little redness of the skin, and you are happy that it got controlled with the antibiotic. But in due course of time, there is resorption, which was little bit of infection, subclinical infection sort of thing, which got controlled with the antibiotic. You see the patient after 2 years, there will be resorption. That is one. Second, if you have not fixed it nicely, means like the Nagata uses 88 stainless steel wire. 88. So that means it has to be firmly fixed, especially the helical margin and the anti-helical margin. If it is not nicely fixed, in due course of time you will see that it has migrated, it has slipped. That was another thing. Sometimes you get exposure of the knots of the proline or steel, whatever you've seen. So that is not much of the problem, it can be taken out. So usually they come with there is something popping out. So stainless steel becomes a little more difficult. Rolling can be taken out easily, but they get exposed. Quite often, sometimes you get exposure of these things and they come to you. Sometimes they might come with the swelling. So every patient is experiencing that any redness, any swelling, any untoward thing, report immediately. because you need to start the antibiotic immediately, and if there is something which gets exposed, something needs to be done. So these are the only thing. Medpor in due course of time, जिंदगी के किसी हिस्से में वो निकलेगा ज़रूर. I have done Medpor, and I have a patient of 15 years follow-up. He came after 15 years exposed with the cartilage of Medpor, because Medpor is a very hard thing. You put in a temporoparietal facial flap, then you put in a graft. It is very hard. सोएगा तो सही ना उस तरफ. With the pressure it gets exposed. So Medpor is absolutely no, unless both side cartilage has been taken out. So then there is no option left. Otherwise, I believe cartilage is the choice of operation. You must learn how to do it. Medpor is a no thing. It always gets exposed. क्या कहते हैं आप? Have you ever used it? Medpor.
I've never used Medpor, but I've removed a lot of Medpors, and that has given me great clarity of thought that you don't venture into it.
So Medpor is a big no, but if both the cartilage has been taken out, and rarely you get a patient. Recently I've done a patient who was operated in one of the corporate hospital, and she didn't have a good result. She was not at all willing for the cartilage of the other side, not at all. We exhausted all our convincing power, but she was not willing. Then that patient we used a Medpor, because she was not at all willing. But getting was, अभी तो आजकल Medpor मिलता भी मुश्किल से है. हाँ, वो ये जो Primapor ऐसा आता है वो अच्छा नहीं है. वो and it's costing around 85,000. So that is there. So any other question? Sorry. Yeah, I'll show you. See, if the skin is actually very tight, because temporoparietal facial flap is a second choice. You do whatever you can. The graft color match is not always there.
Hello?
It is always dark. So the skin is very tight. Sometime in case of anortia, then you can put tissue expander. So tissue expander will give a good result, but then adds to another stage, and then of course the patient has to cough off money also. Tissue expander का भी cost बढ़ जाएगा. But it can be used. Tissue expander can be used. Sometime in secondary cases also, when the skin has been used and you have small skin left behind, it can be expanded.
Sir. Hello.
It is like suction, as you must have seen it today, and then dressing with the contour dressing, Vaseline gauze, lot of ointment, and then fluff gauze with the betadine. That is.
Hello. Hello.
Yes, sir, we
Sir,
can hear you. Yes, sir, we can hear you.
Chalo.
You're audible, sir.
Yeah, Dr. Mohit, we are with you. Dr. Mohit. Okay. We can hear you from remote.
They want me to eat something, so I'll eat.
Oh, please.
Sir, we have raised the TPF. This is bleeding well.
Okay.
And
We can see the vein.
Yeah, we can. This vein is behind this, and the artery is in front here.
Okay,
This artery.
so Dr. Mohit, that is what I was telling these people. I always find vein posteriorly.
Yes.
And
And
can
it
you?
is so difficult.
It is on the superficial aspect, so you can easily injure the vein. It is very difficult to protect it. Yeah.
So anyway, it has survived despite of our bad surgery.
Oh, you tried your best.
So
Good, very nice.
And then we have taken the coastal cartilages 6, 7, 8, 9. I'll just show you.
And I just want to see what is the dimension of the temporoparietal facial flap.
Yeah, I'll tell you, sir.
Okay.
Sir, this is 6, this is 7,
Okay.
this is 8,
All right.
and this is 9. And they are extremely brittle. I don't know how will we carve it.
And the eighth which will be used for the helical margin also appears short.
Yeah, it's very short, sir.
It is very short.
And it is all bony.
It is all bony, yeah.
And
Just
dimension of the flap is, I'll just tell you.
Yeah.
It is.
It says contracted also.
Yeah, it is almost, I would say, 12 centimeter long.
Right. Good.
11 centimeter long.
It must be more than 11. It is contracted.
Yeah, and then hold it.
Almost the same dimension, I believe. Almost the same.
At least 8 centimeter broad.
No, it will be 10. It is all contracted a lot.
Yeah.
So it is 10 into 12 roughly.
Yeah.
Good. And can you just show the artery in the anterior portion? Artery, superficial temporal artery. Dr. Mohit. Okay.
Sir, just a minute. Sir, artery is here. Sir, this is the artery.
And Dr. Mohit, you inject also or not?
Injected, sir. Lot of injection, but it's still bleeding. Now it is more than 2-3 hours. So
Okay.
this is the artery.
Right.
This
You
is
can
one
see.
vein.
Yeah.
This is one vein which is injured at some point here, and this is another vein.
Yeah, but that vein looks very nice.
This is another vein.
Yeah. Great.
Fine.
Okay. So Dr. Mohit, have lunch and then we'll be back again with you. Yeah, please. Can you please use the mic?
Hello. Yeah, so recently there's been a correlation that earlier the cartilage is harvested, more likely it is to resorb or change its shape. And later, in the later half, maybe in around 15-16 years of age, when the cartilage framework is made, the resorption is lesser. What is your take on it?
No, I didn't get it. Like if you take the cartilage in younger patients, the resorption is there. That's what you're telling?
Yes.
So you read it somewhere?
I heard it in one of Mohit sir's talk once.
No, I don't think I've heard anybody saying and I've read it like this. Because see, the cartilage, whether adult or young, it survives by diffusion. The vessels will not grow. If it is survived, it survived. Unless there is some amount of infection that can lead to resorption, or there was too tight of a skin, because the pressure will also lead to resorption. So these are the two important factors. Otherwise, I don't think age will make any difference in resorption of the cartilage. But usually, as the people say, it's around 7, 8, 9 years, 90% ear is grown, and you can make the ear by the age of 9 or 10 years. I personally believe in India, especially in our country, 12 to 13 years is the right age when you get the enough cartilage and thickness of the cartilage also. It is not the width, it is the thickness also. What do you say? Now in younger patients, the thickness is also not there. So you want width, length and the thickness also. So and especially female patients, see, by the age of 13 years, you get the breast mount. And I want to give incision in the submammary area. Because if you give incision lower below, it will always show, because in our scenario, you're putting on blouse, you can see the scar. I want to give a scar in the submammary area. And it is 13, 14 years when you have the breast mount and you can know the area where you're going to have inframammary crease. So the ages would be, I believe, 10, 12 to 13.
Correct. Yeah. 10 to 13, 10 to 15 rather is the ideal age. But having said that, it is not an absolute factor. It is not that you can't reconstruct beyond a certain age. You can, but then the cartilage will be stiffer. There will be more calcification. Your instruments will get blunt, and your courage will also get blunted. So it is something which is not easy. You can do it. If I look at my own patients, my oldest patient has been 68 years old. So it is not that you can't do it, and you can do it, but then you have to tell the patient that okay, you are the one who has delayed the surgery. You are now beyond the ideal age, and then it is like having a tough exam paper. It is not something where you can change the outcome. So your outcome is definitely not probably going to be as good as someone who's between 10 and 15. But I would not say no to an old patient, but I would tell the patient that I wish you would have come earlier.
And especially as of now in older patients also, if you have a good radiologist who can get the 3D CT done, he can exactly tell you how much area is ossified. And you tell you 6-7 is used for the basal framework. If it is calcified, it's not much of a problem. It can be carved out with your burr also sometime. But it is the helical margin, the 8th cartilage, which gives the contour. So if it is ossified, then it is very difficult to carve it out. Very, very difficult to carve it out. Yeah.
First question was to throw light on osseointegrated implant and cosmetic prosthesis, and the other you may be telling tomorrow, but normally our lobule doesn't contain any cartilage, and this lady's that boy's the lobule was good. So can we make a half of the framework and no cartilage in lobule?
So to your first question about the osseointegrated implants, see, the only indication of osseointegrated implant would be if you have exhausted everything. Like he had multiple operations or both the cartilage has been taken out, even the medport has been taken off.
So nowadays they are not ready for scars, and when they hear that something has to be open.
I'm coming to that again. See, if you have an amputation, below knee amputation, and you have very nice prosthesis, but you talk to the person who has a prosthesis. घर में बैठा होता ना, when you have a knock, you have to put on the prosthesis. It's a real thing. Now, if you have an osseointegrated implants, 1 साल तक लगाएगा. After he gets fed up, he will throw it away. Believe me, I have seen patients who had good osseointegrated implants. They have ultimately thrown it away because they are fed up. अपना नहीं है ना. It is not your own ear. It's like your wig. You will continue for a year, 2-3 years, and ultimately throw it away. ठीक है, I'll accept I am bald. So osseoimplant, that is one, and then they have a problem of screws also. They get loosened out, they get infection, they get little bit of cellulitis or osteomyelitis. These are other problems. But I believe I'm yet to see a patient who is using osseointegrated implants for more than 2 years. So I believe if the patient have exhausted everything, I'll advise him to go for osseointegrated implants, or if there is something which cannot be done. Like if the patient is unfit for anesthesia because of the associated heart condition or some other reasons, then I'll probably ask him to go for the osseointegrated implants. I have personally not done any osseointegrated implant. So I have no experience of, but I have seen patients with osseointegrated implants who were not happy in spite of the fact that it was very nicely constructed osseointegrated implant. So they have ultimately thrown it away. They have come to me to take out the screws. So they were not happy ultimately. But of course, if there is nothing, then you have to offer osseointegrated implants.
True, I think osseointegrated implants are a good option for elderly patients who are, in their 60s, and an osseointegrated implant is going to have its life. The screws may become loose 10-15 years down the line. With sun exposure, the color of the silicone keeps fading away. So for younger patients, it's not really a very good option, unless, as Bandari said, rightly said, you don't have an option where the cartilages are used up, local skin is not available, fascia is not available. Then you can't really do anything to help the patient. Apart from that, you really can't compare autologous reconstruction with a prosthesis, given that the color match, or you can say the touch, feel, everything is like, it's like having your own ear, and the prosthesis doesn't feel like that. I have had some patients who were initially recommended, the stick-on prosthesis where you have to apply adhesive and stick it. But that led to so much of thinning of the local skin that when the patient came to me for reconstruction, I had to, tell him to stop using that prosthesis at least for 6 months, allow the skin to, sort of regenerate or improve in terms of the thinness, and then we could go ahead with the reconstruction. So coming to the second point of your question, sir, where you asked about cartilage in the lobule. Now lobule it's a very strange thing that it is always antiverted. If you look at it, it is not in the same plane as the rest of your ear, and the only way you can control that antiversion is by extending the cartilage right into the lobule. So of course you should be able to leave like a 0.5 centimeter or 5 millimeter margin of the lobule for future piercing. And plus it's a stretchable tissue, so when the patient comes for the second stage, I normally do the piercing for them by just stretching out the lower part, the lobule part, only the skin part, not the cartilage, and you can manage to get a piercing done. In few cases I have also made a small drill through the cartilage to put the earring, but then they have to use strictly a gold earring only. They can't wear any artificial earring. There is a very high chance of infection, so you need to counsel the patient properly. But inserting the cartilage in lobule is really something you have to do, otherwise you will have a lobule which sticks out like this and it doesn't really look good. And once you are done with your framework, later on you can't really do anything to control that lobule. Maybe you can give big earrings to wear to control it.
Thank you, sir.
Sometimes in Indian males, so a lot of times the skin is very thick. So what is your take on injection, triamcinolone injections to improve the contours?
So Bhandari sir has published a paper on use of triamcinolone, and I think he would be the right person to throw more light on this. Triamcinolone I have not used for thinning out of the overlying skin ever. I have used it in cases who had a keloidal tendency or early formation of keloid. Those cases I have, but I don't think you should use triamcinolone on the framework. Very high chance that the skin is going to thin out so much that it will expose your cartilage. Not a good idea.
Sir,
in Farming's article it is written he is using 3 types of blocks for giving the projection, that is P1, P2 and P3 like that. So according to the Indian population, what is your experience on that? What we should use? And another question is that related to that also. So do you always give additional cartilage strut from the tragus to the helical root of the helix, or how you decide clinically?
So see, madam has described 3 projection pieces. What you are talking about are called as projection pieces, P1, P2 and P3. So today also you saw that we used a P1. I don't know if you were there when that. So P1 is something you can use to stabilize 2 points, the tragus and the root of the helix. Now sometimes the patients have a mastoid which is low, or the projection in this area is so low that no matter how good a framework you make, it just doesn't show the tragus. So how do you make the tragus stand out is by putting that piece which is underneath the tragus. And why she fixes sometimes the root of the helical rim is because as the skin contracts, sometimes you feel that the rim opens up, because this is the most concave part of your fixation, and no matter how much you fix it, it does have a tendency to warp. You are not taking into account the warping of the cartilage, which is something you can't really control. So how do you control it is by fixing it at multiple points, so that P1 is something which helps you control the root of the helical rim. Of course, P1 is something which you will be able to use only when the patient doesn't have a ear canal. If the patient has a canal, it comes in the way. You really can't use that P1. P2 is a piece that I use very frequently to deepen the concha. Okay, if you need more depth in the conchal area, you need to use an additional piece of cartilage. And in many patients, then you need not reinforce it too much with a big block of cartilage for the second stage, because your concha is already so deep that you can use a smaller piece of cartilage in the second stage. So that's about P2. P3 is very rarely required. It's mainly for syndromic cases. So if you have a patient with, say, Treacher-Collins syndrome, or with a hemifacial microsomia with a very retruded mastoid, a very small mastoid, P3 is what gives projection to the ear lobe, and that is something which can help. So the whole concept why Dr. Fermin, see, you have to realize that she introduced her classification way before she introduced the projection concept. Projection concept was way later on in her practice. So it was after realizing the deficiencies in maybe 1500 cases of ear reconstruction, that's what made her come out with this projection concept. So it is basically something which will enhance the convexities so that the concavities look better, or it is more about enhancing the contours of the ear, because as the discussion was going on, the contours are going to get blunted. What you see at the end of the reconstruction, or what you see even at the end of 6 months, is not the final thing. The contours are going to reduce, or there may be some amount of reduction in the projection. So having a little extra projection is not harmful. It is something which will help in the long run. So that was the logic behind the projection pieces.
One more, sir.
The regime for the dressing. So that is a question I think I should ask madam next time. But yeah, so when she has a very interesting story of how she started doing ear reconstruction. So the teacher of Madam Firman was Paul Tessier. She was Paul Tessier's student, and as you all of must be aware, Paul Tessier was a great craniofacial surgeon, and he used to head the craniofacial unit at Hôpital Necker, which is in Paris. And he never used to recommend ear reconstruction to any of his patients. The results at that point of time were so inferior that he used to tell all his patients, don't do ear reconstruction, just grow your hair, be happy in life. So Dr. Fermin is also a very, very good sculptor. She makes beautiful sculptures. So on Paul Tessier's birthday, she made a sculpture for him, and in that sculpture, she didn't make any ear. And then she presented that sculpture to him on his birthday. So when he saw his sculpture without the ear, then madam asked him, do you feel it looks like you? What do you feel? So that's when he realized that, okay, it is not a correct advice that he has been giving patients not to do ear reconstruction. And then from that point onward, he used to refer all his patients to madam for the ear reconstruction. So that's the story behind it.
Sir, I have one more question, sir. Is there any role of perioperative massage to avoid the tight pocket or better draping of skin?
I thought you were saying pre-operative massage of the surgeon. So it doesn't help. It has no role. It has no role for the skin. Actually, I don't think it is going to help. But then you should. You are talking in basically in terms of expanding the skin pocket. That's what you are asking. So no, it doesn't really help, because skin is an elastic. You expand it as much as you want, but when you leave it, it is going to shrink back. So it doesn't really help. And I wanted to make a point on someone asked about tissue expander. So tissue expansion, when it came into vogue, one of the fields where people thought that this will completely change the way things are being done was ear reconstruction. There was lot of enthusiasm about tissue expansion in ear reconstruction, because if you look at it in terms of geometry or arithmetic or whatever, there is less skin in the local area to cover your framework. That is why you need to do it in 2 stages. You need adequate skin on the front, and of course then there is additional skin that you need behind. So how do you recruit so much skin? So one of the thoughts was by expanding it, like what you're saying. But it doesn't really work. In clinical practice, what happens is, when you expand the skin envelope, it does stretch the skin, but then it also forms a kind of a capsule on the under surface of between the skin and the expander. I'm sure those who have used an expander, when you remove that expander, you see there is a fibrous capsule inside. So that capsule comes in the way of getting proper contours. When you apply suction, that capsule doesn't allow the skin to redrape. And therefore tissue expansion has not really been a great success is what I feel for ear reconstruction. So I don't think any kind of expansion helps. Now if you read Dr. Fermin's textbook, you will find that she has described something called as indirect expansion. So it's a very unique concept. What we normally talk about is direct expansion. You put a expander under the skin which you want to use, expand it and use it for reconstruction. So it is direct expansion. So what is indirect expansion? Especially in cases of burns or in cases of say road traffic accidents, where the post-auricular skin 99% of the time is preserved. When the ear gets amputated, it spares this skin normally. And this skin has excellent color match for your future reconstruct. But then of course dimension wise it's very less, it's very inadequate to accommodate your framework in that pocket. So in indirect expansion, you expand the scalp away from the area which you are going to use. So what you do is you insert an expander higher up in the scalp, you expand that portion of the scalp. In the second stage, when you remove that expander, you have a lot of excess skin here which moves caudally. So when you redrape it, what comes on your framework is this good quality skin in the post-auricular area, and this expansion helps get rid of the tension. And I would advise those of you who want to learn more about it to read it in our chapter on indirect expansion in our textbook. It's a very unique concept of expanding the skin away from where you need to use it. In one case we also used expander in the forearm and put a framework in the forearm, and then we transferred it as a free flap. Didn't give very good contours. The contours get blunted out. You just have a blob of tissue which doesn't look like an ear. It really doesn't help as much as the local skin. So local skin, first option. Temporoparietal fascia, second option. If you have complications with temporoparietal fascia or some injury has already been present in the temporal area, then occipital fascia can be one option. Of course, for occipital fascia, the main problem is in the positioning. The patient has to be almost prone in order to dissect the occipital fascia. The caliber of the fascia is almost same as temporoparietal fascia. The survival is very good. It's a very robust fascia, and Dr. John Reinisch very routinely uses occipital fascia flap to cover his Medpore implants. But let us ask Bandari sir about his views on occipital fascia. Sir?
Actually, occipital fascia is way behind. So to bring occipital fascia to the area of auricular reconstruction becomes difficult. You're getting my point? This fascia is exactly over the ear. It is here. Then maybe if the implant getting exposed or a portion which needs to be reconstructed, the occipital fascia can be used. Although a big fascia can be raised based on the occipital artery. But to bring it here for total reconstruction becomes very difficult for me. So I believe it is only for the cases where it is required to cover the exposed cartilage or exposed Medpore, then probably it can be used. But for total reconstruction, even the deep temporal fascia also it falls short. I've tried in one patient using deep temporal fascia. The fascia is very small. It is very small. It probably can be used only for the segmental areas which can cover the deep temporal fascia. Nothing like superficial temporoparietal fascia. But in case sometimes you don't get the vein, then probably you have to go posteriorly, get the vein from the occipital area.
There was also a question, sir, about Kinacort.
You know what happens? I'll show you in my photographs also. When you're using temporoparietal facial flap, initially all contours are gone. They look very thick. Then in due course of time, 6 to 8 weeks, the edema starts settling down. 3 months onward, you will start seeing the grooves and contours which you have painstakingly made. It is after 1 year when you will see the ear has actually come up. But in some of the cases, if the dissection is not very good and there is lot of ooze which gets collected in the groove which you have already created, and if that collection does not get infection, fortunately it gets fibrosed, it gets organized. So in spite of waiting for 6 months to 1 year, the grooves don't show. In those situations where the flap has survived, where the cartilage has survived, in microossia also where temporoparietal fascia is not used, same thing can happen. So if there is a fibrosis or organized hematoma or organized subclinical infection. Sometimes there can be some amount of infection. There can be discharge which not come out, gets organized under cover of antibiotic. And then the flap, the cartilage has survived, everything survived, but the masking of the contour. In that situation, if you give injection, if you give Kenacort injection, it will take care of the fibrosis. So in that situation, and that too very little in the triangular fossa or in the scapha, very little. So like it will be around 0.23, 0.3 ml in the scapha, or 0.1 ml in the area of triangular fossa. Because if you inject more, in case of microtia, it can get spilled to the subcutaneous tissue. There will be atrophy. Then it can turn the color of the skin. It can get hyperpigmented. And sometime you can get atrophy of the cartilage also. So one has to be very careful injecting Kenacort, but it really gives wonderful results. You will see the grooves coming in 4 weeks of time. Waiting for 6 months. 6 months is the time when you will see the group should actually come. If it is not coming, if even waiting for 6 months, even microtia also, initially the groups are very good. When you open the dressing, it's good. Then in due course of time, the groups are gone because of the edema. Then in 3 months of time, gradually it starts coming. Then after another 3 months, 6 months, when you raise it, the groups are gone again. Then they will start coming again. So the things, that is how it happens. And you have to tell the patients attendant also, see the grooves are good, in due course of time they'll get masked out, then they actually come up. When you raise again, they will go away. Then again 4 to 6 weeks of time they'll come again. It is basically 1.5 to 2 years when you get the results, which actually should have been there.
2 questions. One, any experience of dermal replacements for exposed cartilage like Metriderm or BTM, whatever? And the other is, in second stage, when you put cartilage behind and cover it with the temporal fascia, do you fix that cartilage, or how to fix that cartilage?
So I always fix the cartilage which we place behind the ear using 3-0 monocryl. I take through and through knots from the concha to the cartilage and back and tie it inside the concha. So taking at least 3 fixation points helps you stabilize a C-shaped piece of cartilage in the post-auricular space. I really don't have any experience of using artificial dermal grafts for exposed cartilage, because I believe there is plenty of local tissue available. We'll definitely get some kind of turnover flap, some kind of mastoid fascia flap, occipital fascia. For small exposures, you have plenty of options in the local area. I don't know whether dermal grafts will really work on a cartilage, because when you use it in breast, it's different. You are using it to cover an implant, but then you also have a healthy layer of skin and tissue covering it. In case of ear, if you try to put it on the cartilage, I don't know how well it will survive, or whether it will just shed off when you remove the dressing. Don't know, difficult.
See, if there is a exposed cartilage, forget about the artificial dermis. Your own dermis, how it's going to survive. The dermis has to survive by diffusion initially, and then the vessels should grow into it. Now the vessels will come either from the bed or from the margin. If it is a very small area, maybe the blood supply will come from the margin, it will survive. If it's a little larger area, how it's going to survive? Because there is no vascularized tissue. These dermis, artificial or any dermis, will survive over a healthy tissue where the vascularity can come. So I don't think dermis will have any role. People have shown dermis in like exposed cartilage, where there is a thin strip of cartilage which is exposed. Maybe they are getting blood supply from the margin. But I don't think I will ever use dermis, own dermis or artificial dermis for exposed cartilage. I have never experienced it, and I will probably never use it also, because I would be scared to wait for the dermis to take. In the meantime, you'll lose the cartilage. So that was another point, was to how to fix the cartilage. I actually take 3O Vicryl to fix with the already form the helical, anti-helical margin, fix it with that, and with the sides also with the 3O Vicryl.
The challenges in a bilateral microcia and also revision microcia. Actually, I want to know, in bilateral microcia, what is your planning, and which year to be done, and what age should be done, and this template What should be done, sir?
So the template probably would be like, because both the ears are not there, so we want to make little smaller ear, because it is easier to put in a small cartilage in a pocket than to put a bigger cartilage, because always there is shortage of skin. So you have the leverage of making both the ears little smaller, because that will help you out in making the pocket. That is one. I have tried many times, like you have done the first stage, and in the second stage when you are elevating, you are probably doing the other side. It never happens. I don't know whether. I've always thought of mixing these two things. Like in the first stage, you have reconstructed the one of the ear. In the second stage, when you are elevating, you feel like reconstructing the other ear, but it really never happens, because you want to give all energy and focus on the reconstruction. So it is always 3+3 6 stage that is there. You start little early, like 11 years or 12 years of age, because एक कान बनने में पूरा साल लगता है. So we always plan like summer holidays, then you have Dashera holidays, because of our school days, going children. So like it can be maybe 7 months, not 6 months, maybe 5.5 months. वो holidays में करते हैं, because the छुट्टी का बच्चे का problem होता है, and there should not be problem with the studies also. So it is always, I have never tried to see. I always say it is 3-stage procedure. First stage is reconstruction of the ear. Second stage is the elevation of the ear. And you sometime, I would say most of the time, need some minor modification. There is a little notch here. There is a little elevation. There is something which needs to be done. So that stage can be mixed with the reconstruction of the other side. That is how I do it. And of course, I have to give all chances. It has to be good reconstruction, otherwise the patient will not come for the next reconstruction.
So in bilateral ear reconstruction or bilateral microtia, how I do is I do first stage of one side, wait for at least a month, then do first stage of the second side, and then I ask the patient to wait for 6 months. And then the elevation you can do simultaneously, so that in 3 surgeries you can complete a bilateral reconstruction. I have now done it for 13 patients, and it has worked out well, that you do one ear, wait for 1 month, then do the second ear, and then 6 months later elevate both together. That is how it is. It saves you a lot of stages.
That's a good idea. That's a very nice idea. Cut short the stages.
Idea has come from Brent and also from Nagata. So how he has mixed up these two surgeries, he was doing for a couple of years.
Yes, so Dr. Fermin actually visited Bert Brent and spent some time with Bert Brent. So when she came back, she initially was using the Brent technique, but then she also visited Dr. Nagata at his center, and when she came back, she realized that doing it in 2 stages, saves a lot of time, energy, effort, money for the patient. Because even in France, ear reconstruction is not completely covered by Mediclaim. Patients do get some kind of reimbursement, but more the number of stages, more the admissions, more the financial burden for the patient. So if you can do it in 2 stages, I think it is good. So that's when she shifted to the Nagata technique. But then she has written this in her book also, that especially with the Z-plasty that Nagata does, I think he's the only person in the world who can salvage that kind of a thin subcutaneous pedicle. The only problem you always have is necrosis at that particular point, because the pedicle does not survive. And there was a ear reconstruction workshop some years back in Chennai, where Dr. Nagata's student had come and he did a Z-plasty for lobule reconstruction. That also necrosed at the same point. So the survival of that particular subcutaneous pedicle is very, very precarious, and that's why Madam says in her book that she has given up the Z-plasty. She no longer does a Z-plasty. So it is either a type 2 incision or a type 3B incision for the majority of microtia cases. Z-plasty almost she is not doing it now. She does put cartilage graft, but yeah, she does put cartilage graft, sir. But it is not always covered with temporoparietal fascia. In majority of the cases, she covers it by a tunnel of the postauricular tissue, sometimes with the temporoparietal fascia. Yeah. Yeah. So harvesting cartilage, I have not seen any reports on endoscopic harvest of cartilage. But as I said, there is a center in South Korea where they routinely harvest temporoparietal fascia endoscopically and huge size temporoparietal fascias through a very tiny incision, huge size. So endoscopic harvest of the fascia obviates the need of any scalp incision, no alopecia, nothing. So yeah, that will be the future.
Sir, there's question I want to ask a question about the contouring. So the different patients have different thickness of skin, and accordingly to obtain a good contour, the thickness of the cartilage which we are using means the thickness of the helix, antihelix, and tragus, antitragus. This should be. I think this cannot be same for various persons who have different thickness. So how to adjust that? Any suggestions like that?
So the only thing I can say is that you need over projection. Okay, there is no harm in creating extra contour. The problem will be if you create less of a contour. So the problem of not having a good shape or having blunting of the shape will happen if your projection is not adequate. If you have more than normal projection, at the most what will happen is the ear contours will be too drastically visible for the initial few years maybe, but then eventually the contours anyways get masked. So if you have to choose between the two, you can choose the over projection rather than the under projection. So even if your skin is thick, an over projected cartilage will also show through a thick skin.
So also the in triangular fossa, the inferior crux, that in every person is very sharp. It has very good indentation of skin going into it. So how to achieve that, sir?
So to get a depth there, when you use the P1 projection, a part of the P1 projection is also fixed to the undersurface of the root of the helix. Now if you noticed, I put one more wire later on to fix the inferior crux with the root of the helix. So that is the junction which you need to stabilize, and you can put a small piece underneath that point for extra projection if you need to project it more.
So as you said, in this CAFA, the minimum width should be around 3 to 4 millimeter for the skin to drape properly. So
in the narrowest part.
In the narrowest part, yes, sir. And so in case of the part which is lying beneath the inferior crux of the fossa triangularis, where there also a minimum of 3 to 4 millimeter of width.
So the width of the triangular fossa depends on the size of the opposite ear, and you try to replicate the contours of the opposite ear. Each person's Y of the antihelix is not the same, so that size would depend on the opposite ear. But you need to make sure that there is some space between the two crura, otherwise the skin will not drape in that triangle. It will just tent in that triangle. So not very narrow, has to be wide enough for the skin to enter that triangular space.
And so also, like in my ear, if you say that after the helix there is piece of skin which is not having any cartilage and it is projecting above. So how to achieve this kind of projection?
This is a natural ear you have, right?
Yes.
It's not
Yes.
So whenever we think of any kind of surgery, you have to understand that surgery is camouflage, okay, especially plastic surgery. So plastic surgery is to make it look like you have something there. It may not be there. So I'm sure when you pass in the street, people on the street are not going to stop you and feel your ear. So they are going to look at your ear. So what you are trying to achieve is a visible effect that you have how it should be. It is not something, once you are at home, you can always feel your own ear and say that, okay, I have only skin and not cartilage. But what you want to recreate is what is going to be visible to people. So as long as the skin drapes well on the contours of the cartilage, and as long as visibly it is, when I'm looking at your ears from the front, as long as both the ears look symmetrical and at the correct level and of the same color. I think those are the endpoints that we aim for in ear reconstruction.
Hello, sir. Sir, I will ask a basic question actually. How you are going to counsel a patient of microcia, especially in your private practice? Because patient is going to pay for it.
Yeah.
So how you are going to counsel it?
So counseling for microtia is like counseling for any other surgery actually. The best way to counsel a patient is to show them photos of similar patients, so they realize that okay, there is a possibility that their ear is going to be reconstructed. Whatever patients have seen is usually inadequate knowledge, and inadequate knowledge is not good. They need to know more about what the surgery is going to entail to be better informed. So I show them before after photos, and I sometimes also show them photos of complications, that it is not only the easy part that they should know, but they should also know that there can be complications. But at the same time, you have to give them confidence that even if there is a complication, you can handle that complication. So that information is important. I give them a booklet to read, which has like FAQs of what a patient can expect after ear surgery. So when can the patient start resuming having a bath, when they can sleep on that side, what is the general recovery timeline. So counseling is a constant process actually. Your counseling for a patient who is coming for the first time is different. Counseling for a patient who is coming for the second stage is different. Patient having bilateral microtia, the counseling is different. A patient of low hairline, the counseling is different. So yeah, you need to really spend some time and explain the details of the surgery to the patient.
Excuse me, sir. Is there any way to salvage the framework? Suppose you start getting redness, infections, hematoma is there, contour is not maintaining. Is there any way to remove the framework and reinsert into any other part of the body, and then after infection get cured?
So see, ear reconstruction is not only the framework, right? You have to salvage the skin also, and it gives you one single chance to create a normal looking ear. If you have an adverse event which is so bad that you have to remove the framework and put it somewhere else for salvage, you may salvage the framework, but what about the local skin? It will become very badly scarred. So removing the framework completely and putting it elsewhere, I don't think I've had to do, fortunately. But you should always keep a watch on the patients. Like sir said, cartilage is avascular. If your patient tells you that he or she can see something through the skin or the cartilage is exposed, you need to act on it ASAP. You can't wait on it and hope that it improves on its own unless it's a very minor exposure. With autologous reconstruction, of course, it is not as bad as with any other artificial materials, because if you have infection with Medpore or with any other artificial material, you're gone. The ear is gone. With autologous reconstruction, it will still give you the chance to do some kind of local flap, put a skin graft, put the patient on antibiotic. You can admit the patient, put a infant feeding tube, and give washes with antibiotic or betadine every day. So normally you don't need to remove the framework completely. You can manage leaving the ear framework inside.
Answer your question. Like if you're taken out the cartilage and put in over the radial artery forearm area. So the patient I've done that. Initially the result was good. I'll tell you what actually happened. Now if you put in a cartilage in the forearm area and nice contours, you have actually recreated the ear in the forearm. It can be raised as a radial artery forearm flap and placed over here. The ear is stuck to the skin. Everything is there. Contour is gone over here. If you take that cartilage which got exposed and put it in the abdomen, so you're not taking now this cartilage as a flap. You need to take out that cartilage as in toto. There will be a lot of fibers in the scapha area, in the triangular fossa area, and there will be resorption also. So it does not really look like which you have actually carved out. So it doesn't really work. I've done it once. It actually got exposed, and I also had the same thinking which you had, कि चलो लगा देते हैं and then it'll do it later on. It didn't work. It never works.
So one question regarding burn reconstruction, sir. So if a patient has suffered burn recently, around 1 month ago, so what is the age at which we should attempt reconstruction of autologous ear in the process of the healing of burn?
No, it is true for everything. Like it will be true for the contracture also when the patient is developed. When the scars have settled down, means when the hyperemia has settled down, that is the time when you start reconstructing, because there will be an area which will be hyperemic, because if you are going through that area where you can feel the temporal artery but the scar is little hyperemic, there will be a lot of ooze over there. So the scar has to settle down before you can. It's usually more than 6 months of time.
And so second, so is there any effect of process of healing in a patient having suffered burn on the process of ossification of cartilage? Does it ossify faster in comparison to a normal person?
That I have not read anywhere there will be chances of more ossification. I haven't seen anything like that. I have no experience of this thing that there will be more chance of ossification after the burns. But that is there. See, in one patient, this area was grafted. So I thought I'll use temporoparietal facial flap with grafted skin. And instead of flipping 180, I tried to flip it in another direction. It didn't work. So I thought the graft is already there, and you put in the graft over the fascia. So it is already there. But it was quite thick, it actually didn't work. So that time only then I scraped the skin, but still after that, because there was a lot of thickening, so it didn't actually work. So if there is a scarred area over there, it is very difficult. You have to raise the fascia, take off the scar, and scar never survives. So that means you raise the fascia from the scarred skin, and the skin which is left behind also needs to be grafted because it does not survive. And the fascia which you raise is also very thick. It's a little bit of scarring also over there. So the contours are never good. Unless the skin is already able to scar, then it is very difficult reconstruction.
So Parag sir, a question regarding, so we were discussing about expanded skin, and so you told that because of capsule we are not able to get a proper contour. So then, sir, if we remove the capsule, because there is skin, then there is capsule, then there is expander. So if we remove the capsule, then probably we can get a proper contour.
No, but then in the process of removing that capsule, what happens is you damage the dermal plexus. So your blood supply gets into a problem.
So because in prelamination and these techniques has been described that the capsule itself can be used as a flap.
But not in the ear. I mean, at least in my hands, I have not seen the capsule contour properly into the grooves of the framework. And trying to remove the capsule is a very tedious process, and it damages the vascularity of the skin.
Hello.
Hello.
So maybe you can try scoring the capsule and try if it expands and
Hello.
can cover.
Yes, Surya.
Yeah.
Can you hear us?
Yes, we can hear you.
Right. So, sir has started with the carving. I'll hand it over to him.
All right.
Yeah, hello, good afternoon.
Good afternoon, sir.
Yeah, so I am we are just trying to create a base plate. This is a 7 costal cartilage. So 7 costal cartilage creates part of the base plate, and 6th costal cartilage, which is reverse, forms rest of the base plate. So we'll first carve out 7, then attach 6 to it to create a base plate. So this much we have carved. Now the 7th is so brittle that it has, while harvesting, it fractured in between here. It should not have happened, but it has happened. So we'll just take care and utilize the same piece because there is no other way.
Mohit sir, can you hear me?
Yeah.
Sir, have you tried using electric burrs sometime to carve ossified cartilage?
Yes. This is somewhere in between. This is just brittle. It is just, it is fracturing. It is not totally ossified and it is not totally soft.
Yeah, we can see that, sir. Yeah.
Sir, can you hear me?
Yes, sir. Yes, sir.
Yeah. There is a question in the house. What sutures are we using right now?
We are using 4-0 nylon double arm. This Sentinel company has developed these sutures on our request.
Okay.
Previously, Onolab was making it.
Acha.
But then they stopped it. But later on, they again started making stainless steel wires, which Dr. Parak has got with it.
Okay, sir.
And because we wanted these double arm needles, we requested Sentinel company to develop it, and they have made it. So it is like this.
Right, sir.
And it is available now. Previously, I was also using a lot of stainless steel, but because of the very high extrusion rate, I totally changed it.
Right.
Sir, if it is completely ossified, then how to fix it?
Hello?
If it is completely ossified, then how to fix?
We'll use the diamond burr under a water bath to carve it.
And fixing?
Instruments, these different blades we fix into this handle. And then tighten it. These are very good for this carving.
We have a chat question, sir. What is the other best suture material that can we use that we can use if stainless steel and nylon are not available?
We can use PDS.
So yeah, there is a company which manufactures PDS with straight needles for ear reconstruction.
यहाँ पे रखो तो इधर डालो। For creating base plate in brittle cartilages, it is good to use a stainless steel also because it secures it well, and because it is under surface, there is no chance of exposure. And for the helix and anti-helix, one can use PDS or nylon.
There's a question online to Dr. Parag when sir was closing. Dr. Pooja Mistry says sometimes the suction doesn't hold or it gets discharged. What is the cause of it and how can we prevent it?
Well, you have to take sutures very close and make sure that it's airtight, watertight. You can also use a running suture. If you feel that simple sutures are allowing air to escape, you can use a running suture, and you can always cover it with skin glue, ferracrylum, to seal it. Mohit sir, am I audible to you? Mohit sir, can you hear me? Sir, can you hear me? Mohit sir, can you hear me in the OT?
Yeah.
So this piece that we used for the base frame was 7 and 6.
Yeah.
So was there no synchondrosis, or why did we have to harvest two separate pieces?
What happens is, if the cartilage is so brittle, it is easier to harvest one cartilage at a time.
Okay.
That's why we separate it.
Okay, sir.
But in like children, sometimes we get a good joint piece together, then we don't separate it.
That's correct. Yeah.
But in especially in Nagata's technique, it is good to separate and then rejoin nicely because the carving requires it to be so.
And you have removed the perichondrium on both the surfaces.
Yeah. Something is here, but we'll end up removing everything. Now this is the base plate.
It's looking very nice, sir.
Now we have to place helix and anti-helix, which is anti-helix is fine, but helix is the difficult part because it is very brittle. And technically it should come like this. Other way around, not like this. And this is flayed also, this is ossified here. So let's see what are we able to do.
Sir, in your opinion, in your experience,
Yeah.
if the cartilage is ossified, do you feel the chance of resorption is more?
Whether it is ossified or not ossified, it always resorts if you don't cover it with BPM.
Okay, let me reframe the question. Does it resorb more if it's calcified as compared to a cartilaginous?
Don't know.
Bandari sir, you would like to, yeah?
So this is the 8 costal cartilage which we are going to cut like this. Like Very brittle.
Yeah, looks very brittle. Just want to add over here. See, the cartilage survives by diffusion. If it is bone, then it will survive by two techniques: creeping substitution and osteoinduction. So the chances of survival will depend on these two factors, whether bone to bone contact. Because it is bone, then chances, because it's not contact with the bone, then you will have BMP. There are the other factors. And therefore, if it is bone, the chances are definitely resorption.
Although it is right now curved like this, but it has to come like this. For this, there are two ways.
Dr. Mohit, it is from the same side or from the opposite side? So that's what I always tell the people, that if you take it from the opposite side, it curls into as you find, like if this will be good for the opposite side. The way you want to curl in, the curve in, it will be good for the opposite side. You always take it ipsilateral or contralateral? Yeah, no, yeah, Dr. Mohit, the thicker portion should come to the root of the helix. That is what you want to say? Yeah, yeah. So that's what I'm saying. If you take it contralateral, it always contours like that. Because then, see, this is good for the right side. Sorry, left side of the patient. So if it curls in like that only, do you take from the ipsilateral or contralateral? Contralateral, ipsilateral. And how do you make that then? Then the smooth portion does not come superiorly. No, no. This is the superior margin, right? Yeah. So it has to come the superior. It should form the superior margin of the helical margin. Yeah, I can hear you. All are made in Delhi.
Are we audible?
Yeah, we can hear you. We can hear you.
I have one request.
Yeah, I understand. Okay, Mohit. I just want to tell to the audience over here, if you flip it, now you want to make this the superior margin of the helix, right? The smooth one. The smooth, yeah, right. Now we can't see that. And it is curling to other side. It is curling. So how are you going to do that? So what I tell the people, see, if you take out the cartilage on one side, it starts curling to other side, but then it makes it very thin. Yes. So let me explain this in a different way. If you take the cartilage or take the slice of the cartilage on one side, it starts curling to other side. That means this side where you have taken off the cartilage, it will become more convex. So that is what you want. This is Gibson's principle. If you take out the cartilage from one side, it curls to other side. The same thing? So, no, that I understand. Now, if you take out the cartilage from both the sides, it becomes very supple that it can be molded in any direction you feel like. Okay. Yes. Yeah, if the helix get fracture, then the contour which you actually want doesn't really come. There will always be a notching or pointing the area. So helix is the most important thing in ear reconstruction. This gooch is very nice. From where did you get it? The disposable blade? Very, very nice. So it can be changed like. ये तो फर्मिन वाला यूज करते हैं. कार्ल स्टोल्ज.
इंडियन वाले ही बनाते हो.
नहीं, एक राजधानी स्टोर करके अच्छा बनाता है वो. राजधानी स्टोर करके वो दिल्ली में 5,000 का देता है. तो इट इज डैम चीप कंपेयर टू दी अदरवाइज. ओके.
Now we are able to bend it.
Yes. Little more bend is required.
You can need more bend.
Yes.
So I'm saying there is other factor.
Yeah, because the yellowish portion is all ossified. मैं आपको नंबर दे दूँगा. क्या चीज़? उसका disposal नहीं है. वो fix वाला है. Yeah.
Very bad.
Maybe one suture required over there, but the helix is not good. It is all ossified. curvature.
create a slot here so that it can just get fixed here. So this kind of slot.
So that is Nagata, which is the root of the helix going right up to the anti-helix. Yeah.
Mohit sir, can you hear me? When you stack up the cartilages, like this helical rim and the Y of the anti-helix you will place on the base frame, so what is the thickness that you normally aim to create? The thickness of your framework.
See, now there is no restriction in the TPF, but otherwise it is at least, I would say, between 15 to 20 millimeter thick framework, 3 layers. 15 to 20 millimeters. It's a very solid framework with great definition. Normally midpoint of the, at the midpoint of the ear, the anti-helix is almost equal or higher than helix in normal population, but in reconstructed ear, if you make anti-helix higher than helix, it looks very bad. Very bad. Helix only should look bad. It's a smaller framework, we have to first fix it and then trim it radically. brittle. Turn the way I have.
Mohit sir, in these kind of calcified cartilages, have you ever carved out a framework using a single piece like a mono block?
Yes, yes. 3-4 times. In a 53-year-old gentleman or 55-year-old gentleman with a bird and created a framework and that's it.
Very true.
Just not bending.
Yes sir, we can see that.
Especially the inferior thrust. I'll have to devise some therapy. There has to be a gap of at least 3 millimeter between helix and anti-helix for skin to break.
Sir, your audio is not very clear.
All the extra portion is trimmed.
Sir, can you repeat what you said of between the Y of the anti-helix and the helical rim? Sir?
Hello?
Can you hear me, sir?
Yeah.
So can you repeat what you said about the gap between the Y of the anti-helix and the helical rim?
See, there has to be a gap of at least 3 millimeter between this anti-helix and helix so that skin can come and drape here. If you join this thing to helix, it will be a very bad chamber. See, helix coming here, there has to be some gap in between.
Yeah.
So that the skin can drape.
That's correct, sir. It's looking very nice, the framework.
It is not over until it is all over.
Sir, in these nylon sutures what you are using, how many sutures are there in each packet?
I think 50 or 60. Each file is total 60, I think.
60. And how much does it cost?
Maybe 12,000. Full box. Full box. It's a whole box containing 5 sutures.
Each box has 5 sutures.
Each box has around 12 files and each file has 5 sutures.
Okay, so 60 sutures in each box.
Yeah, I told them 50, but I think they were telling me they have kept 60. I don't know. I have told them to keep it reasonable. Whatever they. Somebody can. We are not making anti-helix, tragus. Tragus we are not making.
Right, sir.
Make sure that the edges are not sharp. under the skin.
Right, sir.
Yeah, which one is he talking about? Like you just say no. ऐसा बोल रहे कि we would like to take him for his talk. Then he will give us has any talk.
मोहित सर, हेलो हेलो। हाँ सर, हम लोग थोड़ा सा एक टॉक कर लेते हैं सर का इन बिटवीन।
कर लो यार जो तुम्हें करना है।
ठीक है सर। और कौन किसका नाम था?
To everybody, beginning our scientific session for today, I would like to invite Dr. P.S. Bhandari sir to enlighten us regarding ear reconstruction using superficial temporoparietal flap. I would like to invite Dr. A.K. Chaudhary sir, Dr. Ravindra Bharti sir and Dr. Devesh Raut sir to kindly chair the session.
Good afternoon, gentlemen. Can you hear me? At the outset, my sincere thanks to Dr. Chaudhary and Dr. Giri and his team for inviting me over here to share my experience with the August gathering over here about reconstruction of ear in post-mortem deformity. See, I'll be talking about superficial temporoparietal facial flap. As you understand, superficial temporoparietal fascia lies in the temporal region. And if you see the layers in the temporal region, starting from superficial to deep, in this area you have skin, then you, with a very little amount of fat, that is called subcutaneous tissue. So you have a skin, then you have subcutaneous tissue, and then you have superficial temporoparietal fascia. The artery is embedded in the fascia while the vein is superficial aspect of the fascia. Then you have loose areolar tissue. Then you have deep temporal fascia. And then you have the temporalis muscle. And in between you have deep temporal artery. Now temporoparietal fascia, superficial temporoparietal fascia is an extension of SMAS. If you trace it inferiorly over the face, it is continuous with the SMAS. And if you trace it superiorly, it is continuous with the Galea pinnoretica. The blood supply of temporoparietal facial flap, as you understand, is the superficial temporal artery in its vein. The artery is a branch of external carotid system. It travels with the vein anterior to the ear where the pulsation can be felt. Now superficial temporal artery, as you can see over here, 2.5 centimeter above the zygomatic arch, it divides into two branches, frontal and the parietal branch, and then they multiply into various branches. They are accompanied by the veins. Now the incision which is given to raise the temporoparietal facial flap is an incision anterior to the ear in the preauricular region and then divides in a Y-shaped manner. Now the two transverse incision can also be given to expose the temporoparietal facial flap, but why I believe people say if you give this incision, the chance of elevation are drastically reduced. But if you give a Y-shaped incision, expose it is better, it is easier to raise the flap. In case of transverse incision, it is extremely difficult because the exposure is limited. So if you are well experienced, you can probably go with the two transverse incisions. But for the beginners, I would say go with the Y incision which extends from the preauricular region. So this is how you ask the patient to get this hair shape. And now, as I was mentioning in the morning, there is no definite plane of dissection between the superficial aspect of temporoparietal fascia and the undersurface of subsequence tissue. That means below the hair follicle. And the connection between the scalp and the temporoparietal fascia is also very firm. It requires very sharp dissection with the knife. An assistant that follows along the bilateral artery will also be there to coagulate the small tiny vessels. Extremely important. Now when you raise, you're raising the skin along with the subsequent tissue just at the level, just below the level of hair follicles. The hair follicles should not get exposed. They, as you can see over here, you cannot see the hair follicles. They are all exposed, they are all covered by the fat globules. So when you're raising it, make sure that the follicles, they don't get exposed. They must lie covered with the fat globules, or else there will be, as you can see over here, you've raised it with the fat globules. Now you can compare it. This is also one of my patients. On the right side, you can see the hair globules, hair follicles. Now this should not happen, because once we expose the hair follicles, there are chances of losing hair and the chances of alopecia. On the left side is fine because it is all covered with the subsequence tissue. So that should be the plane. And as you can see over here, this area, you can see the fat globules lying over the fascia. So there should not be any fat globule over the fascia when you're raising the skin along with the subsequent tissue of the temporoparietal fascia. And as I was just mentioning, must have seen in the morning, you can see the vein is lying superficial. That means it is on the surface of the flap. That means when you are giving incision, there is every chance of injuring the vein. So that means you give incision and just preauricular region, because the vein lies posterior to that and the artery is lying deep, and therefore you are probably saved. So what I basically do, I give lot of adaline saline before I raise the flap. So I start from the top of from this area. I will take 2 ml syringe deliberately, because I want to give little bit of every time with little bit of adaline saline. So what I will do, start with the top, because this is the area where the vein has ramified. The artery is also ramified. There is very less chance of entering the main artery or the vein. So you inject in the plane which is superficial to the fascia and deep to the fat globules. You make a bleb, and then through that bleb you inject again. So gradually you are injecting and not hitting the artery or the vein, because otherwise there is a definite chance of injuring the vein or the artery if you are not following this regime, because they are very close. So starting from the top where the artery and the vein is ramified, you make a bleb with the 2 ml syringe, and then through that bleb just continue injecting, and around 40 ml is injected. So I usually prefer to give 0.5% xylocaine with adrenaline, which is 1 in 200,000 dilution. So I'll take 10 ml of xylocaine with adrenaline, which is 1 in 200,000 dilution, and dilute it with 30 ml of adaline saline, which is again 1 in 200,000 dilution. So dilution of the adaline remains the same. The concentration of the xylocaine goes down. So I give 0.5% xylocaine with adrenaline into 1 in 200,000 dilution, and by watch I wait for 20 minutes. So I'll inject, wash, inject. Wash means I'll wash my hands, put on the gloves, inject, and then we'll have a cup of coffee, because 20 minutes is a long time to wait. So once I have injected, then I'll come and start elevating the same plane which is already there. So once you have injected, there will be little bleed. But then you have to be very careful about that the vessels which are large has now shrunk, and a tiny bleeding point would be a larger bleeding point had it not been adrenaline. That means all smaller points, they need to be cauterized. So one has to, if you have injective adrenaline, but I have seen people, they elevate, I've seen that. So they elevate without giving adrenaline. It becomes very messy and bloody also. So I was also scared initially that, like, if you are raising any flap, this is a common teaching that don't give adrenaline because it will cause spasm of the vessels. So I was also very much worried about it, but now I always inject adrenaline saline before raising the flap, because then the plane is very clear, one, and the bleeding is very little. So as you can see, the vein is superficial and artery is lying anteriorly, which is embedded in the flap. Now one have to take care of the frontal branch of the fascia, now which lies in an oblique course of the zygomatic arch. Now you can be drawn by a line connecting 0.5 centimeter inferior to the tragus. You make a point, and 1.5 centimeter lateral to the eyebrow. This is the line of the frontal branch of the fascia. Now, so you don't go so anteriorly, it is not required also. But if advertently you go so anteriorly, there are chances of injuring the vessel, injuring the nerve, but you don't actually go so much anteriorly. So this is the safe zone. Now, when you're raising the temporoparietal fascial flap, auriculotemporal branch of the migrate nerve will lies posterior to the artery and provides sensation to the scalp. It always, while you're raising the flight, you will always cut it. So this portion becomes insensate, but later on the vessel nerves can grow from the side. So as I was mentioning, as you can see over here, once you raise the fascia, there is a definite plane of cleavage between the temporoparietal fascial flap and the deep temporal fascia. So it is so easy to raise the flap once you have cut the fascia, as you can see over here, and usually 10 to 12 centimeter of the flap is required to cover the whole of the cartilaginous framework. And this is also seen that the distal portion, usually the distal portion falls short, and if you rose beyond the superior nuchal line, it is a random pattern flap, and there are chances of necrosis in the distal portion. Therefore, try to make a little smaller ear if you are using a temporoparietal fascial flap, because if the ear looks like an ear, a little short does not matter. But if it gets necrosed, it becomes difficult. So make a little smaller as compared to the other side so that it covers completely by the temporoparietal fascial flap, and there is no chance of necrosis. As you can see, again, the vein lies posterior, the artery lies anteriorly. Now, sometime, as I was mentioning, in case of hemifacial microsma, you don't find the artery. So random pattern flap can also be raised 1:1 ratio, but still you are very skeptical about the survival of the flap, but I have done temporoparietal fascial flap also. Now this is extremely important, as Dr. Parag was also mentioning, it has to be very optimum size. If you raise a flap which is larger than required, it will fill the grooves. And once the grooves are filled by the fascia, it has to actually go into the grooves. It should not fill it. So if it is larger than required flap, whatever you do suction or you do pressure dressing, it will never come up because it has filled the grooves, so it will mask the contours. On the other hand, if it is smaller flap, there will be tenting, so it will not go into the grooves, and there is a groove which will have a potential space when the blood can get collected, and if the blood gets collected, it can get organized under cover of antibiotic and masking of the contour to be there. Or if it is tight, then there are chances of tension and necrosis. So therefore, it is extremely important that it has to be optimum in size, and coaptation is always done with the suction catheter. It is always required. No bolster sutures are advisable because there are chances of necrosis later on. So suction is always done, as you can see over here. Now, as you can see over here, it is little short. The flap, so the grooves are not very clear. And if you go back, if you see the grooves over here, they are very, very clear, but it's an optimum flap. Now, if you see this, if you see it here, the grooves are not very clear because falling little short. So that's what I'm saying. It has to be very optimum. Otherwise, like this patient is absolutely fine. You can see the grooves. Here also one can see, and no bolster sutures is required, there are chances of necrosis. So this was like temporoparietal fascial flap. In this, many patients, ideally in all cases of microtia also, you prefer to use the local skin. But we got so many patients who were working in a government hospital, they were not willing to come again and again. So within many patients we have done reconstruction with the temporoparietal fascial flap in single stage, like you take out the cartilage, carve it out, raise a flap, turn it down and covered with the thick spread skin graft. Now a few cases, this was a post-burn chondritis and were not willing to come in again and again. So this is how the patient looks like. Sorry, this has come again. So we raised a temporoparietal fascial flap, and this is pre and post. This is after 6 months after the reconstruction. Another same patient after 9 months. And now this is after 3 years. You can see this takes lot of time for the contours to come again. This is after another 1 year. This is after 4 years. So this is pre and this is post after 4 years. So I would always say if you raised a temporoparietal facial flap, it takes at least 1 year to show the result. This is after 3 years, and I would just mention it looks like an ear, but the color match is bad. The color is very dark in spite of the fact the color of the patient otherwise also dark, but this is more darker as compared to the other areas of the skin. So the contours are good, it is mash, but the color is always a problem with the temporoparietal facial flap. Therefore, the first choice always has to be the local skin for the reconstruction. There was another patient where again we use a temporoparietal facial flap. So once you've raised it and covered with a lot of ointment, then Vaseline gauze and then contour dressing, and this is how, but sometimes you can have a good color match also. So it depends upon there is a variation. So this is how the patient looks like. This is after 1 year and comparing with the normal year. So it's a good reconstruction with a good color match. Now this is another patient, post-burn, raised a random flap, turned it down, covered with the graft. This is how the patient looks. The color is not good. Then we thought of reconstructing the lobule so that she can have earrings. It's a bad scar in the neck. But this is how a lobule has been reconstructed after the reconstruction with temporoparietal facial flap. Now another use of temporoparietal facial flap would be when the patient at all is not willing for the costal cartilage, especially in the bilateral, because the number of stages would increase. So we use a med-pore flap for these patients. So this is how the patient looks like with med-pore. Med-pore is a radiant material, as you understand. It gets incorporated into the tissues and therefore does not. The only problem, it is very hard. It is very, very hard, and they always complain of hardness of the material, and there are chances of exposure in due course of time. This is on one side, this is the other side. So both ears reconstructed with the temporoparietal facial flap and split skin graft. This is how the patient looks like. This is another patient where the med-pore reconstruction was done with the temporoparietal facial flap. Now another use of temporoparietal facial flap, once it has been reconstructed, you raise in the second stage, put a cartilage and then cover the cartilage with the temporoparietal facial flap in the second stage. This is how it looks like after it has been covered by the temporoparietal facial flap and then covered by a thick split graft. This is the second stage where you use a temporoparietal facial flap. Now this can be used in other areas also. It's a very versatile flap. As you can see over here, there's a loss of lateral eyebrow. So what we have done, we have taken a very thin strip of hair-bearing skin with a wide temporoparietal facial flap. You need to have a wide temporoparietal facial flap because the artery and vein are a little apart. So you have to take artery and the vein. So you have taken a little wider temporoparietal facial flap, but the island of the skin is very thin. So the vessels, you can see, this is the island of the skin and the vessels are going over there. And this is how the patient looks like. We've taken a very, very thin island of the skin to reconstruct the eyebrow with the temporoparietal facial flap. This is, then we've done some Z to, now this is another patient where the eyebrow is lost, there is a ectropion. Now you can see the exposed bone also. So it was very difficult to, I couldn't find, like, you can raise whole of the skin, giving incision here, rotate it down. So we thought of reconstructing with the temporoparietal facial flap. Again, we have taken a large flap with the island of the skin. So the fascia will cover the bony portion also, and whole of the area has been grafted. So you can see the strip of the skin, hair-bearing skin. So this is how this looks like. That has been closed, and this is how the patient looks like. Little higher, but the other things have been covered with the temporoparietal facial flap. Now the problem with the temporoparietal facial flap is the color match. It is very dark, and then what we have done, we have asked patient to apply melalite, which is hydroquinone, and then a combination with the steroid. So it started like, can you see in between the color has changed, and you can see the extent of the color change. Now it changed to the extent that I can see the little thinning of the cartilage over here. See, he continued for 1 year, he did not come, and what we can see, impending exposure of the cartilage. Then they asked him to stop it, and once he stopped it, again back to square one. the color is changed again. So there'll always be a problem with the color match. Like this patient, temporoparietal facial flap, the color is not good. Sometimes the color is very, very nice. This patient, as you can see over here, she was one time operated by somebody's putting tissue expander, you can see incision here, and it fails, and we have done reconstruction with the costal cartilage and the temporoparietal facial flap, and see the color match. So it is extremely difficult to predict the color match. This is how initially then it changed, and we did not do anything for this. Now another problem would be, now if you are not careful, can you see over here the alopecia, especially at the site of the incision. So when you are raising, initially you are little careful to raise the flap little superficial because you are worried about the artery in the vein deep to it. So initially you are actually injuring the hair follicles, and therefore if you happen to do like this, then you excise this portion right at the start, because once you've taken out the fascia, it can be easily closed. So that portion needs to be excised, saving the hair follicles so that you don't have the result like this, where you have the alopecia at the margin. You can see the closer view of the same patient. Inadequate. Now this is another patient where we had a very low lying ear. So we have to actually raise this lobule up in the first stage. So we give in a incision all around or sort of islanded based on the auricular artery. So can you see this much flap has been, the vestige has gone up because there was an external artery meatus. So we do not want to excise the meatus. So it was moved up, and then second stage we raised the temporoparietal facial flap, covered it. So if you are not careful, this is another problem. You can see, because if you have not raised completely separated entirely, the fascia is pulling the cartilage entirely, and you can see the direction of the ear. So the fascia is fine, it is covering the thing. It is, you can have the grooves, you're covered by the split skin graft, but the direction of the ear is not right, and it is not possible to correct it later on. It's extremely difficult. It is, I don't think it will be possible to correct it later on. So the side, size and direction has to be right in the first stage, otherwise it becomes very, very difficult. Similarly, another patient, we've reconstructed this with the temporoparietal facial flap. Nice contours, smaller ear. Now as compared to the other side, probably is not there, it's a very small ear. So the size, the direction, everything is extremely important. Direction is very important, the size is important, the elevation, everything, every detail is important when you are reconstructing the ear. So this was like in the, I believe this was in the Navicon, we have done this patient. This is how the patient was during the operation, during the stage. So once you put in the graft, you put a lot of ointment and then cover it with the contour dressing with the acryflavine wool or betadine with the wool, whatever you feel like. So this was another patient where we use a temporoparietal facial flap. This is 10 days after the operation. This is the elevation after 1 year. And this is how the patient has sent the photograph to me. He's a very happy man. Same height, everything looks fine, except a little bit of a color change. Thank you very much.
Any questions from the audience? Yeah. Give the mic, please. Mic.
You know what happens if you have not cut, you have not given the incision right up to the root of the ear, it will always be pulling entirely because there is a leverage over here. So you have to go right deep up to here so that there is no pull over the fascia. Otherwise the fascia is pulling the cartilage entirely, the direction would be wrong. So you have to go right up to the ear so that the fascia release completely.
So we have to go right up to the root of the helix.
Right up to the root of the helix.
Well, I think the key point is to be a good plastic surgeon, you should know the planning in reverse.
Absolutely.
For designing this flap. So there is no margin where you can manage with it, giving a traction and pulling it.
Sir, I always tell, see, if you are able to feel the superficial temporal artery, then it's a good artery. to rely upon. If you are not able to feel the artery, but if you are able to auscultate with the Doppler, it's not a good artery. So if you are able to feel it, then only go for the temporoparietal facial flap, because there will always be chance of marginal necrosis or disproportionate necrosis or impact. So if the artery is good, then only you should go for the superficial temporoparietal facial flap, otherwise you should not.
Sir, as you said, if you take excess flap, it will be bulkier, and if you take less, it will fall short. So how preoperatively we can exactly?
See, you measure the length and the width of the cartilage. So it should be around 2 centimeter beyond that on either side. And as Dr. Parag has rightly mentioned, if you think of to go little beyond that. And if you find it is still larger, then you can trim it off. Taking care, because always the artery is at the margin anteriorly, because the limit is almost close to the artery. So when you have to trim posteriorly, because the vein would be little anteriorly. When you are trimming, it is very difficult, because then it contracts and vein and artery are very close to the margin. But then you can always trim it if it is a larger flap. If it is a smaller flap, then you're in fix what to do.
Thank you, sir.
Any more questions? I think the whole trick what I find here from your presentation, that the vein is the main key point. Most likely its anatomical position is such, you are likely to damage as a young surgeon.
Right. Absolutely.
So that is the most important part what I meant out. And second point was the how much will be the dimension has to be properly planned before you undertake taking the temporoparietal flap.
I always advise you should have a feel that you are in the right plane when you are injecting. So just have a feeling that you are just deep to the subcutaneous tissue or inject, and then through that injection go on injecting, so that you don't injure the vein or the artery while injecting. While injecting also you can injure.
Doctor.
Yeah, that's one thing I just got it with the eyebrow, when you reconstructed the eyebrow. I've done it, but I done it with a narrower flap then, but somehow it survived. It's this thing. So
now you can do it with the narrow flap, provided the artery and vein are closer to each other.
yeah, that's true.
So
Probably,
if they are wide
lucky,
apart, then you have to take a larger flap.
Larger flap, that's true.
Wider flap, because then you have to include both the artery and the vein.
Yeah, if it's a venous drainage is not there, you need to have a broader
Absolutely.
pedicure.
It has to be artery and vein has to be there in the flap.
So your experience with the Medport, does he stock it, and what the process goes on after putting of the temporoparietal flap over the Medport? In fact,
What I've seen, like when you're using costal cartilage, initially the contours are good, then they will go away because of the edema, post-op edema, and then it will come gradually in 6 months to 9 months in 1 year of time. In Medport, there is no edema afterwards. It gets stuck. And the result is always like that. So that is what I find in Medport, because it's a porous thing, they grow into it. So get stuck to the Medport, and the result which we have seen will remain throughout. That is the difference with the Medport.
anyone has any question? Devesh, you would like to ask?
So many times we get traumatic ear amputation cases in hospitals. So what is your experience on using that graft of that amputated part?
I believe in the textbook also, the people, one of the treatment which is written is temporoparietal facial flap. It should never be used, because the cartilage, the ear cartilage will not able to withstand the force of contraction of the graft which you are going to put in over the graft. So if you cover the cartilage which is exposed with the temporoparietal facial flap and put a graft, it will contract and it will get deformed in due course of time. So it should never be used, because it's a lifeline for the ear reconstruction. What if you are a good microvascular surgeon, we have the tiny vessels which can be reimplanted, then it should be tried. Or else what I advise, that you denude the posteromedial surface of the skin throughout, so the cartilage is bare. Then make multiple holes in the cartilage, and attach it with the rest of the ear, and then make a raw area posteriorly, so that whole of the ear with the raw area with the fenestration is attached to the in the post-auricular region. so that their chances as a composite graft they increase. This is one. Or second, what you can do, you can dermabrate the cartilage throughout, all around, and bury it in the post-articulation. So it might survive later on, it can be raised and can be sutured to the rest of the portion. It should never be covered with the temporoparietal fissure.
Thank you, sir.
Can I go ahead with the closure of this session?
He wants to ask some question.
Yeah, please.
Regarding your question, we had done a case similarly.
Yeah.
So we had created a retroauricular pocket in a human ear bite, and we replanted after 24 hours in a diabetic male. But as sir said, we had fenestrated the cartilage and created a retroauricular pocket, covered it, and after 5 to 6 weeks, we had raised the flap posteriorly again, and then turned it upon itself. And the cartilage has survived so far 1.5 years of follow-up, and it has been extensively good.
Actually, long follow-up is required in this type of cases. As I was telling that may be chances of deformed of the cartilage.
What is your experience with the Chinese surgeons making the autocartilage frame and putting it to the different part of the body? And
So I don't have any experience like making the cartilage and putting somewhere else and then raising later on, or like the amputated portion, it gets deformed, sir.
Okay.
I have done in 2 cases. It gets deformed. When I was in MAMC, I have done in 2 cases. It always gets deformed and can never be used. And because that cartilage, when you're putting in the post-auricular pocket, that contours which comes with the costal cartilage, because it's a hard thing, it will never come. And the skin, as you understand, is very thin, very, very thin over the normal ear. And the skin which you raise cannot be that thin. So it never works.
Thank you very much for a very lucid presentation. I think most of us are gained from your vast experience of so many decades working on this difficult reconstructive procedure, I think, in plastic surgery. Thank you very much, sir.
Thank you.
Hello?
Yes, sir.
Am I audible?
Yes, sir, you are audible.
So finally, I think we are lucky we are able to make the helix with that thing.
Yes, sir.
So helix and anti-helix are complete now.
Right, sir.
And we are just creating a third layer, the conchal graft. Come like this.
Right, sir.
And then we will fix it. So this is this we are creating the third layer, which is the conchal graft, and we have cut out. It will just go behind the triangular fossa, not behind the triangular fossa. It just goes behind this region. I'll just show you. So this Simba concha. So it's a conchal piece. We have taken out this piece. It will come like this behind. Okay. So marking.
Mohit sir, do you always create a third layer, or is it only because it's temporoparietal fascia that you're adding this piece?
Always create.
Always?
Always create third layer. Yeah. What are you asking?
This is Dr. Bhandari Mohit. So that means in the second stage there is no need to put a cartilage.
Sir, it's always a 3-layer framework we create.
And then in the second stage?
Second stage we further utilize another piece which we bank. But in this case, because it's a single stage thing now, but we use one more piece of cartilage for further reinforcing it. Even then it contracts back.
Yeah, that is true. But then you are augmenting not in this patient because you have no shortage of fascia, so you can wrap it all around. But in microtia also you always make it 3-layer, and then in the second stage also put cartilage again.
Yes, sir.
Okay.
What I am carving is cavam concha.
Yeah.
And this one is the Simba concha.
So Mohit, once you have sutured this to the basal framework, you'll put a cartilage again for elevation?
There won't be anything. It will be the end stage.
Yeah, so then it is different for microtia and this, because if you believe this will give the elevation, then why cartilage again in the second stage in case of microtia?
Sir, even then when we elevate, some more strength is required. Otherwise, even what we are seeing, sir, even after putting that cartilage another time, then also it contracts back.
True, totally agree with you.
Yeah. Root of helix. When we put this also has to go down. Then only it fits here. Otherwise it becomes very awkward to fit. So there has to be some depression here also. This also finally goes to accommodate.
सब बोलते हैं कि हम बड़े दिखाते हैं सब पहला वाला हाथी का दो दांत होता है, बाहर होता है, अंदर होता है, तो बाहर वाला दिखाते हैं, अंदर वाला कोई नहीं दिखाता। तो बाद में भाई आपने इतना बात किया, अच्छा बात किया, आपने क्या किया आपके जिंदगी में क्लास में? कल कहाँ गुजर गया, क्यों बदल गया? I asked all the presidents, in 1 year what you have contributed to that? How many, at least, how many seeds you have planted for at least 3 or 8 years in the future, people will take to it. एक कंफ्रेंस पे सीमेंट मिल कर
का केस संडे मैरिज हो रहा है, इवेंट मैरिज होता है, डेस्टिनेशन मैरिज. Conference is not a destination marriage. A conference, what you are looking for the present and for future, forget the past. मुझे लगते हैं ना, ये क्या होगा, APS में कोई नहीं रहेगा, only president will be there, only उसमें नहीं है. अभी everybody is thinking in a project, what I am going to get from it. If there is no substantial thing, I am taking of Coimbatore last time. Why there was such a big error? Because it is a fiesta of academic life surgery is there. There is a different, completely different mode of presentation of things. Varieties are there. People got interested. Not just one thing. Now young generation is not like us. कि हमको conference जाना ही है, वहाँ बैठना है, बहुत था, नहीं था, एकदम नहीं था. What you say? कम नहीं है. अभी देखिए उसका पहले कॉन्फ्रेंस क्या था? Sir, you see, last year conference आप याद है? आप ये जो किया था ना, तो महाजन जो किया था, उसमें तो पूरा छा गए. APSI is your mother actually. Whatever you may be, उनके जमाने नहीं है हमको. Where I should make commerce, only art science में रहना. हाँ वो तो बोलो. But अभी अब suppose you are joining in cancer institute. Hair transplant you होगा भी, you have to do everything. But again depends on person. Cancer hospital में रहा, बाकी कोई cancer नहीं.
Your framework is looking excellent, Mohit sir. Congratulations. In spite of, am I audible?
So this is the framework.
It's looking excellent.
Third layer is the conchal piece. So it gives the conchal definition. And here we have antihelix. So there is a gap between antihelix, superior crest and the helix, and inferior crest and the helix, so that the skin or TPF can drape. And here we are not creating tragus. So it is just coming. This is slightly weaker here. I think I'll have to put one more white here because the pieces are joined. But there is no trauma of tensile strength of skin. So it should be okay, more or less. More or less okay. Behind it looks like this.
Can you show us the depth of the framework, sir? If you have a scale.
So including 3 layers, it is, I would say, almost 2 centimeters. Almost 2 centimeters, including third layer.
Right, sir.
These 2 layers are around 1.5 centimeters. So as I said, between 15 to 20 millimeter it comes. So it should come like this.
Mohit, excellent reconstruction. Very, very nice.
Sir, abhi to hua nahi hai.
Very nice reconstruction. We're talking about the cartilage carving. Very nice.
The reconstruction is yet to
You have done a wonderful job. Dr. Mohit, Dr. Chaudhary, you have made a wonderful job, in fact. And with the difficulty, all that, the results are quite good. A good surgeon is who takes the challenges.
Still could not take the challenge. Doing something. So this is with the template overlapping.
Mohit sir, can you hear me? Sir, can you explain what you are fixing now currently?
I am myself trying to figure out. I am just taking TDS and then fixing the conchal cartilage
Right, sir.
to the under surface of the skin.
Right, sir.
Just lift it up.
And you'll be inserting drains later on?
Sorry?
Will you be inserting drains later on?
Yeah. Once I fix it to some extent, so it doesn't fall.
Right, sir.
We are also not sure about the position right now, so let us be.
Dr. Mohit,
Lobule.
and you'll cover it with the fascia.
Yeah, framework is like lobule is made of the framework.
Right, sir.
Okay, so this is fixed. Now take a photo, please.
And have you taken a skin graft from the scalp, sir?
Yeah.
Did you use a dermatome or with a Humvee's knife?
Dermatome.
Yeah.
Regarding the inauguration, that's what Dr. Sanjay Giri wants to tell you. It has been a very nice work. Everybody is appreciating excellent framework.
I think a good.
So we'll be with you after the inauguration. Thank you very much for the demonstration. Thank you. We'll be coming again. We'll be coming again.
Fine, sir.
Sir, you come for 10 minutes. Sir, will come.
Participants. It is an honor to welcome you all to this 3-day Knowledge Fest, workshop on techniques for ear reconstruction with hands-on cartilage carving being organized by the Department of Burns and Plastic Surgery, AIIMS Bhubaneswar. Today marks an important milestone in our quest for improved patient care and innovation. We've all gathered here with a shared commitment towards our patients with various auricular deformities. This workshop aims to provide valuable insights into the cutting-edge techniques of ear reconstruction and offer a platform for collaboration and knowledge sharing. I would now like to request Professor Dr. Ashutosh Biswas Sir, Executive Director, AIIMS Bhubaneswar, our chief guest for today, Professor Dr. Dilip Kumar Parida Sir, Medical Superintendent, Lieutenant Colonel Abhijit Sarkar Sir, Deputy Director, Administration, AIIMS Bhubaneswar, our eminent faculties for this workshop, Dr. Parag Telang Sir, Dr. P.S. Bhandari Sir, Dr. Lakshmikant Mishra Sir, President APRASO, and our respected HOD, Dr. Sanjay Giri Sir, to kindly grace the dais. As we find the dawn of wisdom, knowledge, and new beginnings, I now request our distinguished delegates to kindly come forward for lighting of the ceremonial lamp. I would also request Dr. A.K. Chaudhary Sir to kindly come forward for lighting of the lamp. Sir? I would also request Dr. A.K. Chaudhary Sir to kindly come forward for lighting of the lamp, sir. May this ignite a spark and inspire us to innovate, collaborate, and bring hope to all those in need. I now invite our respected HOD, Dr. Sanjay Giri sir, to deliver the welcome address.
Our lovable Bhandari sir, along with Mohit sir, who is doing our workshop in the OT, and all the esteemed delegates who has come from outside, and also faculties, some faculties from outside medical colleges, also online viewers. It's a great honor for Department of Plastic Surgery to organize this workshop on the ears, specifically, which is a very eminent part of our plastic surgery fraternity, and it requires a lot of things to know how to make the ear reconstruction. So this was a plan to have a knowledge regarding this carving and how to do this ear reconstruction, which is a very difficult subject. Of course, in our MCS time, it is also too difficult to know how to do these things. But we are very fortunate to get all the three doyens in this part and in this ear reconstruction of our India. And we hope that in these 3 days, you can get the maximum knowledge about the ear reconstruction, and that will definitely going to help in future for this reconstruction of ears. And also on Sunday we have carving hands-on, and that will also make us whatever we have learned in these 2 days, we can use these things in making the ears. And all the queries, everything, I think can be cleared by our eminent faculties in this 2 years. Thank you, sir, for giving your times. It is not easy to get all of the three at one place. So we have planned it for last 6 months, and after that we got it anyway. Thank you, sir, for coming and enlightening us for this workshop. Thank you, and I hope you will enjoy these 3 days. Of course, today it was a little bit of problem in the first part, and tomorrow also we will have 3 cases, and I hope you will enjoy these 3 days. Thank you.
Thank you, sir, for your words of wisdom. Next, I would like to invite Lieutenant Colonel Abhijit Sarkar, sir, Deputy Director Administration, AIIMS Bhubaneswar, to kindly say a few words.
Firstly, a warm good evening to everyone. Honorable dignitaries on the dais, Professor Dr. Ashutosh Biswas, Executive Director and Chief Executive Officer, the other dignitaries on the dais, Dr. P.S. Bhandari, Dr. Mohit Sharma, and the organizing chairman, Dr. Sanjay Kumar Giri, the present eminent and honorable faculties, as well as dignitaries. Firstly, I welcome you all to this workshop on hands-on cartilage carving on ear reconstruction surgery. It basically also re-emphasizes on the sharpening of your skills as well as your innovation process in further taking reconstructive surgery into further impediments of success and progress. I thank you all once again. Thank you.
We are honored today to have amongst us faculties of national eminence. Dr. P.S. Bhandari, sir, a stalwart in the field of plastic and reconstructive surgery, is widely recognized for his varied contributions to the field. He is currently a senior consultant in the Department of Plastic Surgery at Max Super Speciality Hospital, Saket in New Delhi. Sir was formerly the consultant plastic surgeon, professor and head Department of Burns, Plastic, Maxillofacial and Microvascular Surgery at Loknayak Hospital, associated with Maulana Azad Medical College. Sir has also held eminent positions such as the ex-president of National Academy of Burns India, ex-president of the Delhi chapter of Association of Plastic Surgeons of India, and the ex-secretary of the Delhi chapter of Association of Plastic Surgeons of India. It is my proud privilege to welcome Dr. P.S. Bhandari, sir, to address the gathering today.
Good afternoon, ladies and gentlemen, honorable dignitaries on the dais, dear friends. It actually gives me immense proud to be present over here with the August gathering over here in this part of our country, and a unique ear reconstruction workshop where you are in part getting the feel of costal cartilage carving also. I've just landed today and I've seen the facilities and everything seems to be very, very nice. The operation which I've seen right now just reached. Dr. Parag Telang was finishing, Dr. Mohit was still on. So I believe you'll get all spectrum of ear reconstruction and at the same time hands of cartilage carving. So it's a very, very nice opportunity and very nice facilities over here. And it's very kind of your, sir, you've been the inspiration to the young plastic surgery department who have organized this workshop. It's a unique of its kind where you can have the hands of cartilage also. So I wish all the success to the workshop and the conference, and thank you very much for inviting me.
Dr. Parag Telang sir is a name we all recognize and look up to. Sir is currently the founder director of Designer Bodies Center for Advanced Cosmetic Surgery at Mumbai. A surgeon par excellence, sir is specifically interested in facial aesthetic surgery, breast and body contouring surgeries, and autologous ear reconstruction. Please put your hands together and welcome Dr. Parag Telang sir.
Honorable dignitaries, I would like to thank Dr. Sanjay Giri sir for postponing the program for me, because it was initially I think planned in the month of December and I could not come at that point of time, and sir was kind enough to reshuffle the dates. When we look at ear reconstruction I feel is a very complex art, and for us to learn that art we need to learn a lot from our teachers, and the 3-day workshop is basically designed in such a way that whatever we have learned from our teachers we should be able to pass on to the younger generation of plastic surgeons. So I feel even if 7 or 10 out of you go on to train in the art of ear reconstruction, the whole idea behind this workshop would be successful. I encourage you all to actively participate in this workshop, ask us questions, get your doubts solved, and walk away from this workshop as better plastic surgeons. Thank you.
Thank you, sir, for your wonderful insights today. I now request Professor Dr. Ashutosh Biswas, sir, Honorable Executive Director, AIIMS Bhubaneswar, to kindly grace the dais.
All the dignitaries present here, the national and global expert in plastic surgery, Dr. P.S. Bhandari and Dr. Mohit Sharma, Dr. Parag Telang, and the others, Dr. Ruchi Gupta, who is the president of APR ASO, and all the participants taking part from the different institutions. And I would like to thank also Dr. Giri and his team, the Department of Burn and Plastic Surgery, for organizing this kind of wonderful workshop, reconstruction of the ear. This reconstruction of the ear, and as you know, the ear is formed by cartilage, and you are looking for the cartilage to remodel it, carving it, and then you are putting them in a place which is similar to the normal ear, looks all the design so naturally the God has made a technology. We are trying to, so getting the floating ribs, cartilage, and putting them in the ear from the abdomen, and then it's really a very Herculean job. And here technology putting knowledge for curbing, making similar to the normal AR is really commendable job. All the expert members sitting here, and they have innovated this kind of technology, and the cartilage carving and hand carving and long standing with the surgery, and it's a very important organ of the body, ear. And for hearing, not only that, it enhances the hearing process by the external ear, and it also the part of the beauty of the men and women, the beauty of your gold rings and all, looking beauty, especially for the women. So it's very important, and we are getting a lot of the cases are very huge, the burn and the trauma. You are losing the ear and several organ, and this kind of technology, I think, if through this workshop, if the surgeons they get this skill from the global expert, national expert sitting here, so it would be very useful for the younger generations and the surgeons, those who are interested to know. And I just watching a few minutes. Dr. Rohit was is performing, I think, for a long time. Dr. Telang has already performed. So it's really the field, and then putting a flap and then arranging and going into making a shape looks like ear, the ear of the normal, and then putting them into the proper place. It really requires a very innovative approach, and then innovation for the surgical. It's really art of surgery. You need to learn the art. So here, through this workshop, I think the people, those who are attending on physically as well as on virtual mode, would be very much beneficial to know this. But unless you go for, by watching, you may not learn the surgery. By watching, you may not be a football player. You have to go to field and kick the ball, then only you'll be a player. So by this is just an induction to the first process, and thereby you can imbibe and go to field for practicing it. Gradually you'll be the expert in this field. So thank you very much, and I wish you all the best, all the participants, for showing the interest and coming here and learning this very high-skilled kind of innovative kind of the surgery, carving the cartilage and putting them in a place, reconstruction of the ear. And I would like to thank the department, the burn plastic department of our Institute AIIMS Bhubaneswar, for organizing, especially the Dr. Giri and his team working hard for this workshop. Thank you very much. Thank you all.
For your words of wisdom, sir, and always guiding us in the right direction. I now request, sir, to felicitate our esteemed faculties with a token of our appreciation and respect. I kindly request Director, sir, to felicitate Dr. P.S. Bhandari, sir. Can we have a big round of applause, please? I would now request, sir, to kindly felicitate Dr. Parag Telang, sir. Please give a big round of applause. I would now request our respected HOD sir to please felicitate Director sir. Yes, sir. We'll do it later. I would felicitate Deputy Director Administration sir. Please give a big round of applause. I would kindly request sir to please felicitate We would like to express our gratitude with a token of our appreciation to Dr. Arun Kumar Chaudhary sir, former professor in HOD, SCB Medical College, Cuttack. Thank you for gracing the occasion today, sir. Bharati sir, Senior Consultant, Ganga Hospital, Coimbatore. Please give a big round of applause. We also have amongst us today Dr. Deepthi Gupta ma'am, Associate Professor, Department of Plastic Surgery, Vardhaman Mahavir Medical College and Safdarjung Hospital. Thank you ma'am for gracing us with your presence today. We would also like to thank Dr. Vishwadeep sir, Assistant Professor, Department of Plastic Surgery, AIIMS Patna. So we are honored to have you amongst us today. As we come to the end of the first day, it is both an honor and a privilege to stand before you to express our gratitude for everyone's contribution to this workshop. I would now like to invite Dr. Ranjit Kumar Sahu sir, Additional Professor, Department of Burns and Plastic Surgery, AIIMS Bhubaneswar, to kindly deliver the vote of thanks.
Respected Director sir, DDA, Parag sir, Bhandari sir, and Dr. Giri, it is a very difficult thing. This is small parts of the body to mastery in the small parts. It's really difficult. So we have planned in the department last 6 months, and we are in the busyness of this. Now it is a successful event with the grace of with the kind permission from our director sir and all faculties from the national faculties. So I hope everybody's presence here is the success, and attending from outside Odisha, it's a grand success. Now this event is also online. So all my staffs, it's a great pleasure. My thanks to my all staffs, the department, also audiovisual systems, all my paramedical staff, sisters, nursing
It's a great pleasure. Thanks everybody for your presence and support. Thank you everybody.
We come to the end of today's ceremony. Thank you so much for gracing us with your presence. I would like to
Yeah, you're not.
I'm putting suction on this.
All right. So can you ask the cameraman to focus over the temporoparietal facial flap where you are putting the suction? Oh, very nice. Very, very nice. Good. So what suction you are putting in? This is a Venflon. Hello. This is Venflon he's putting on. Okay. All right. Yeah, yeah. And this will now be attached to a syringe?
Yeah.
Okay.
Great job, Mohit sir. Congratulations. It's looking very nice. Everybody is applauding you for your patience and perseverance. Your resilience was much more than the cartilage, ultimately. Sir, can you guide us about your post-operative protocol for the dressing? How long do you keep the drains? When do you change the dressing?
No dressing. Just keep it open. We'll put a graft and maybe even some ointment and Gelonate and Venflon for few days, maybe 5 days.
So this is only because it is temporal fascia that you are keeping it open, or even for microtia cases, you don't
keep it open.
You don't apply any dressing.
Always.
Okay.
Mohit sir, I have a question. Hello. Hello. Sir, the question is regarding the wind flow. So, has it been shortened or it has been kept, length has been kept intact while inserting it into the flap?
It is between, it's in the scaphoid fossa.
Okay, but sir, has it been shortened or the length has been kept intact?
It is working, just I'll show you. Give me syringe. 20 cc syringe. 20 cc syringe and 5 cc plunger. Your lock wali nahi hai? Okay. So see, that way.
We have the microphone on the way of our camera. Oh.
The camera, your hand is missing.
Sir, how much negative do you get with? I think it is 10 ml, sir.
What?
Sir, 10 ml, sir. So
10
you,
ml.
so you create full negative section with this, or sir, till how much mark do you keep it?
It is just, we'll just, in bit, what we do, we suck it.
Yes, sir.
After sucking it, we discard, we just block this thing, take the syringe off, discard the blood.
Yes, sir.
Again attach it, and release it. So we don't want to keep too much suction.
So how much should it be like 4 centimeter, 4 mark or 5 mark? How much it should be?
It is just like that, so that we don't want too much of pressure on the skin. Now this is TPF.
Yes, sir.
I cannot, there is no particular guideline or this thing about it.
So how do we know that we have created a lot of pressure and it is going to impact the temporal fascia when we are creating this negative?
In the skin, it blanches foot graft.
And so in this fascia side it is already bright red color. So
Yeah. So we won't suck too much. There is no, as such, no big guideline. What
Thanks.
we will do, we will just put the graft, and we will not put too much pressure at all. We'll just leave it like this, let it settle. Our aim is not to develop, don't allow any hematoma to develop.
चौड़ा कौन सा है?
Yeah, just rub it. Put it on a sheet and rub. Yeah, वहाँ जाके बता देंगे. एक second. Just let me see.
Dr. Mohit, did you have any advantage of taking 2 sheets of skin graft?
Advantage?
Of having 2 sheets of skin graft?
No advantage. Out of fear, we have taken. It should not fall short.
I like you very much because you tell the truth and not only the reality.
मैं तो हमेशा लगाता हूँ। आपको अभी गुड आइडिया, हमने तो उसमें भी आंटी में भी तो लगाया था पैर के अंदर। उस लेडी
लगाया था, कान पे कब लगाते हैं?
लगाया।
Dr. Mohit? Dr. Mohit? Can you hear us?
Yes.
So, on behalf of all the audience and the senior members of Plastic Surgeon Association of Orissa and India as well, so we congratulate for your marvelous work. And I think you are the second Dharmapat in Orissa, because in Konark, no? So it is almost a better architecture like Konark, if you have seen Konark, the sun temple. Yeah. So you are no way less than the carving you have made for the catalyst, with the challenges already you have seen, no? So Professor Bhandari, Professor Dr. Parag and Dr. Giri and all that, they have been very much impressed with all our junior guests here from different places of the country and also from the state also. So I think they all agree that we have learnt a lot from your demonstration of the live operative surgery and live streaming all over the country also, maybe abroad also. So in a difficult situations, I think the whole thing you are showing is almost possible in every place of the country. And the custom-made designs of suction and all that you are showing is something special. It don't needs lot of cost to have it. So that is one of the innovations you have made out in this particular surgery.
This was told to be by Dr. Farmin.
Yeah, so you are now better than Farmin, because you have made it possible in Orissa and India also, no?
Lot of good people are there.
Yeah. So thank you very much from our side. And anything Dr. Bhandari to speak?
Mohit, full marks.
Thank you, sir.
And one, maybe more than 10, one for the writing. Extremely good result. Very nice.
So we are not generating much pressure, sir.
Yeah.
We just want it to heal, and it will automatically drape nicely if it survives.
It will definitely survive. I'm only worried about the post-operative care of the patient. No dressing. How will the patient carry the things?
Yeah, we just we applied histacrylate around 50 grams, 60 grams. So patient cannot turn on the right side, and I think it is a lot of things for us better. And we have a brain which we have a splint which we have developed. We take Foley's catheter.
Okay.
And make a ring.
All right. So you're giving some protection around the cartilage and graft.
Yeah, we can put that on Amazon. There is a cup available. You can put that, or maybe make some, or maybe you cut a sponge and then put a sponge all around.
Okay. But you don't want to give any pressure, no dressing.
No pressure, no dressing.
Okay. No sort of cage, sort of thing. Yeah, sort of thing, protecting the dressing.
And I'm not, right now, not cutting it too much because I want the hand. We just want it to just settle. It will all shrink and go into the crevices, and it will just break the framework very nicely.
Yes.
So we don't want to put too much suction now to create a control, because once it settles, suction is only to avoid any hematoma. Once it settles, we will just remove it.
Okay. So
And
on.
this suction we will only use to cut intermittently, mildly in between. So little bit of suction for 2-3 ml, and then we will stop it.
So how frequently it needs to be sucked out?
Maybe every 8 hours.
Every 8 hours. All right.
Fine, sir. Thank you.
Thank you. Thank you very much.
Mohit. Probably busy.
Yeah, sir, you were saying something?
Yeah, no problem. That's That's quite a good perseverance and a real good demonstration on a rigid cartilage. The flexible cartilage is for the boys and the rigid cartilage is for the men, I think. Right, that's nice. Very nice result. Good.
Do you want to add some comment?
On the scalp side, we will just Caltrostat, put Caltrostat and then just leave it with some sort of.
Mohit sir, you will not put any suction additionally for the scalp?
Suction is there, sir.
Okay.
What we can do? How do we put pressure on it?
Sir, we have a doubt. When do you usually remove the drain, sir? In this case, what is your opinion on like how long do you keep the drain in situ?
When something stops, when it stops coming into the syringe,
Right, sir.
you can remove it. Maybe 3-4 days.
Okay.
Not more than that.
And when do you discharge this patient, sir?
We keep at least for a week.
Okay. And then we'll ask them for a weekly follow-up.
But at least a week of care, I would say 10 days of care.
Right, sir.
Till the graft nicely.
Right.
Suction doing. हम करते हैं इसे ना गॉज रखो गॉज रखो right. tape, I can just put it here. यहाँ पे टेंशन लगा दो।
Whatever you have taken, we will give for benefit all the young people. And we should amazed so many big people of the country, not small people. We make a live operating program. I told you only one place in India that is I know, and I feel proud of my students who took lecturing difficult things. These are all challenges. Make addition to the country, have so many people in my village who want to yeah, no, that is there on the
First you have to motivate not patient. First you have to motivate the director of the resident. And there is not one to five people will be there. Whether two will be doing whatever minor department for yourself, a lot of things are there. But to manage that, we have to take burden. I know how much is now head of this course and all that. That is the advantage. It has a lot of time, energy, lots of. I was talking with the research students in the last time. There is no time for house. We all time, energy, money, everything is spending on it. So it's not that easy when it's on. I know because I was doing life education. Another me, I'm proud of it. But it's not that. Manage the finance part. Just like you to bring down here and do all on the same day on you. You are my male person because we are so that has more confidence and so I think people should really the good classes taken that they good architect, good organization and public organization by men. And these are things to get this thing if you go to France and with so it comes your how much money to get a visa? I think Paris I know. Very costly and it is not possible. They don't allow anything, sir. They don't allow to do it. So that is the thing today world is you can't get it. Now everything is getting and the registration is moving. So really advantage you have taken all this. I really you are really my minister told you are getting into investor. Even sir, I am minister of that. Can you tell me any work today no work you can do free of cost? And a doctor you are telling to be very free of cost. But anything can you do without money? Background business, you want to learn from Gujarati business and you know unless you are a Gujarati businessman, in your profession also it is very difficult.
ଗ୍ରୀନ୍
ହ୍ୟାଲୋ
ରହିବ ସାର୍।
ହ୍ୟାଲୋ
ଭାଇ ମାନେ ଟିକେ ଦେଖିଦେବା ଏପଟୁ କାହିଁ ଆସୁନି। ସନ୍ତୋଷ ଭାଇ ଦେଖିଲେ?
ହ୍ୟାଲୋ ହ୍ୟାଲୋ ଟେଷ୍ଟିଂ ହ୍ୟାଲୋ
ୟେସ୍ ଓକେ। Girija from OT3.
Satya audible?
Yes, yes.
Everybody to our live operative reconstruction ear reconstruction workshop today. We are honored to have such distinguished faculties amongst us. I welcome Dr. Parag Telang from Mumbai and Dr. Mohit Sharma from Delhi. Please give a big round of applause to them. Thank you, sir, for making so much time for us and being here. I also welcome all our delegates and thank you for being here. I promise this is going to be a very lucrative workshop for all of you. As is the tradition, let's start proceedings with a lamp lighting. I invite our esteemed dignitaries, Dr. Mohit Sharma and Dr. Parag Telang, and our President, Sir from APRA, so Dr. Lakshmikant Mishra, Sir, and President-elect Dr. Ruchi Gupta, Ma'am, Dr. Arun Chaudhary, and Dr. Sanjay Kumar Giri, to enter the dais to light the lamp and inaugurate the workshop. Sir, it will be a great honor if you could say a few words before we start the ceremony. Later. Okay, sir. So for today we have two cases for the live operative workshop. I'll begin with the first case which is going to be operated by Dr. Mohit Sharma by the Nagata technique. It's a case of left-sided congenital microtia And the video here will demonstrate both the history of the patient as well as the examination and the planning proceedings. Please play. So she's a child of 8-year-old female.
1 minute. Started?
Start. So this is a patient, 8-year-old female with the right ear microtia, no other ear complaints. Antenatal history was normal. Birth history, she was a term child, normal vaginal delivery with no postnatal complications. Family history is also normal. Child was immunized as per age. Developmental milestones also achieved as per age. Right now she is presented with right grade 3 microtia and facial nerve is normal. She has a history of right side moderately severe to severe hearing loss. Left side hearing is normal.
Okay, so this is an 8-year-old child. So normally when we operate on these children, we need chest circumference, minimum chest circumference and Ziphi sternum of 60 centimeter. Her chest circumference is 58 centimeter approximately, and that is not the most ideal situation to operate these children because the volume of costal cartilage is not adequate. But here now she has a chance to get the procedure done in this workshop, so we are just giving her the benefit of the surgery. And this is a typical lobule type microtia. So when we take a template on a transparency and just measure the size of the ear. So this ear is almost 56 millimeter long. So we'll take a 52 millimeter template. 4 millimeter will come from the thickness of the skin, and that template we just apply here, and we split the lobule after marking the position. The general parameter is we take the index finger of the child and at least one index finger behind the sideburn should be the root of the helix. So we just see the orientation of the auricle, we see the axis of the auricle, and also we see the position of the lobule. It is more or less similar in this child. So along with that, we also measure the distance from the lateral canthus to the root of helix and angle of mouth to the lobule, and then try to match it on both the sides. The face is not too much contracted on this side, so we'll just keep it, we'll keep the position one finger breadth, one index finger breadth behind the sideburn, and we'll harvest 6, 7, 8, 9 costal cartilages extrapericordially and create a framework, put the framework in a subcutaneous pocket here and transfer the lobule primarily and use the Nagata technique to reconstruct the auricle. Thank you.
So our second case is Master Mrigank Das. He's 11-year-old male with left-sided microtia with external auditory canal atresia. His family history and antenatal and postnatal history was normal. On examination, he has a left grade 3 microtia and there is no associated facial palsy. And on CT scan, patient has left external auditory canal atresia with deformed pinna and left ossicular chain deformed and fused. This case will be operated by Dr. Parag Telang by the Foreman technique.
माइक को बंद कर दीजिए।
Ear reconstruction is definitely, it is demanding. Taking out cartilage, carving it to the shape and putting it in the pocket, getting the accurate size and shape, it demands a lot of effort and technicality also.
I think he being a junior also, I think he has really conceived the most difficult operation in plastic surgery reconstruction is the ear reconstruction. I think universally majority will agree for it. Because you have to do a lot of, it is not the form, not about the function we are interested much, but to get exactly like the other ear if it is there, not the bilateral ones. It's very difficult to really mimic the other side. So there has not been many people except Brand, Nagata and single stage by Fisher. Many people have been in the literature. What do you say? Do you agree with this? Thank you.
Speaking, every step is demanding, right? From the harvest of cartilage and carving the different parts, putting them together, creating a pocket. Everything has to be done in correct, perfect state so that we can get a good result. In spite of that, sometimes after elevation, all those things, maybe the thickness of the skin of Indians is a bit thicker, so the results may not be very optimal. But we keep trying to achieve perfection, which still eludes us. So that's the reason for these workshops, and we learn one or two good steps from the experts.
Yeah, it's quite difficult to get the symmetry, and achieving it is a good thing. And here, definitely, it's a very cosmetically important part of the face, and especially for the females, all the more. So, and it is a difficult surgery.
Ear reconstruction is really a challenging surgery, as it's not a common surgery. And I think the incidence wise, 1 in 10,000 cases we are getting, and in my series also I have seen around 6 to 7 cases since last 10-12 years in my experience. I think carving this cartilage is challenging part. Getting a good result is also a challenging. So I think it will be helpful for all the juniors, and also for us also. It's definitely the experts are there. It will be helpful throughout the day.
What is your feedback on the ear reconstruction in your experience?
Good morning, everyone. So I was fortunate to be trained under Dr. P.S. Bhandari, who is a legend in ear reconstruction. So basically there are certain things which are very important. The age of the patient, and second is the main is the cartilage. So cartilage carving because ear is a very complex structure and with a rich vascular supply. So we have to give a best 3D reconstruction of the cartilage. And there are many challenges like less skin, or sometimes in post-bone reconstruction there will be vascular supply. So we have to adopt many techniques to give a very good reconstruction in ear. So I think this conference would be a boon to all the MC students, also all the so that they will have an idea about the various techniques of ear reconstruction and how to give a very good result. Thank you.
Anybody want to share his experience or our experience? What are the different methods for reconstruction of pinna? Yeah. So this is a teaching, training and learning also. So not that there is nothing called junior, senior. We are all seniors because everybody has passed our postgraduates. We have gone to the MCS level. So I don't think anybody is a student or a teacher here. We are all sharing each other. Okay? Please.
So I am also fortunate to be trained under Dr. P.S. Bhandari sir, and Jayant Boss is my senior in that institute. So we have learned about two techniques, Formin and Nagata, and we also consider what Bhandari said, that it is combination of both. So we say it's our teacher's technique, because in one technique you are taking cartilage from the other side and putting it under the ear. Sir combines a little bit of both. So we are fortunate to learn both the techniques in the same roof. And definitely there are other techniques also, like in recent literature, a Chinese surgeon, he has done a new innovative thing. Instead of doing the second stage after some months, he has done a delay at the first stage, in which the occipital fascia, which is postauricular fascia, it is incised, and along with the skin, it is left for 7 days for delay to occur. Then he inserts the cartilage framework under the skin. It is basically between the skin and the fascia, and then it is elevated at the same time. So it saves the time, and it also gives a good result.
Thank you very much.
Sir and ma'am, all the delegates, breakfast and tea is served in the opposite room. Please, we'll have a short 10 minutes break and then we'll start with the OT.
Anybody likes to have breakfast, you can go.
Yes, sir, yes, sir. As you wish.
I think most are not fast. We have already broken our fast. Anyway, so I think Brent and Nagata both are, and Fisher is the person who did the one-stage operation. And rightly told, Chinese has also made it that you can implant in one place the cartilage and take off. So, how are you?